Okay, so as I said, it's very important to put this is the essence and the most important knowledge and information you should be aware of for the clinical neurological examination. You should get all the information in one equation. So, for example, if you have motor, you ask yourself, is it upper or lower or mixed? There is upper motor neuron lesion in the form of hypertonia, hyperreflexia, upgoing plantars, positive clonus, and the pyramidal shape distribution of weakness. Coordination is intact and sensations are intact in the four modalities. So here you got the diagnosis. This is motor neuron disease and only upper motor neuron disease. This is what is called, anybody knows?
PLS.
Yes. Thank you very much, doctor. Primary lateral sclerosis. It's different than ALS. ALS is amyotrophic lateral sclerosis. Primary lateral sclerosis, it's only upper motor neuron disease with intact coordination and intact sensations. So this is very important note and will give you the diagnosis. It will give you the diagnosis in neurology. The equation will give you the diagnosis. If there is everything, all are impaired. There is manifestations of upper motor neuron lesion, manifestations of lower motor neuron lesion, sensations are impaired, and there is spastic barbaresis, and there is manifestations of hyporeflexia, and manifestations of hypotonia, and upgoing plantars, and sensations are impaired, and coordination is impaired, equal Friedreich's ataxia. Friedreich's ataxia is the easiest as motor neuron disease. Because motor neuron disease, you will find only motor manifestations, upper or lower or mixed. Upper and lower or mixed amyotrophic lateral sclerosis. Coordination is intact, sensations are intact. Amyotrophic lateral sclerosis. Upper motor neuron only, primary lateral sclerosis. Lower motor neuron only with coordination is intact and sensations are intact. It's called progressive muscular atrophy or Kennedy's disease, which is bulbophagia, hereditary disease. So it's very, very, very different between, a big difference between amyotrophic lateral sclerosis and other motor neuron disease, because amyotrophic lateral sclerosis is a degenerative disease, unknown cause, it's a progressive, and it's fatal, no treatment. While some congenital diseases are mild and lifelong. The patient will have early in life and can live with it. Upper or lower motor neuron lesions. If you find everything, no doubt. If you find everything in the case, it's Friedreich's ataxia. Friedreich's ataxia, you will never miss. It's also spot diagnosis. You will find the patient, titubation, tremors, head titubation, the trunk titubation, moving all the time. And staccato speech, and nystagmus, and post-pointing. And there will be intentional tremors, dysdiadochokinesia, pendular reflexes. These are manifestations of cerebellar syndrome. You will find peripheral neuropathy, and you will find spastic barbaresis, upper and lower motor neuron. Lower motor neuron, you will find hyporeflexia of the ankles, and you will find upgoing plantars. Upgoing plantars is the only sure sign for upper motor neuron lesion. Whenever you find it, so never to miss it in the exam. Plantar reflex is a killer. If you don't do it, you will never differentiate between upper and lower motor neuron lesion. Because muscular atrophy may be disused atrophy. It's very similar to wasting, which occurs in lower motor neuron. Fasciculation also is diagnostic for lower motor neuron lesion. Fasciculations, lower motor neuron lesion, no doubt. If there is wasting, can be wasting due to lower motor neuron or disuse atrophy due to lower motor neuron lesion. So these data are very important. You put this equation, you will get the diagnosis. Even if you are not able to reach a diagnosis, you will reach a differential diagnosis. So in order to save your time, because it's long session, we'll go for the bus test videos. In bus test videos, we have two important objectives. The first objective is to review the steps for clinical examination. To review the steps is very important to know, and to know by heart. It's as your name. You should do a professional neurological examination. See the videos many times and go for practice. Do it at your clinic, in your family, in your friends, whoever. But you should practice how to do the clinical examination. Tone, power, reflexes, coordination, sensation. You should know how to do this, and we have 3 or 4 cases which are as appropriate examination. For example, cerebellar syndrome. Cerebellar syndrome, you will examine the patient, the specific examination. You will examine for nystagmus, you will examine for rebound phenomena, you will examine for pendular reflex, you will examine for staccato speech, this diadochokinesia. So there are some important examination specific for cerebellar syndrome. Myasthenia gravis, also there is fatigability test. Myotonia dystrophica, you should know how to examine and elicit the specific signs for myotonia dystrophica. For other cases like Parkinsonism, it's examined as appropriate. So there are some cases, these are examined as appropriate. It's very important, but otherwise, tone, power, reflexes, coordination, and sensation. So to know the steps for clinical examination is 50% of the mark. If you are doing professional, fluent clinical examination, you will pass the exam. Keeping the patient safety and the patient welfare. Use no sharp needles for pain sensation, no sharp needles. Make sure that it's not painful. So that's why it's very important to do the fluent clinical examination, and you know, this is the main important point here. The second important point here in our session is to know the different cases which come in the exam and how to examine and how to elicit signs and how to put it. The only thing that I want to tell here is to do the abduction and the adduction of the lower limb while you are doing the power. The power, examine the power of adduction and abduction. It's very important, and in some videos you will not find the candidate is doing the abduction and the adduction of the thighs, because actually it's very important in clinical diagnosis. If the adductors are weaker than the abductors, it's proximal myopathy. Pyramidal shape distribution of weakness, which is a very important sign of upper motor neuron lesion, is 3 important components. The first is distal weaker than proximal. Distal weaker than proximal. And abductors are weaker than adductors. If you find the reverse, it's a proximal myopathy. And flexors are weaker than extensors in the lower limb. So this is what's meant by pyramidal shape distribution of weakness. So in order to save your time, I will go for the videos. And while we are going through the videos, we'll give some comments, but the most important is to attend, because sometimes we don't have time, we are busy, we are not interested, but please attend these videos because these are very important to memorize and to know how to examine the patient, how to present your findings, and how the discussion goes, even if you are going to the exam for the first time.
Hello there.
Hello.
Is it Mr. Fletcher?
It is, yes, Doctor.
My name's Dr. Maskery. I'm one of the doctors here. May I examine you?
Certainly you can.
Are you in any pain at all?
No.
Just going to look at your arms to begin with.
The sound is clear?
Yes, clear.
Just ask you to hold your
Yes,
hands
doctor,
out
it's
for me
very clear. Yes, sir.
Okay, thank you.
and turn your hands over. Okay, and just hold your hands out in front of you like this and just spread your fingers apart. And close your eyes for me. And open your eyes again. We'll turn your hands over. Just move them up slightly more and just keep your hands nice and still for me and close your eyes. That's great. You can open your eyes now. Just relax your arms. Now if I can just take this hand, what I want you to do is just stay nice and relaxed and let me take all the weight.
Yes.
Nice and relaxed for me. And on this side, nice and relaxed, let me take all the weight. And relax. Now if I can just take this hand, and this hand. Good. Can I ask you just to move your hands out to the side like this? Good. And gently push them down. Good. And just push down against me. As strong as you can. Good. And your arms like this for me. So I want you to pull me towards you as strong as you can. Good. And pull me towards you as strong as you can. Good. Now just relax this arm slightly. Push me away. Good. And push me away. Good. Arms out in front of you. And make a fist. Just bring this fist backwards. And don't push it down. Good. Bring the fist backwards. And don't let me push it down. Good. Fingers out straight. Bend these fingers up for me. Together. And don't let me push them down. Good. And bring these fingers up. And don't let me push them down. Good. Fingers apart. Nice and strong. Don't let me push those together. Nice and strong. Don't let me push those together. Nice and strong. Turn your hands over. Now bring this thumb up towards the sky. Perfect. Don't me push that down. Nice and strong. And on this side, thumb up. Don't me push that down. Good. Now if you could just grip my fingers. Nice and strong. And grip my fingers. Strong as you can. Good. And relax your arms. Just bring them across your waist there. I'm just going to tap this on your elbow and your wrist, okay?
Yeah.
So stay nice and relaxed for me. And I'll just bring this across, nice and relaxed. Good. And bring this one across. Good. The next thing to do is if I can just ask you to take this hand, just your first finger, touch my finger for me, and now your nose, and my finger, and your nose. Good. Can I ask you to do the same with the other side? So my finger, now your nose, and my finger, and your nose. Good. The next thing I'd like to do is to check your sensation, okay? And we'll start off with this pin. So I can just touch this on the bottom of your neck. Does that feel sharp?
Yes.
Okay. If I can ask you just to put your hands out like this for me and rest them down onto your knees. Perfect. So you can keep your eyes open for this one. I'm just going to touch it against your arm. Does that feel sharp?
Yes.
Does it feel the same there?
Yes.
And here?
Yes.
and here.
Yes.
Does it feel the same?
A bit duller on that side.
A little bit duller on this side.
Mm.
And here,
Yes.
and here.
Yes.
The same on both sides?
Duller on the left again.
And here,
يا رب
and here.
نبقى لي
The same. Here, and here.
Ah, no, that's, yeah.
It feels a little sharper, does
Yes, that's,
it? Here, and here.
yes.
Does it feel the same on both sides there?
That's correct.
Thank you. Next thing to do is this piece of cotton wool, if I can touch that against your chest there.
Mm.
So can you feel that nice and soft there and there?
Yes.
Does it feel the same on both sides?
Yes.
And here, and here.
That's okay.
That's okay. Next one is this. So this is a tuning fork. So can you feel that buzzing there?
Yes.
And can you feel it stop?
Yes.
Okay. So you can keep your eyes open to begin with. Can you feel that buzzing there?
Yes.
And close your eyes for me. Tell me if it stopped.
Stopped.
Okay. Just lift this hand up. Can you feel that buzz in there?
Yes.
And how about now?
Stopped.
Okay. Next thing to do, so if you just look at your finger for me, if I'm going to move it down,
Yes.
and I'll ask you to say down, and up. So if you close your eyes for me and say down or up.
Up. Down. Down.
Okay. And on the other side.
Down. Up. Down.
Okay, thank you. That completes my examination.
Thank you, Doctor.
Thank you. Could you present me with your findings, please?
So, on examination, Mr. Fletcher had resting flexion of the interphalangeal joints on the 4th and 5th digits of the left hand. This was accompanied by wasting of the first dorsal interossei and also the hypothenar eminence on the same hand. When I examined the wrist, there was evidence of scarring present on the ulnar aspect of the wrist as well. When I examined power, there was weakness of finger abduction, and this was associated with hyperalgesia when I tested with sharp touch in the region of the ulnar nerve and altered sensation with soft touch.
What do you think the cause for this ulnar nerve lesion might be?
So when these symptoms are accompanied by a scarring over the ulnar aspect of the wrist, I feel that this is most likely due to an ulnar lesion, either due to trauma or due to a surgical procedure.
Okay. How can you be sure this isn't part of a more generalised neurological disorder, such as mononeuritis multiplex?
So in this case, I examined the patient's upper limbs. Ideally, I'd like to complete it by taking a full history and also examining the patient's cranial nerves and performing a neurological examination of the patient's lower limbs. In this setting, the reflexes were normal. In a generalised inflammatory neurological condition, I would expect some degree of areflexia.
Okay. Are you confident that we're not dealing with a C8 T1 nerve root lesion?
So when I tested the power in abductor pollicis brevis, the power was actually strong. And when I tested sensation in the T1 dermatome, that was normal. So I feel it's unlikely to be a C8 T1 lesion.
Okay. And are you also confident that the other major upper limb peripheral nerves are spared here?
So when I examined the motor aspect to the radial nerve, wrist extension was strong. This was accompanied by strong finger extension as well, demonstrating good motor function of the posterior interossei nerve. When I examined the abductor pollicis brevis, as said previously, that was strong, indicating good motor function of the median nerve as well. When testing sensation, I could only find altered sensation within the distribution of the ulnar nerve.
Fine. Let's say that the patient is now complaining of unpleasant, sharp shooting pains in that hand. Are there any treatments you could offer him?
So in that setting, we'd be looking at potentially a tricyclic agent, which is licensed for the treatment of neuropathic pain, such as amitriptyline.
Okay. Let's say we've given him some amitriptyline, but unfortunately he develops drowsiness and also complains of a dry mouth. These are common side effects of that drug. What else could you do for him?
So where the first-line therapy is ineffective or the side effects aren't tolerated, we could look at using an anti-epileptic drug, which is, again, licensed for the management of neuropathic pain, such as gabapentin or pregabalin.
Okay, but let's say, once again, unfortunately, sedation is caused by these drugs. How else could we manage it?
There's also an SNRI licensed as well, called duloxetine, or if tablets aren't being tolerated, then we can consider topical therapies such as capsaicin.
Do you think there are any investigations that are required here?
So I think it would be important to arrange neurophysiological testing. Nerve conduction studies in this setting would be useful, although the diagnosis is quite clear. It would help us to localise the lesion more thoroughly. Performing EMG could help to provide some prognosis as well in terms of recovery.
Okay, thank you very much. In this case, the candidate was asked to perform a neurological examination of the upper limbs. This case is a good example of the importance of performing a thorough inspection, as there are major clues to the diagnosis just from the signs apparent at the end of the bed. The patient has abnormal positioning of the left hand fingers with mild extension at the 4th and 5th metacarpophalangeal joints and relative flexion of the fingers. This is characteristic of the so-called ulnar claw. In addition, there was a scar over the wrist that could indicate either trauma or surgery, and as such may point towards the likely etiology of the hand problem. Making this initial observation is clearly important, as it will alert you to some of the signs to look out for. Specifically, you'll be looking for evidence of an ulnar neuropathy. This means that you know to pay special attention to wasting within the small muscles of the hand, and you'll need to confirm weakness in muscles such as finger abductors. However, at the same time, you would also want to make sure this case wasn't a mimic of ulnar nerve damage. In particular, you'll be aiming to exclude the possibility of a C8-T1 radiculopathy. This can be done by looking for weakness in other hand muscles that are C8-T1 innervated, but not supplied by the ulnar nerve. Abductor pollicis brevis is just such a muscle. In addition to ensuring this is not a radiculopathy, you'll need to work out whether this is a pure ulnar neuropathy or whether other upper limb nerves are involved. This can be achieved by testing wrist extension, which is radial nerve, finger extension, which is posterior interosseous, and abductor pollicis brevis, which is median nerve. Sensory testing will also help to work out whether this is an isolated mononeuropathy or a more diffuse problem. Now, trying to hold all of this in mind can be very difficult, especially under exam conditions. It's for this reason that we recommend having a very structured examination approach and doing the same thing each time. The muscle groups that we recommend testing have been chosen with this in mind. The standard movements that our candidate tested cover all the upper limb root values C5 to T1, but also tap the major upper limb nerves. In the same way, a very standardized approach to sensory testing is helpful. The candidate carefully checked each dermatome in turn, but also tested areas on the hand which are specific to ulnar and median sensation. This turned out to be very helpful, as the patient was able to clearly describe a difference in sensation affecting the ulnar portion of his left hand. The instructions that you give to the patient for sensory testing are very important, as this case demonstrates. The candidate was careful to ensure the patient understood what was going on, and wherever possible, he allowed the patient to have his eyes open. By doing this, the candidate was able to establish that whilst there wasn't any frank sensory loss, there was a qualitative difference in sensation, hyperesthesia in this case. The important signs in this case were all in the left hand. There was wasting of dorsal interossei, wasting of hypothenar eminence, and a scar over the wrist. In addition, there was weakness of the finger abductors, with good strength in all other small muscles of the hand. There was hyperesthesia in the ulnar nerve distribution of that left hand. These findings are consistent with the left-sided ulnar neuropathy. The presence of scars suggests the case is likely to be traumatic, but the patient may also have had surgery to repair an injured nerve. In this sort of case, there are a very limited number of useful investigations. The diagnosis seems clear, but peripheral neurophysiology would be helpful in order to confirm the diagnosis and also look for evidence of re-innervation on EMG, which does help with prognosis. If the signs were less clear-cut and there was genuine doubt about the differential, meaning you were worried about cervical radiculopathy, then an MRI scan of the neck may be required. And an examiner could ask you about management, and given the hyperesthesia, they may ask you about the management of neuropathic pain. There are a few options with respect to this, but generally we'd start with tricyclics such as amitriptyline and move on to gabapentin or pregabalin if there are problems with lack of efficacy or side effects.
Hi, is it Mr. Morrison?
Yes.
Hi, I'm Dr. Maskerin, one of the doctors. May I examine your legs?
Yes.
Do you have any pain in your legs at all?
No.
I'm just going to have a look at them to begin with. And just keep the legs nice and relaxed for me. Okay. Keep this leg still. Lift this one straight up off the bed. Don't let me push it down. Good. And lift this one up. Don't let me push it down. Good. Push down into the bed. Push down into the bed. Good. Bend this knee for me. Pull me in towards you. And push me away. Good. Bend this knee for me. Pull me in towards you. And push me away. Good. Bend this ankle up towards you. Bend this ankle up towards you. Just the big toe this time. Just the big toe. And push down. And push down. Good. I'm just going to tap this on your joints now. Stay nice and relaxed for me. Good. Nice and relaxed for me. Good. Bending this knee. Can I ask you just to clasp your hands together for me? And when I say pull, pull, pull. Good. And bending this knee. So relax to begin with. And pull. Good. I'm just going to put this across the bottom of your foot, so just relax for me. Okay. Can I ask you just to pop this heel onto this knee and run it down the leg and up and back up again and down. Good. And relax. And this heel onto this knee and down the leg and up and down the leg and up. Good. And relax. So the next thing to do is to check your sensation. So this should feel sharp if I press it here.
Yes.
That? I'm going to do the same thing on your legs. Just tell me if you can feel it here
I can feel pressure but not sharp.
and here
Pressure but not sharp.
and here.
Pressure, pressure, nothing, 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 nothing.
I'm just going to run it up the foot. Tell me when you can feel it. And up the leg.
I can feel pressure now. Pressure. Oh, that one was sharp.
It becomes sharp there. Same on the other side.
Nothing, nothing, nothing. Pressure, pressure. Ah, that one was sharp.
Sharp there. Thank you. This should feel soft if I just press it here.
Yep.
Doing the same again. Let me know when you can feel it.
I can feel it now.
You feel it there?
Yep, yep. Yes, 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 yes.
Just there?
Yes, yep.
So next one we're feeling for a buzz. So you'll feel the vibration there.
Yes.
Close your eyes for me. Tell me when it stops.
Stopped.
Okay, open your eyes again. So we'll put this here. Can you feel that there?
Nothing.
Or there?
Nothing.
Here?
Nothing.
Here?
Nothing. I can feel pressure but no vibration.
Okay. May I just pop this onto your hip? Can you feel that there?
Yes, I can feel that.
Is it vibrating?
Yes.
Close your eyes and tell me when it stops.
Stop.
Good. And then the other side, just looking down, can you feel that there?
Nothing.
Or there?
Nothing.
Or there?
Nothing.
Okay. Here?
Nope. Pressure.
And may I pop this on your hip?
Yeah, I can feel vibration there.
Close your eyes. Tell me when it stops.
Stop.
Good. Next one, I'm just going to move your joints. So if you just look at the toe for me, feel that down and up. Close your eyes.
Don't know.
With the whole toe now, close your eyes. Down or up.
Don't know.
And with the ankle, up
That's up.
or down.
Down. Up.
And on the other side, just looking at the toe to begin with. Down, up. Close your eyes.
Don't know.
With the whole toe now.
Don't know.
And with the ankle.
That's up. Down. Up.
Okay. Open your eyes for me. And would it be okay to see you walking?
Yeah.
You have 1 minute
Do you
remaining.
need your stick for this walk?
No.
And just stand with your back against the wall. Now I'd like you to take a few steps forward, please. And turn around for me. Now, as you're walking backwards, can you just walk with your heel toes like that for me? Okay, thank you. And just stand with your back towards the bed, but not touching it for me. Put your feet together, your head up. Just get your balance there for a second. And now I'd like you to close your eyes for me. Okay, you can open your eyes now. Just sit back down on the bed. You can pop your feet up as well. Thank you very much. That completes my examination.
Thank you. Could you present me with your findings, please?
So, on examination, Mr. Morrison had normal tone. His power was reduced more distally. Reflexes at the knee were maintained, but at the ankle they were diminished, but with potentiation they were present. Coordination was intact, and on sensory testing he appeared to have a symmetrical Stockings distribution of reduction in sensation to pinprick up to the knee, and also to soft touch as well. Proprioception was reduced to the ankle, and vibration was reduced to the hip. I feel that this is most likely in keeping with a peripheral neuropathy.
Okay, can you be a bit more specific about what sort of neuropathy you think this is?
In this setting, he did appear to have a predominantly sensory polyneuropathy with some motor signs. Ideally, I'd like to take a full history and examine the patient's cranial nerves and upper limbs as well.
Okay, what sort of causes would you consider for that type of neuropathy?
So for this type of neuropathy, the most common cause would be diabetes. Other metabolic causes would include things such as hypothyroidism, uremia, vitamin deficiencies such as vitamin B1, vitamin B6 and vitamin B12. There could be also some toxic causes, so they would include things such as chemotherapy agents, antibiotics and other medications which can be prescribed. Certainly the most common cause of a toxic agent would be alcohol use and alcohol overuse, which would also cause predominantly sensory polyneuropathy as well. There would also be some inflammatory conditions can cause this. So classically we'd be thinking about chronic inflammatory demyelinating polyneuropathy, or CIDP, but other systemic inflammatory conditions such as sarcoidosis or ANCA-positive vasculitis or rheumatoid arthritis could cause this as well. There's then the polyneuropathies associated with paraneoplastic causes, either due to a solid organ malignancy such as lung cancer, or those associated with a paraproteinemia.
Okay, sticking to the topic of causes of the neuropathy, are there any simple bedside tests or measures you could do to try and work out the cause of this gentleman's problem?
So I could perform ophthalmoscopy, looking for any evidence of a diabetic retinopathy. I'd also like to perform urinalysis, looking for glucose in the urine, and I could also perform a blood glucose measurement as well.
Okay. In terms of other investigations or lab investigations, how would you go about, putting together a plan for his investigation?
Well, I think it'd be important to start with some simple blood tests, so a full blood count, looking for any evidence of a macrocytic anemia, urea and electrolytes, checking the patient's urea level, liver function tests, as there could be some derangement of transaminases in alcohol use. Other tests such as thyroid function, checking the patient's vitamin levels, particularly vitamin B12, screening the patient for autoimmune inflammatory conditions with a measurement of an ESR, and also in any patient presenting with peripheral neuropathy, we should be checking for immunoglobulins and serum electrophoresis.
Okay, and setting to one side the blood tests, are there any other sorts of investigations that could be helpful?
So it would be important to also measure HbA1c, and moving away from blood tests, we could perform neurophysiological studies such as nerve conduction studies and EMG.
And what's the main purpose of doing nerve conduction studies in a situation like this?
So in a situation like this, we need to perform nerve conduction studies in order to determine whether this is demyelinating in nature or whether this is axonal, with the demyelinating conditions more likely to be associated with an underlying inflammatory condition such as CIDP.
Okay, and are there any other bits of information you can get from the neurophysiology?
So you can also help to figure out whether this is length dependent in nature. And those which are non-length dependent are again more likely to be inflammatory in nature.
Okay, thank you very much. In this case, the candidate was asked to examine the lower limbs. To begin with, it appeared as if there was little to find, as inspection, tone and power were essentially normal. Indeed, given the normal tone and almost normal power, you'd already be thinking that a significant upper motor neuron lesion was unlikely. However, there was actually some very mild distal weakness of the great toes, and this was really a clue as to what was going on. As we checked the reflexes, it became apparent that the ankle jerks were all but absent, and this would have helped to confirm the hypothesis that a peripheral neuropathy was the likely diagnosis. The sensory testing was entirely in keeping with this, as a clear stocking distribution of sensory loss became apparent. You will have noticed that not all the sensory modalities were affected equally. This is very common in peripheral neuropathy, as different sensations are mediated by different nerve fibre types, and while some diseases will affect all nerves, some have a tendency to target one fibre type or another. In this case, we saw quite significant small fibre involvement, as evidenced by the pinprick alteration, and perhaps even more obvious large fibre damage, reflected by the severe vibration sensation loss. The next finding of note was the abnormality of gait. The patient walks quite well to begin with, so the candidate made the test harder by asking him to walk heel to toe. This revealed a midline gait ataxia. Additionally, the patient swayed when standing with his eyes closed. In other words, he was Romberg positive. This is a helpful observation and means that his unsteadiness is due to sensory ataxia. This, of course, is in keeping with the findings of sensory loss, thus providing some internal consistency for the case. Taken together, the findings of distal weakness, hyporeflexia, stocking sensory loss, and sensory ataxic gait are all in keeping with a predominantly sensory motor neuropathy. In a situation such as this, you can expect to be asked about potential causes for peripheral neuropathy. As peripheral neuropathy is the commonest neurology station in PACES, you should be prepared for this question. It is in fact such a common scenario you might consider preparing an answer for this in advance. In this case, we saw the candidate give the most likely diagnosis first, which I think is a very reasonable strategy. The candidate then went on to provide a structured list of causes. It's a really good idea to break the differential diagnosis down into major disease categories. In this case, we heard about metabolic causes, toxic causes, immune-mediated causes, and cancer-associated causes. This was very good, as they were all plausible, given the clinical findings. You'll notice the candidate didn't try to suggest all neuropathy etiologies. Given the relative preservation of power and lack of wasting, there'd be no reason to suggest a genetic cause for this neuropathy, such as Charcot-Marie-Tooth. Having gone through potential causes, it would be natural for the examiner to explore how you might investigate the patient. Once again, given the frequency with which this case appears in PACES, it's worth rehearsing an answer to this question. When doing so, it's important to think about simple bedside measures that can be done. This would predominantly be bedside tests for diabetes, such as a BM or urine dipsticks. But don't forget, it's possible to directly assess diabetic end organ damage by looking for diabetic retinopathy on fundoscopy. Your investigation plan needs to match the list of possible causes you have given, but also needs to be rational, which means starting with basic blood tests and moving on to more advanced tests and tests for rarer diseases. Remember to try and justify each test you suggest to the examiner. As well as blood tests to investigate the cause for the neuropathy, it's worth thinking about nerve conduction studies. This can provide valuable information about the neuropathy, and in particular, it can determine whether the neuropathy is demyelinating or axonal. This is principally important because demyelinating neuropathies are much more likely to be immune-mediated and will need specialist investigation and potentially treatment. In this case, the neuropathy was indeed secondary to diabetes, so the mainstay of treatment is with tight glycemic control. However, it would also be important to consider other management steps, such as physiotherapy for gait stability and regular podiatry for foot care.
Hello, is it Mr. Taylor?
It is, yes.
Hi, I'm Dr. Maskery. May I examine your legs?
You can indeed, yes.
Thank you very much. Are you in any pain at all at the moment?
Not at all, no. Thanks for asking.
Thank you. Okay, just keep your legs nice and relaxed for me. Nice and relaxed. I'd like to check how strong your legs are now. Keeping this leg still, just raise this leg straight up off the bed for me. Don't let me push it down. Okay, and this leg straight up off the bed, don't let me push it down. Okay, push down into the bed. And push down into the bed. And bend this knee for me. Push me away. Push, 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 push. And pull me towards you. And relax. And push me away. And pull me towards you. And relax your leg. Bend your ankles up towards me. And on this side, up again. Just the big toe this time. So just moving the big toe up towards you. And on this side. Push away with your ankle. And push away. Okay. I'm just going to tap on some of your joints now. So if you just stay nice and relaxed, let me take all the weight. Good. Can I ask you just to clasp your hands together for me? And when I say pull, just pull together. So relax and pull. And relax and pull. Just relax to begin with. And when I say pull, pull. Pull. On this side. Relax to begin with. Pull. And relax. I'm just going to run this along the bottom of your foot if you just stay nice and still for me and relax. Okay. The next thing I'd like to do is if you can just pop this heel onto this knee for me, run it down the leg, lift it off the leg and back up to the and down. Good. And now can you do the same but with the other leg? Good. And relax. So I'd now like to check sensation. We start off with sharp sensation. So just lift your head up for me. I'm just going to touch this at the bottom of your neck. Can you feel that there?
Yes.
Does it feel sharp?
It does, yes.
And just keep your eyes open for me and say yes if you can feel it.
Yes. Yes.
Does it feel sharp?
It does.
Or does it feel the same on both sides?
It does. Yes. 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 Yep. Yep. No. No.
You don't feel it. Okay. And here.
Nothing.
And here.
No.
Can you tell me where you start to feel it?
No. No.
And do you feel pressure or sharp?
That's sharp.
And on this side as well.
No. No.
Sharp again?
Sharp. Yeah.
Thank you. Now, just touch this here. Feel soft?
Yep.
Keeping your eyes open, just tell me when you can feel it.
No.
And again.
No.
Okay. Next one is vibration. So, can you feel that there?
Feel the pulse, yep.
Close your eyes for me. Tell me when it stops.
No.
Okay. So we're going to do the same thing on the legs. So eyes open to begin with. Can you feel that vibration there?
No.
Can you feel it there?
Slightly cold, but no vibration.
Can you feel it here?
I can feel a little bit of vibration there.
Close your eyes for me. Tell me when it stops. Open your eyes again for me. Can you feel this here?
Yep.
Close your eyes for me.
Stops.
Good. And on the other side, open your eyes. Can you feel the vibration there?
No.
Can you feel it there?
No.
Can you feel it there?
A little bit there.
Close your eyes for me. Tell me when it stops.
No.
Okay. And open your eyes again. Can you feel the vibration? Close your eyes.
No, it's gone.
Okay. And finally, if you just look at your toe for me, I'm going to move it upwards.
Yep.
I'm going to move it downwards. And we say up or down. Okay, close your eyes. And now look again. So I'm going to move the whole toe.
Maybe down. Down.
Okay. What I want to do, just look down. So the ankle is either up or down. Close your eyes for me.
That's up. That's up. That's down.
Okay. And on the other side, if you begin with the end of the toe here, That'll be down, that'll be up.
Yeah, can't tell.
So we're doing the whole toe this time.
Maybe. Oh,
Okay, and you're going to move the ankle this time. So that would be up and that would be down. So how about now?
that's up. That's down. That's down.
You have 1 minute
Thank you.
remaining.
And could I ask you just to swing your legs over the side of the bed? Would you be okay to walk for me? Okay, just come so your back's against the wall. And what I'd like you to do is just take a few steps forwards for me. And turn around there for me. And come back towards the bed. Now, can I ask you to stand with your back towards the bed? So just turn around to face the wall. And just so you're not touching the bed, step forward slightly for me. Put your feet together. And can you try and close your eyes for me? And open your eyes. Do you want to take a seat on the bed?
Yeah.
And pop your legs back up again for me. Thank you very much.
Thank you very much.
That completes my examination.
Thank you. Could you let me know what your findings were, please?
The signs here show that the neuropathy is long-standing and mostly consistent with a Charcot-Marie tooth. On examination, Mr. Taylor had generalised wasting of his muscle groups, particularly in the distal muscles. He also had high arched feet. On examination of his tone, it was flaccid bilaterally throughout the lower limbs. Power was reduced particularly in the distal muscle groups, and I wasn't able to elicit any reflexes, even with potentiation. His coordination did appear to be intact, but his sensation was reduced to pinprick and soft sensation to the ankle. He had proprioception in the ankles, and his vibration was reduced up to the medial malleolus. When I examined his gait, he had a high stepping gait with bilateral foot drop, consistent with a sensory ataxia, and he found it very difficult to stand still with his feet together due to unsteadiness.
Okay, bearing that in mind, what would you expect to find on examination of the upper limbs?
So ideally I would like to complete my examination by taking a full history, examining the cranial nerves and also examining the upper limbs for a neurological examination. In the upper limbs I'd expect to find much the same signs, so I'd expect to find generalised wasting, and indeed when I shook his hand to begin the examination I did notice wasting of the dorsal interossei of his hands bilaterally. I would also expect to find again flaccid tone, areflexia and reduction in power, particularly distally. However, I would expect these signs to be less prominent than in the lower limbs.
Okay, you mentioned there taking a history. In addition to hearing about Mr. Taylor's limb symptoms, what other aspects of the history would be particularly important?
So Charcot-Marie tooth is an autosomal dominant condition, so I'd pay particular attention to the family history. I would expect for someone such as a parent or a sibling, or maybe an auntie or uncle to have been affected by this condition.
Okay, let's assume that we want to investigate the patient for Charcot-Marie tooth. How should we proceed?
So I think neurophysiology would be very important in order to determine whether this is demyelinating or axonal in nature. Essentially, this is a genetic condition, so a blood test looking for Charcot-Marie tooth genetic studies would be essential.
Okay, why is the distinction between demyelinating and axonal neuropathies helpful or important in the investigation of Charcot-Marie tooth?
So there's multiple types of Charcot-Marie tooth, particularly type 1 is associated with demyelination, and that would help to delineate between the subtypes of the condition.
Okay, do you know of any treatments that are available for Charcot-Marie tooth?
In terms of disease-modifying treatments, I'm not aware of any treatments which are currently available. However, diagnosis is important, particularly given that this is a genetic condition. It would help, to direct family members who may also be affected, and it would also, allow the patient to understand what's affecting them.
Okay. In the absence of disease-modifying treatments for Charcot-Marie tooth, what other management plans do we need to put in place for him?
So we can involve the multidisciplinary team in order to manage this patient effectively. So the physiotherapists could work with him to help improve his mobility, and they could also bring in other departments such as the orthotics department. I noticed this patient had bilateral foot orthoses, which he told me helps him to drive. The orthotics department could provide these if necessary. There's also the occupational therapy team who could help at home, helping him to mobilise around the home as well. and bringing these together can help to improve the patient's function in the community.
Okay, thanks very much. In this case, the candidate was asked to examine the lower limbs. From the outset, there were clear abnormalities on inspection. The patient had ankle-foot orthoses at the side of his bed. These devices are used to correct foot drop. There was evidence of marked muscle wasting, especially distally, but no clear fasciculations. It would be possible to say that the feet were in relative plantar flexion with quite high arches, but true pes cavus probably wasn't present. Having made note of such marked lower limb wasting, it would be sensible to have a look at the patient's hands to look for similar problems. In this case, inspection of the patient's arms reveals marked wasting of the dorsal interosseae and thenar eminences. There's also evidence of wasting in the forearm compartments. As the examination proceeded, it became clear that we were dealing with a severe neuropathy. The overall pattern was one of a predominantly motor sensory motor neuropathy. There were some points of good examination technique to mention in this case. The candidate was careful to ask the patient to put each muscle group into activation before applying any resistance. This is generally good practice, but especially so in cases of severe weakness when you need to know if there's anti-gravity power, let alone power against resistance. Another point of good examination technique was the careful assessment of sensation. The candidate looked for any dermatomal sensory loss with the pin first, and then checked for a stocking distribution using the same modality. Having found a stocking loss with the pin, he very sensibly confirmed that with another modality, namely soft touch using cotton wool. Vibration and joint position sense are tested differently. It's not really possible to lose these sensory modalities in a dermatomal pattern, so the key thing is to start distally and then, if impaired, move ever more proximally until the sensation is normal. To really accurately test these modalities, the patient has to close their eyes, but for the remainder of the sensory examination, it's best to let the patient have their eyes open. In a case such as this, having established that the likely diagnosis is Charcot-Marie-Tooth, the examiner may well ask for an investigation strategy. Testing for this sort of genetic neuropathy is quite different to the investigation plan for most acquired polyneuropathies. In this scenario, basic blood tests are unlikely to be helpful. Neurophysiology can be very useful and are an appropriate first strategy. This test will demonstrate severe and uniformly reduced responses in keeping with a genetic neuropathy. In addition, it may be possible to determine if the neuropathy is axonal or demyelinating, which would help you target genetic testing appropriately. There are many different mutations that can cause a Charcot-Marie-Tooth phenotype, and this stage of the investigation is best managed by a specialist in neuromuscular disease. As the candidate mentioned, whilst there are no definitive treatments for genetic neuropathies, an accurate diagnosis is essential in terms of providing help to the rest of the family, and genetic counselling via the clinical genetics department should always be offered. By accurately phenotyping and diagnosing these genetic diseases, we're able to further research work and move nearer to potential disease-modifying treatments. Finally, there are some generic aspects of management that you should be familiar with. Anybody with a chronic neuromuscular disease will benefit from the input of a multidisciplinary team. Physiotherapists can greatly help with gait and mobility, whilst the orthotics department can be vital in providing the sort of foot supports that keep people ambulant. For patients with significant upper limb involvement, an occupational therapist may be able to make home adaptations to circumvent some of their difficulties.
Hello, is it Mrs. Smith?
Yes,
Hi, I'm Dr. Maskery. I'm one of the doctors here. May I examine you?
yes,
My first question is, have you noticed any change in your sense of smell?
it's fine.
It's okay. I'd like to examine your eyes now. The first thing to do is I'll just stand behind the chair. Can you cover up your right eye for me? And I'd like you to start at the top and just read down the letters for me.
HPNDZU FRVE ZHNUD. Can't read.
And if you cover up your other eye for me and start again from the top.
HPN DZU FRVE ZHNUD. Too small.
So it's 612, 612. That's okay. So if you look directly at me, keeping your head still, I'm just going to move my hands into the corner of your vision. If you say yes when you see one of those hands move.
Yes.
And again, yes when you see one move.
Yes.
That's great. Next thing to do is, can I ask you to cover your right eye with your right hand, please? And now I'm going to move this red pin just into the corner of your vision, looking directly at me. Say yes when you see it.
Yes.
And again, looking directly at me, just say yes when you see the pin.
Yes.
Keep your hand still for me. Yes when you see the pin.
Yes. 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 Yes.
And again.
Yes. Yes. Yes.
And can we switch eyes now? Looking directly at me. Yes when you can see it.
Yes. 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 Yes.
Keep your hand still for me.
Yes. Yes.
That's great, thank you. You can relax now. I'd like to take your glasses off, please. I'm now going to shine a light into your eyes. So if you can just look straight at me. Keep looking straight at me. Good. Now I'd like you to just look across behind me and now look at my finger. That's good. I'd now like to look at the back of your eyes. Okay, so I'd like you to choose a spot on the wall behind me and keep looking at that. I'll come quite close to you and I'd like you to continue looking behind me, okay? Do you mind if I rest my hand on your shoulder?
No.
Thank you. Keep looking at that spot. That's good. I'm just going to look at the other eye. Keep looking up into the distance for me. That's great, thank you. You can pop your glasses back on now. Okay, can I ask you just to look at my finger? I'm going to move my finger, keep your head still. If you tell me if you get any double vision at any point for me. And up. And down. Thank you. Now, I'm just going to touch this piece of cotton wool on your neck. Can you feel that there?
Yes.
I'm going to touch it on each side of the face. I want you to say yes when you feel it.
Yes. Yes.
And does it feel the same on both sides?
No, it's lighter on this side.
Lighter on the left side. So there, compared with there, it's lighter on this
Yes,
side.
it's lighter.
And here,
Left.
lighter on the left side. So I can also elicit the corneal reflex at this point.
That won't be necessary. The corneal reflex is present.
What I'd like to do at this point is if you can just relax your mouth for me. I'm just going to put my finger on, so relax your mouth open. I'm just going to tap this very gently. That's good. Now, put my hands on your cheeks, just bite together for me. Excellent, and relax. And bite together. And relax. Good. Raise your eyebrows up for me. And relax. And close your eyes tight. I'm just going to try and open those. Don't let me open them. Don't let me open them. Good. Puff out your cheeks. Good. And show me your teeth.
You have 1 minute remaining.
That's excellent. Can I ask you to open your mouth for me and just relax your tongue? Good. Say ah for me.
Ah.
And cough. I can ask you to open your mouth again and stick your tongue out and move it side to side for me. That's great, thank you. And I can also elicit the gag reflex at this point.
That won't be needed today.
Now, I'm just going to cover this ear. Can you hear this?
Yeah.
And can you hear this?
Yeah, that's better.
Sounds better on the right side. I'd like you to look over your left shoulder now for me. And I'm going to put my hand on your cheek. Don't let me push your head back. Good. Look over your right shoulder. And again, don't let me push it back. And look back towards the middle. Can you shrug your shoulders for me? That's good. Relax. And shrug them again. Thank you very much. That's great. Thank you very much. And that completes my examination.
Would you present me with your findings, please?
So Mrs. Smith has a left-sided homonymous hemianopia, accompanied by left-sided reduction in sensation on her face, and also reduction in hearing on the left side as well. Ideally, I would like to complete this by taking a full history from the patient and performing an upper and lower limb neurological examination. In this setting, I feel that the symptoms are most likely due to a right-sided middle cerebral artery infarct or a lesion affecting the right hemisphere.
Good, okay. Thinking about your examination of the limbs, what other signs might you be interested in?
So I'd be looking at, in particular at the tone, looking for increased tone, reduced power, hyperreflexia, and any evidence of clonus.
Okay, and just returning for a moment to the cranial nerve examination, you mentioned that she had a visual field defect. Could you talk me through how the nature of that visual field defect helped you localise the lesion?
So this visual field defect in particular was a left-sided homonymous hemianopia, which respected the midline and showed no evidence of macular sparing. If this was a posterior cerebral artery stroke, then we'd expect macular sparing. Given that wasn't present on examination this time, it's more consistent with a middle cerebral artery stroke, and that would also fit with the left-sided sensory changes.
Okay, let's move away from the neurological examination and think about what other physical signs we might want to look for in a case such as this.
So initially, I would like to palpate the patient's pulse. I'm looking to see if there's any irregularity to the pulse, such as atrial fibrillation, which can increase your risk of stroke. I'd also like to auscultate the carotids, listening for any evidence of a bruit, which could indicate stenosis in that vessel. I'd also like to listen to the heart. I'm auscultating for any evidence of a cardiac murmur, which could suggest valvular heart disease, increasing the risk of stroke further.
Okay. Are there any other measurements that could be done at the bedside which would be important in assessing stroke risk?
So a very important measurement to be taken at the bedside would be blood pressure, as hypertension is associated with stroke.
Good. Now, let's move on and think a little bit about initial investigations. If this lady came in to A&E with these signs, how would you proceed?
So in the acute setting, we'd need to arrange an urgent CT brain. The reason for this is, if this patient has no other contraindications on history or examination, and if the CT scan showed no evidence of hemorrhage, she could be a candidate for thrombolysis therapy.
Okay. Now, what if it was a different situation and she'd come to your clinic in the outpatients and this was a more chronic scenario? How would you proceed under those circumstances?
So I think in that instance it would be important to arrange an MR brain to characterise those changes in the right hemisphere. We'd also have the opportunity to look more closely, looking for things such as an ECG to see if the patient is in sinus rhythm, and also arranging things like blood pressure measurement and a carotid Doppler.
Okay, and what are the findings you might be interested in looking at on the carotid Doppler scan?
So on the carotid Doppler scan, we'd be looking for evidence of stenosis to see if that could be a cause of the stroke.
And if you found stenosis, what action might that lead to?
So we need to look at the degree of stenosis within the carotid vessels. If it was suitable for endarterectomy therapy, then we could arrange that.
Now, let's say we've done the ECG, it didn't show an abnormality. We've done the carotid Dopplers and there was no significant stenosis. What further tests could you do to look into the cause of this lady's stroke?
So I think in that setting we'd have to look more closely for any evidence of paroxysmal atrial fibrillation, and we could do that using a 24-hour or 5-day heart monitor.
Okay, let's say we do that, we measure it for 5 days, and there is no evidence of paroxysmal AF. Any other tests we could do?
In that setting I would arrange an echocardiogram to look for any structural cause for these symptoms.
Okay, thank you very much.
Thank you.
In this neurology station, the candidate was asked to examine the cranial nerves, and the principal finding was a visual field defect. There was also evidence of sensory loss on the left side of the face. One of the potential pitfalls of this case is that despite being asked to examine the cranial nerves, the lesion is actually in the right cerebral hemisphere. This is an important lesson to learn. Cranial nerve examination may reveal pathology that does not affect the cranial nerves themselves. The candidate rapidly established that there was a visual problem, so he performed a detailed examination of that component and used a red hat pin to carefully map out the visual field defect. Remember, the sensitivity of field testing with a moving finger is only about 50%. Using a pin increases this sensitivity to nearer 80%. In this case, a left homonymous hemianopia was found, and there was no evidence of macular sparing. This is a helpful observation. In posterior cerebral artery strokes, we see macular sparing, due to the occipital pole receiving blood supply from the middle cerebral artery. So this complete field defect would be consistent with right middle cerebral artery ischemia, assuming a vascular etiology. Having identified this field defect, the good candidate will be on the lookout for other right hemisphere signs. In this case, the candidate found reduced sensation in the left side of the face. It would be all too easy to attribute this to trigeminal nerve damage, especially as you've been told to examine the cranial nerves. This is an example of framing bias. However, if you interpret the field defect correctly, it will be apparent to you that this loss of sensation likely reflects right hemisphere cortical damage, consistent with the notion of a right middle cerebral artery stroke. There are two ways of establishing the sensory loss is not due to trigeminal neuropathy. Firstly, you could test sensation on the neck or some other site out with the distribution of the trigeminal nerve. Alternatively, you could check the corneal reflex. This will be lost in cases of trigeminal neuropathy, but remains intact when the sensory loss is due to hemispheric damage. The remainder of the examination was fairly unremarkable, and as is usually the case, the lower cranial nerves take much less time to examine than the visual components. There was mild reduction in left-sided hearing, although this is unlikely to be related. However, new unilateral hearing loss should always be taken note of and investigated in its own right. The candidate performed a fluent and comprehensive cranial nerve examination on this patient. He didn't take the opportunity to check saccadic eye movements, but actually, due to the dense field defect, this would have been a difficult test to perform. It's worth remembering, however, that horizontal saccadic eye movements are a sensitive way to check for internuclear ophthalmoplegia, and vertical saccades can reveal early signs of a vertical supranuclear gaze palsy. The findings in this examination are not particularly subtle. So as an examiner, I would be expecting the signs to be picked up correctly and for an accurate diagnostic formulation to be made. The presence of a left-sided visual field defect and left-sided sensory loss clearly localizes the lesion to the right hemisphere. The nature of the field defect, sharply respecting the midline with macular sparing, is strongly suggestive of an ischemic etiology. It's therefore quite possible to conclude that the patient has had a partial middle cerebral artery ischemic stroke. We can say it's partial based on the absence of a clear left-sided weakness. There is a differential diagnosis, and in principle, other right hemisphere lesions could produce these signs. Having found these signs, there are some other features that I would expect a good candidate to look for. In particular, I would expect them to suggest proceeding to limb examination to look for other signs of stroke, increased tone, weakness, sensory loss, hyperreflexia. In addition to this, it would be appropriate to look for any evidence of the likely etiology. Simple bedside measures would include checking the pulse for atrial fibrillation, listening to the heart for murmurs, and auscultating the right carotid for a bruit. We would also measure blood pressure and check the urine for glucose. In a station such as this, it would be reasonable to ask the candidate for a plan or investigation. It makes sense to initially confirm the primary diagnostic hypothesis. This will require cranial imaging. In the acute setting, a CT brain scan is the investigation of choice. But if this was a subacute or chronic situation, an MRI brain scan would be a better option. If the initial tests confirm ischemic stroke, the next stage would be to investigate its etiology. This would mean getting carotid Dopplers, as this is an anterior circulation stroke. An echocardiogram can be performed to look for any evidence of cardiac thrombus, and prolonged ECG monitoring is used to look for arrhythmias, specifically paroxysmal atrial fibrillation. Alternatively, the examiner may accept the diagnosis of ischemic stroke and ask for a treatment plan. This will depend on how acute the situation is. In the hyperacute scenario, attention needs to be given to the possibility of thrombolysis. In the longer term, one's thoughts need to turn to secondary prevention and addressing vascular risk factors. This would mean consideration of antiplatelet therapy, a statin, and an ACE inhibitor.
Hello, is it Molly Smith?
Yes.
Hi Molly, nice to meet you. I'm Dr. Maskery. Thank you for letting me examine your lower legs today. Are you in any pain at all?
No.
So I'm just going to move your legs now. I want you to stay as relaxed as you can for me. Just rolling this. Okay, so just stay nice and relaxed for me. Nice and relaxed. Okay. Now I want to see how strong your legs are. So keeping this leg nice and straight, can I ask you just to raise it up for me? Lift it up off the bed and don't let me push it down. And on this side, can you lift it up off the bed? Don't let me push it down. Okay. Now I'm going to put my hands underneath your leg, push down for me. And again, push down. Can I get you to bend this knee in for me? Okay. Pull me towards you and push me away. And on this side, bend your leg for me. Pull me towards you and push me away. Okay. So you bring your feet up towards you and don't let me push it down. Don't let me push it down. Just the big toe this time, up towards you and up towards you. And now push me away and push me away. Good. Now I'm going to check your reflexes. So just keep your legs nice and relaxed. Nice and relaxed. Okay. Bending this knee in. Bending this knee. Now I'm just going to run this across the bottom of your foot. So can I ask you to pop this heel onto this knee for me? Can you run it down the shin, then take it off the leg and pop it back on your shin? And just repeat that motion for me. Well done. Can you do it on the other side for me now? And lift it up off the leg and back up. Good. And just relax your legs. Now I'd like to check sensation. So I'm just going to tap this on your chest here. Does that feel sharp? I'm going to do the same things on your legs now. So, does that feel sharp there?
Yeah.
Does it feel sharp there?
Yeah.
Okay. And here?
Yeah.
And here?
Yeah.
And here?
Yeah. Yeah.
Does it feel the same on both sides and does it feel sharp?
It feels slightly duller on the left side of my leg.
Okay.
Yes. Yeah.
And here?
Yeah.
And here?
Yeah.
Okay. This time is something softer. Just press this here. And again. Feel the same on both sides?
Yeah.
And just say yes each time you feel it.
Yeah. Yeah. Yes. Yeah. 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 Jokes, yeah.
This time with vibration.
Okay.
So you can feel it vibrating there.
Yeah.
And then it's stopped.
Yeah.
Okay. So we'll try that here. So I can ask you just close your eyes, say yes when you feel it start to vibrate. Can you feel that there?
I feel the pressure.
Okay. And what about now?
I'm not going to feel the pressure.
Okay.
Yeah, I can feel it.
Tell me when it stops.
No.
Okay. And just on the other side. Can you feel that there?
No. I feel that.
Is it vibrating?
Yeah.
And tell me when it stops.
Stop.
Okay. If you look at the toe now, moving it down or up, I want you to close for your eyes for me and just say down or up.
Down.
And this time. And this time.
Say
say down again.
Okay, moving the whole toe now. Just say up or down this time.
Down.
Or this time.
Up.
This time.
Down.
And on the other side.
1
This
minute
time.
remaining.
Down.
This time.
Down.
And this time.
Down.
Okay, moving the whole toe now. This time.
Down.
This time.
Up.
And this time.
Down.
Okay, you can open your eyes now. I'd just like to see how you walk. Can I ask you just to swing your legs over the edge of the bed for me? Now, taking your time, just stand up. Can you get your balance there?
Yeah.
Yeah? Do you think you'd be able to take just a couple of steps forwards for me? And turn around there. And just a couple of steps backwards. And just turn to face me. Now, can you get your feet slightly closer together? I'll stand here. Now, if you just stand up straight, look straight at the wall, can you close your eyes for me? And open your eyes again. Okay, well done. Can you just sit on the edge of the bed? And then just pop your legs back up. Thank you very much. That completes my examination. To finish this assessment, I would like to examine the cranial nerves and the upper limbs.
Okay, could you present me your findings and also give me your differential diagnosis?
So this patient had evidence of an asymmetrical spastic paraparesis. On closer assessment, there was evidence of hypertonia bilaterally and evidence of clonus at the left ankle. Testing of power showed that both legs were weak, but it predominantly affected the proximal muscles in the left leg. Both sides had brisk reflexes, and plantars were upgoing bilaterally. Coordination was impaired, but I feel this was probably due to weakness more than true incoordination. On assessment of sensation, there was evidence of patchy sensory loss on the left-hand side with pinprick testing. Soft touch was normal, but there was impairment to both vibration and proprioception distally. When I assessed her gait, there was evidence that she was unsteady on her feet and she was a little ataxic. However, we were able to perform Romberg's test, and this showed that it was positive. Putting these things together, it's most likely that she has a myelopathic picture, and when we think about the differential diagnosis of this, it's quite broad. So if this came on quite suddenly, we'd be thinking about vascular causes, things such as spinal infarcts, but the picture doesn't really fit with that. Probably the most common cause of these symptoms would be a disc prolapse. Other differential diagnoses could be inflammatory causes, things such as multiple sclerosis, particularly if there's other features suggestive of multiple sclerosis when you examine the cranial nerves and the upper limbs, or if there's a history of relapsing remitting course. In terms of investigations, given that these are upper motor neuron signs, I feel that the most appropriate examination at this point would be an MR scan of the cervicothoracic cord.
Okay, thanks. You've mentioned multiple sclerosis there and a few other things you'd be on the lookout for in that case. What sort of signs are you talking about?
So I think it'd be very important to examine the eyes. So if there was any evidence of a relative afferent pupillary defect alongside a pale optic disc, those would be in keeping of optic neuropathy. Now, if you were examining eye movements and there was failure of one eye to adduct with nystagmus and abduction of the other eye, then you'd be looking at a lesion within the medial longitudinal fasciculus, indicative of internuclear ophthalmoplegia.
Okay, so you already mentioned doing an MRI scan of the cervicothoracic spine. Are there any other investigations that you think would be helpful?
So when we're considering a diagnosis of multiple sclerosis, one has to consider the presence of lesions in other places in the central nervous system. So it would be useful to do an MR scan of the brain, looking for associated lesions such as periventricular region. The other thing we could do is a lumbar puncture. So we'd be expecting a predominantly normal cell count in a lumbar puncture in multiple sclerosis. However, we would be looking for oligoclonal bands. If they were present, that would be very indicative of MS.
So let's say that this lady does have a diagnosis of multiple sclerosis and she's now come in with an acute deterioration in her walking and she has these signs. How are we going to manage that acute situation?
So I think it would be important in that situation to acknowledge the fact that this is likely to be a relapse of a multiple sclerosis. We treat that with high dose of intravenous corticosteroids such as methylprednisolone. Prior to starting these, we need to make sure that she has a negative urine dip and no signs of infection. There are a few things that we need to warn the patient about. First of all, we need to warn them of the fact that it can affect their sleep. It can cause insomnia. It can cause personality change and even mania. There are a few things that we also need to do, such as monitor the patient's blood glucose, as we expect that to rise whilst they're taking steroids. There's a few more things to discuss, such as the fact that it can cause gastrointestinal ulceration, and very rarely it can cause avascular necrosis of the hip. Okay, thanks very much.
In this station, the candidate has presented a case of asymmetric spastic paraparesis. The examination was performed in a fluent, confident and systematic way. The key areas of inspection, tone, power, reflexes, coordination and sensation were all covered. There was good assessment and analysis of gait. The candidate successfully identified the important upper motor neuron signs. There are a number of important points of technique to bear in mind in order to achieve this. When testing lower limb tone, it's important to perform a slow passive knee bend, followed by a rapid knee bend. This allows you to assess the difference in tone according to the velocity of movement. With spasticity, increased tone is velocity dependent, so the rapid movements make it more obvious. That was the case on this occasion. The candidate also did well to elicit the ankle clonus. This too requires a very rapid movement of dorsiflexion, as clonus is evidence of spasticity. Remember, rigidity is non-velocity dependent, so the speed of movement makes no difference. In this case, the knee reflexes were clearly brisk and both planters were upgoing. Remember to apply firm pressure along the lateral border of the sole and across the balls of the feet in order to check the plantar reflex. When you come across a case where the clinical signs suggest a spastic paraparesis, you'll inevitably have to generate a differential diagnosis. In terms of localization, we'd predict pathology in the spinal cord. It's important to prepare well for this sort of scenario and have a clear strategy in your mind for how you'll express your thoughts. It's very reasonable to talk in broad categories of disease. For instance, you could consider trauma, ischemia, inflammation, infection, neoplasia, as well as metabolic or nutritional disorders. As part of the questioning in this case, we talked about the investigation of MS. This is a relatively common neurological disorder and you should be familiar with it. MRI scanning is the most important investigation. It's obviously critical to scan the symptomatic part of the nervous system. However, in cases of apparently isolated transverse myelitis, which has a relatively broad differential, it can be very informative to scan the brain as well, to look for typical changes of multiple sclerosis. You should be familiar with the role of lumbar puncture in MS, and the fact that the presence of oligoclonal bands can help with prognostication in a clinically isolated syndrome. In terms of treatment, you're not required to have in-depth knowledge of disease-modifying treatments. You should be aware that treatment choices in MS have moved on significantly in the last few years, and that patients will need to see a specialist to assess their options. However, you should certainly be comfortable with the use of high-dose steroids in acute relapse management. It's particularly important to be aware of the risks of high-dose steroids and how to counsel patients in that regard.
Hello, is it Judith Edwards?
It is.
My name's Dr. Maskery. Thank you for letting me examine your arms today. Are you in any pain at all?
No.
Good. So can I get you just to pop your hands out like this for me in front of you, the palms up, and close your eyes. And open your eyes again, turn your hands over and spread your fingers wide and close your eyes again. Open your eyes and relax those arms down. That's good. Next thing I'd like you to do is just take my hand, go nice and relaxed, I'll do all the work. And on this side, nice and relaxed. Good. I want to see how strong you are now, so bring your arms out towards the side like this. Gently push those down. Good. Gently push them up. Bring your arms in front of you like this. Nice and strong. Push me away. Push me away. pull me towards you, pull me towards you. Arms out straight, make a fist. Bring that fist up, bending your wrist back like that, good. Hand on this side, bringing the wrist back. Straighten your fingers out, keep those together, don't let me push those down. Don't let me push those down. Now can you bring your fingers apart? Don't let me push those in. Don't let me push those in. Turning your hands over, thumb up towards the ceiling. Don't let me push that down. Don't let me push that down. Now can you take my hands and squeeze them and pull me towards you? Good. And relax. So the next thing I'd like to do is just to check your reflexes. So if I can just get you to pop your arms, rest them on your lap, and stay nice and relaxed for me. Nice and relaxed. Good. Now, starting with this hand, just with your first finger touch your nose for me. And now my finger, your nose, my finger, your nose, my finger. Good. And on the other side, can we do the same again? Great. Now starting with this hand out flat, I'll just demonstrate it to you. So I want you to clap, but each time turn your hand over and try and go nice and quickly, okay? Good. And on the other side for me. Great. And relax. So now I just want to check your sensation. The first one will be sharp. So if I can just touch this against your chest here. Does it feel sharp there?
It does.
If I can pop your hands on your lap with your palms facing upwards. Good. Does that feel sharp on both sides?
Does.
Each time it feels sharp, say yes for me.
Yes. 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 Yes.
And does it feel the same on both sides?
Yes.
The next one's just soft, so I'll just press it here. Can you feel that there okay?
Yes.
Just say yes each time you feel it.
Yes. 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 Yes.
Thank you. This one's just testing for vibration. So I'll put this here. Can you feel that vibrating?
Okay.
Okay. So now in the hands, if you just turn your hands over for me. What I want to do is, if you just hold your hand there, I want you to tell me when you can feel the vibration start and stop, okay?
Yes.
Has it stopped?
Yes.
Good. Close your eyes for me. Just place that there. You feel it vibrating?
Yes.
Good. So close your eyes, tell me when it starts
Yes.
and when it stops.
Yes.
And on the other side, tell me when it starts, close your eyes,
Yes.
and when it stops.
Yes.
Relax your hand down. Now finally what I want to do is just check if you can see where your joints are. So if you look at your hand for me, this is up and this is down. So if you can just close your eyes and say up or down.
Up. Down. Down.
And on the other side, keep those eyes closed.
Up. Up. Down.
That's great, thank you very much. That completes my examination. To finish my assessment, I would like to examine the cranial nerves, the lower limbs, and make an assessment of gait. Could you present your findings and give me your differential diagnosis? Of course. So this patient had findings in keeping with an ataxic syndrome. On general inspection, I noticed that she had a truncal ataxia, and there was evidence of an intermittent head tremor as well. On closer inspection, I noticed that as I was introducing myself, she had evidence of a scanning or staccato speech. She was hypotonic as well, although power was preserved throughout. Her reflexes were normal and symmetrical, and her sensation was intact in all four modalities as well. When I assessed her coordination, I noticed when checking for dysdiadochokinesis that she had clumsy movements, and when I checked for past pointing in the finger-nose test, she did pass point and she had some intention tremor present as well. When I put all this together, it fits with a cerebellar syndrome of ataxia. Thinking about the potential causes of cerebellar ataxia, we'd have to group them together based upon how they came on and how the symptoms evolved. If it was something that came on acutely, I'd be thinking about stroke, either ischemic or hemorrhagic. If with a detailed history you found that these symptoms were relapsing and remitting, then you'd think about multiple sclerosis, which can affect the cerebellum. A detailed social history would be required to look for risk factors such as alcohol consumption, which can commonly present with these symptoms. Of course, there are rarer causes of cerebellar syndrome, such as genetic or paraneoplastic causes of cerebellar degeneration. Thinking about how we investigate specifically, though, we'd have to consider MR imaging, which is far superior to CT when imaging the posterior fossa.
Okay, you mentioned cerebellar ataxia. Are there any other physical signs you'd be particularly interested in trying to elicit?
Absolutely. So I'd like to look closely at the eyes. I'd be looking for any evidence of nystagmus, and when checking for pursuit movements, I'd expect those to be jerky as well. You could also ask her to repeat some phrases to check her speech, things such as 42 West Register Street, or even baby hippopotamus.
Okay, what sort of considerations would you have when managing a patient with an ataxic syndrome like this?
So I think management should be based upon the actual underlying etiology of the cerebellar syndrome. But more broadly speaking, we should think about the multidisciplinary team approach to helping the patient retain their function and independence. For example, we could ask for physiotherapy to review the patient regularly to help with their mobility and to give them exercises to preserve their strength. We'd also need to involve the occupational therapists to see what kind of adaptations we need to make at the home, and also do we need to provide them with any mobility aids to help with their independence.
Thanks. In addition to those sorts of management steps, what sort of lifestyle advice could you give to the patient?
So I think that's really important. So firstly, we could look at the patient's occupation. We need to assess whether they're at any risk whilst they're at work and see if there's any adaptations we can make to their workplace to help them continue with their occupation. The second thing to do is to look more broadly at their medical history, particularly looking at their medications. Are there any medications that they're taking which could contribute to affecting the cerebellum or exacerbate any causes of dizziness or unsteadiness? The other thing to think about is, although the alcohol may not be the cause of their cerebellar syndrome, it is known to exacerbate these, so we should advise the patient to reduce their amount of alcohol consumption or stop this altogether.
Great, thank you very much. This candidate presented a case of ataxia. The neurological examination was performed in a confident, fluent and well-structured manner. All the key elements were covered in terms of inspection, tone, power, reflexes and coordination. In addition, he noticed some subtle signs outside the upper limb exam. He correctly noted an ataxic pattern of speech, also known as scanning dysarthria, and a titubating head tremor. When performing the neurological examination, it's really important to give clear instructions to the patient, and the candidate did a very good job in this case. The sensory examination was performed very nicely, and the candidate made sure to test 4 modalities. Once again, clear instructions were given to the patient throughout. Pinprick and light touch were checked in a dermatomal manner, which is entirely appropriate. Remember, if you suspect a peripheral neuropathy, it's a good idea to also look for a glove distribution of sensory loss to these modalities. If the patient had demonstrated impaired vibration sense distally, it would have been necessary to move more proximally, joint by joint, until it could be felt normally. The same is true for joint position sense. Ataxia is a potentially tricky case in PACES. In this situation, the candidate correctly identified that the signs indicated a cerebellar cause. When you have a patient with ataxia, the decision you have to make is whether it's cerebellar or sensory. The presence of unsteadiness and clumsy upper limb movements do not help you make this distinction. Cerebellar ataxia will usually be accompanied by nystagmus and dysarthria. Sensory ataxia will be associated with impaired sensation, especially for the modalities of joint position and vibration. With sensory ataxia, there are some additional signs to look for in the upper limbs. Pseudoathetosis is an involuntary writhing movement of the fingers and hands with arms outstretched and eyes closed. It shows that the limbs are deafferented. In addition, the patient with sensory ataxia in the upper limbs will be able to perform finger-nose testing with the eyes open, but would struggle with the eyes closed. In short, remember that patients with cerebellar ataxia will usually have eye signs and dysarthria. Patients with sensory ataxia will have impaired joint position sense and vibration. With sensory ataxia, all the problems are made worse by removing the patient's visual input. This is readily elicited at the bedside examination. Don't forget, if you identify a case of sensory ataxia, you need to decide if the cause is central or peripheral. Central causes are usually due to spinal cord pathology, typically dorsal column damage. Peripheral causes are due to neuropathy, with the large myelinated sensory fibres most obviously affected. Occasionally, sensory ataxia can be due to both central and peripheral nervous system damage. The best known example of that is B12 deficiency. One final thought on cerebellar ataxia. The cause is usually evident from the history, and clearly the cadence of onset is critical. Investigations will be guided by the history, but all patients with cerebellar ataxia will require brain imaging. MRI is far superior to CT for looking at this area, but CT has an important role to play in hyperacute presentations when hemorrhage needs to be rapidly excluded.
Hello there. Is it Judith Edwards?
It is.
Thank you very much for letting me examine your legs. Are you in any pain at all?
No.
Good. I'm just going to have a look at your legs to begin with. Okay. Now what I'd like you to do is be as relaxed as possible. Just going to move your legs. Good. Now I want to see how strong you are. So keeping this leg nice and straight, lift it up off the bed for me. Don't let me push it down. Good. And this leg straight up. Don't let me push it down. And relax. Push down into the bed. Down, down, down. And down into bed. Good. And bend this knee for me. So pull me towards you and push away. Good. Bend this knee, pull me towards you and push away. Good. Now what I want you to do is bring this foot up towards you by bending your ankle. Good. And this one up towards you. Good. Just the big toe this time. And this side. Good. And push away. Excellent, thank you. So next I'd just like to check your reflexes. So again, stay nice and relaxed for me. Let me take all the weight. Good. Just bending this knee in. Okay, what I'd like you to do is just bring your hands together like this for me. So keep them nice and relaxed for now. I'll ask you to pull together. When I say pull, pull and hold, okay? Pull. Bending this one. And put your hands together. When I say pull, pull. So I'm just going to run this along the bottom of your feet now. You stay relaxed. Now, can I get you to pop this heel on this shin for me? Run it down the leg, take it off, and back up to your shin, and keep moving it down, up. That's good. And can we do the same on the other side? So this heel against this shin, and along. That's good. And relax your legs down. So I'm just going to check your sensation in your legs now. If I can just touch this against your chest, does that feel sharp?
Yes.
Okay. Roll these up slightly. Thank you. Can you feel that on both sides?
Yes.
And does it feel sharp?
It does.
What I want you to do is say yes each time it feels sharp on your legs.
Yes. 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 Yes.
And this time, can you feel it here?
Yes.
I want you to tell me if it changes as I move up your leg. Does it feel the same all the way up?
Yes.
It's sharp at the bottom and at the top?
Yes.
And on the other side now.
Yes.
Does it feel the same?
Yes.
Thank you very much. This time it's a little bit softer. I'll just press this here. Can you feel that?
I can.
Does it feel the same on both sides?
Yes.
Say yes each time you feel it.
Yes. 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 Yes.
And this time we'll be checking for vibration. So if I just press this here, can you feel that vibrating?
I can.
Okay. So I'm going to do that on your toe now. I want you to tell me when you can feel it vibrating and when you feel it stop. Okay. So I'm going to get you to close your eyes for me. Tell me when you feel it vibrating.
Yes. Yes.
Keep those eyes closed.
Yes. Yes.
Thank you. And just looking at your feet now. So if I move the toe up or down, so I want you to close your eyes and just say up or down.
Up. Up. Down.
And on the other side.
1 minute remaining.
Up. Down.
Okay. Now, I'd like to see you walk if that's okay. Can I just get you to swing your legs over the side of the bed? You manage. Now, are you able to stand up from there? Take your time. Well done. Just get your balance. Okay. Now, would it be possible just to see you take a couple of steps? Okay. Will you stop there and just turn around? Good. Are you able to put your feet together?
I'm sorry, I can't do that.
That's okay. Let's just get you sat back on the bed then. And bring your legs back on. Thank you. That completes my examination. So to finish my assessment, I would like to examine the cranial nerves and the upper limbs.
Okay, could you present your findings to me and also give me your differential diagnosis?
So this patient has features of an ataxic syndrome. On general examination, I noticed that she had a truncal ataxia and there was also evidence of an intermittent head tremor. When I was introducing myself, I noticed that she had a staccato or scanning speech. When I looked more closely at the legs, her tone was actually normal, her power was normal, and the reflexes were present in the knee, and with the Gendrasic manoeuvre, or potentiation in the ankles, they were present as well. Planters were down going. When I was checking for coordination, I noticed that she had clumsy movements and evidence of ataxia when she was doing the heel to shin test. However, sensation was normal in all four modalities that I tested. So when I examined her gait, I noticed that she was very unsteady when getting to her feet, but was able to stand with an ataxic posture on 2 feet with a broad-based stance. When I examined her walking, again, she was broad-based and unsteady. When I asked her to stand with her feet together, she was unable to do this, and so I was not able to check for Romberg's sign. So in terms of what caused this syndrome, well, we'd need to think about how the symptoms have evolved. If these have come on acutely, then we need to think about stroke, either ischemic or hemorrhagic in nature. If when looking at their history there's evidence that this has relapsed and remitted over a period of time, then we need to consider multiple sclerosis affecting the cerebellum. A detailed social history is an important part of this examination, and as we might be able to identify risk factors such as excessive alcohol consumption. There are rarer causes of cerebellar syndrome such as genetic or paraneoplastic cerebellar degeneration. Either way, in terms of investigation, we'd need to do some imaging of the cerebellum, and MRI is far superior to CT when looking at the posterior fossa.
Okay, thanks. So you've presented this as a case of cerebellar ataxia. How can you be confident that this isn't in fact sensory ataxia?
So I think there's a few features which would help me to confirm that it is cerebellar ataxia. First of all, when we examine her speech, there's evidence of scanning or staccato speech, which we wouldn't expect in a sensory cerebellar syndrome. Also, when we examine her sensation in her legs, all 4 modalities were intact. Although I wasn't able to perform Romberg's sign, she was clearly ataxic, even just standing up, and so I don't think that this would change my diagnosis.
Okay, now when we think about the management of patients with ataxic syndromes, what are some of the important considerations to bear in mind?
So importantly, we need to address the underlying etiology and see if there's any reversible factors there. But thinking in a more broader sense, we'd need to involve the multidisciplinary team to help improve the patient's and retain the patient's function and independence. We can involve a physiotherapist to help with mobility, seeing if the patient needs any walking aids, and helping the patient in terms of exercises to preserve strength. We could also ask for an occupational therapy review to see if there's any adaptations to the workplace or to home in order to help retain their independence. In addition to those sorts of management strategies, are there any forms of lifestyle advice that you could give to this patient? So I think there's a few factors in lifestyle in which we could offer to patients in this setting. First of all, we could look at their occupation. We'd need to see if there's any risk associated with their occupation and how we can minimise this to help the patient retain their independence. We'd also look at their general medical history as well, particularly at the medications they're taking. Are any of the medications exacerbating or influencing things such as unsteadiness or dizziness? A further point would be looking at a social history, looking at the alcohol consumption of the patient. It might be that this cerebellar syndrome has not been caused by alcohol intake itself. However, we know that excessive consumption can exacerbate cerebellar syndromes, and therefore we'd advise them to reduce the amount of alcohol that they drink. Okay, thanks very much.
This candidate presented a case of ataxia. The neurologic examination was performed in a confident, fluent and well-structured manner. All the key elements were covered in terms of inspection, tone, power, reflexes, coordination and gait. In addition, he noticed some subtle signs outside of the lower limb exam. He correctly noted an ataxic pattern of speech, also known as scanning dysarthria, and the titubating head tremor. When performing the neurologic examination, it's really important to give clear instructions to the patient, and the candidate did a very good job in this case. He also sensibly asked what the patient was able to do in terms of gait and was careful to ensure her safety. The patient clearly had an ataxic gait, so it was unnecessary to ask her to attempt heel-toe walking. In patients whose gait appears initially normal, it is good practice to get them to walk along a line, as it can provide evidence of subtle midline gait ataxia. The candidate did a good job of testing the reflexes and noted that the ankle jerks were suppressed, so used reinforcement to bring them out. If the patient had demonstrated impaired vibration sense distally, it would have been necessary to move proximally joint by joint until it could be felt normally. The same is true for joint position sense. Ataxia is a potentially tricky case in PACEs. In this situation, the candidate correctly identified that the signs indicated a cerebellar cause. When you have a patient with ataxia, the decision you have to make is whether it's cerebellar or sensory. The presence of gait unsteadiness and clumsy lower limb movements don't help you make this distinction. Cerebellar ataxia will usually be accompanied by nystagmus and dysarthria. Sensory ataxia will be associated with impaired sensation, especially for the modalities of joint position and vibration. With sensory ataxia, there are some additional signs to look for on lower limb examination. When assessing gait, look to see if the patient has to look where they're putting their feet. Romberg's test involves getting a patient to stand still with their feet together and then close their eyes. In sensory ataxia, the patient sways once the eyes are shut. In addition, the patient with sensory ataxia may struggle to perform heel-shin movements with eyes closed. In short, remember that patients with cerebellar ataxia will usually have eye signs and dysarthria. Patients with sensory ataxia will have impaired joint position and vibration. With sensory ataxia, all the problems are made worse by removing the patient's visual input. This is readily elicited at the bedside examination. Don't forget, if you do identify a case of sensory ataxia, you need to decide if the cause is central or peripheral. Central causes are usually due to spinal cord pathology, typically dorsal column damage. Peripheral causes are due to neuropathy, with the large myelinated sensory fibres most obviously affected. Occasionally, sensory ataxia can be due to both central and peripheral nervous system damage. The best known example of this is a B12 deficiency. One final thought on cerebellar ataxia. The cause is usually evident from the history, and clearly the cadence of onset is critical. Investigations will be guided by the history, but all patients with cerebellar ataxia will require brain imaging. MRI is far superior to CT for looking at this area, but CT still has an important role to play in hyperacute presentations when hemorrhage needs to be rapidly excluded.
Hello there, is it Mr. Leon?
It is, yeah.
My name's Gavin Britton. I'm one of
Nice to
the
meet you.
medical doctors. I've been asked today to have a look at your arms in terms of how they move and the strength.
Right.
Would that be alright?
Yeah, that'd be fine.
Do you have any pain or stiffness in your arms?
No.
If you just rest your arms down onto your lap, I'm just going to have a quick look at them first. If you just turn your arms over for me. Okay, and if you can pop your arms out straight like this for me. And then close your eyes. Okay, open your eyes and turn your hands over for me. And then close your eyes. That's okay. Rest your arms down for me. I'm going to take your hands now. You just relax and I'm just going to move them around. So you just relax. Okay, rest that one down. Again, I'm going to do this one. I'll do all the moving. Okay. I'm going to check how strong your arms are now. If you can pop your arms up like this for me. Don't let me push the arms down. I'm going to try and... Okay, and this side. Okay. You can bring your arms in to the middle. Don't let me pull them out. Okay, and don't let me pull them out. Okay. If you can bring your arms out in front of you like this and push me away. Okay, and push me away. Okay, and pull me towards you. Yep. And this one, pull me towards you. That's it. Put your arms out like this for me and cock your wrists back. Don't let me push your hands down. Okay, don't let me push your hands down. Okay, if you can spread your fingers out for me like that and just keep them together first off. If you just put your fingers together, yeah. Don't let me push them down. Don't let me push them down. You can spread your fingers out. So I'm just going to push them in now, so if you keep them all nice and strong. That's it. And this side. That's it. And this side. And this one. Brilliant, thank you. If you can turn your hands over. Thumbs towards the ceiling for me. Don't let me push your thumb down. Don't let me push your thumb down. Okay. If I can grip this hand, like that, yep. Don't let me pull my hand out. Okay. And this one, again, don't let me pull my hand out. Okay. That's okay, that's fine. I'm going to check your reflexes now, so if you just relax down for me. Okay. I'll just check this side. Okay. And just relax. That's it. I'm just going to pop that arm across there. Okay, and relax that one. I'll borrow this one. What I'd like to do now is test your coordination. So with this finger, if you can touch your nose, touch my finger. That's it, and touch your nose, touch my finger. That's it. Can we try this one? Touch your nose, touch my finger, your nose, my finger. That's it. With this hand, if you can put it into the palm of your other hand, turn your right hand over, and then turn it back, and then go as fast as we can. Okay, thank you. If we, with the left hand, if we put it into the palm of the right one, turn it over, and then go as fast as we can. That's brilliant, thank you. I'm going to check your ability to feel things now. I'll start off with this cotton wool. I'll show you what it feels like in the middle. Can you feel that?
Yes.
If you can turn your hands over for me and just put them into your lap. Can you feel that?
Yes.
And that? Does it feel the same as in the middle?
It feels the same.
Just let me know if you can feel it on both
I feel
sides.
it,
Yeah?
yeah. They all feel the same.
Yeah.
Yeah.
All feel the same.
Yeah.
I'm going to do the same, but I'm going to run up your hand now. Let me know if the feeling changes.
That feels the same. Same.
Okay. We'll do the same thing again, but with a pin prick. This won't break the skin, but I'll show you what it feels like. Does that feel sharp?
Yeah.
Sharp?
Yep.
Sharp. Same on both sides
Yes.
and same as in the middle.
Yes,
Again, let me know. You feel them on both sides?
Yeah. About the same, yeah.
Yeah. Same on both sides?
The same.
Same on both sides. Again?
Yeah.
Same on both sides?
All the same, yeah.
Good. Going to run up the hands now. Let me know if it changes.
No, about the same. Yeah,
About the same?
Yeah.
Good. This is a tuning
1
fork, so
minute
it vibrates.
remaining.
I'll show you what it feels like in the middle. Can you feel that?
Yeah.
Can you feel it here on your finger?
I can, yes.
Close your eyes and let me know when it stops.
It stops.
Okay, we'll just try the other side. Can you feel that?
I can.
Close your eyes and let me know when it stops.
It stops.
Okay, good. What I'd like to do lastly is if I can take this hand, I'm going to move your finger down or up. I'd like you to close your eyes and tell me if it's down or up.
Down. Down. Up.
Okay, and the other side.
Down. Down. That's up.
Good. Thank you very much.
Thank you.
To complete my examination, I'd like to assess this patient's cranial nerves, lower limb examination including gait.
Thank you. Could you present the case to me, please?
This patient has possible motor neuron disease. On examination, there were widespread fasciculations, and there was global wasting on examination. This was most pronounced in the first dorsal interosseous muscle. On examination of this patient's power, power was reduced, more so approximately on the right side, and distally it was reduced bilaterally. Tone was normal in this case, and reflexes were present. Importantly, sensation was normal, and I didn't detect any bulbar dysarthria whilst I was examining him. Given on examination, I found a primarily lower motor pattern, and I haven't seen any upper motor disease processes currently. I would like to make sure I complete the examination, as this may aid in my differentials. My primary differential will be that of motor neuron disease. Other differentials, given that I've only found the lower motor pattern, would be rarer causes of motor neuron disease, such as spinal muscular atrophy and Kennedy's disease. Another important differential would be that of multifocal motor neuropathy with conduction block, as this is treatable. To investigate this gentleman, I would primarily like to start off with doing neurophysiology. On EMG, I'd be looking for fibrillations and fasciculations, and an absence of sensory signs. In terms of multifocal motor neuropathy, I may expect to find demyelinating features and a conduction block. Given that this case isn't entirely straightforward, I would want to proceed with structural imaging in the form of an MRI scan.
Okay. Given some of the uncertainties that you've mentioned, what features in the history might help us distinguish amongst these conditions that you've been talking about?
So on the history, if I was thinking that this was motor neuron disease, I might be expecting an asymmetrical disease process, which is rapid and quite aggressive in its disease course. I might be looking out for signs and symptoms of behavioural or cognitive dysfunction that might fit with frontotemporal dementia, and that might be more suggestive of motor neuron disease. If I was thinking this was multifocal motor neuropathy with conduction block, I would be looking out for a more pronounced distal weakness early on in the disease process, and the patient may complain of clumsiness. I'd also want to check this patient's family history. There are familial causes of motor neuron disease, and I would also want to be asking about other family members, as they could potentially be Kennedy's disease.
Okay. Assume that the diagnosis is in fact motor neuron disease or amyotrophic lateral sclerosis, and what key management steps do you know of?
So first off, I'd want to refer this patient to a treatments available are largely supportive and consist of a multidisciplinary team approach. This patient might benefit from assessments by the physios and occupational therapists, as they may be able to provide support and adaptations in the home and workplace. I'd want to perform some regular screening of this patient. So first off, I'd want to screen their weight, appetite and swallowing. And with the speech and language team, we might want to consider non-oral feeding in the form of a peg tube, and we might also want to consider communication aids as well. I'd want to consider screening this patient's respiratory function. I'd do an early morning blood gas and do an FVC as well. Patients with motor neuron disease can develop problems with type 2 respiratory failure and may need to go on to needing NIV, especially at night. Other devices that might be available to this patient might be things like cough assist devices that can provide some support. The last thing I'd want to screen for are cognitive and behavioural changes that might be suggestive of frontotemporal dementia.
Okay, thank you very much.
Thank you.
The candidate was asked to examine the upper limbs of a patient who had developed increasing weakness of the arms. He presented a case of possible motor neuron disease, also known as amyotrophic lateral sclerosis. The upper limb examination was performed well in a fluent, efficient and professional manner. The candidate gave clear instructions to the patient throughout. He followed the recommended examination routine of inspection, tone, power, reflexes, coordination, and checked 4 different sensory modalities. Inspection was particularly important in this case, as it revealed the key findings of muscle wasting and fasciculation. It's perhaps not surprising, given the inspection findings, that weakness was detected. The pattern was somewhat asymmetric, with proximal power affected more on the right side, but distal power reduced equally in those distal muscle groups. Whenever you detect the combination of weakness, wasting and fasciculations, the first diagnosis that springs to mind is likely to be motor neuron disease, also known as amyotrophic lateral sclerosis or ALS. That's entirely reasonable, as whilst it's a relatively rare condition, it's a very serious disease. Remember, however, the clinical diagnosis of ALS rests on the presence of combined upper motor neuron and lower motor neuron signs. In this case, there was clear evidence of lower motor neuron findings, the wasting and fasciculations, but there was no evidence of upper motor neuron signs. In particular, there was no hypertonia and no especially brisk reflexes. However, one might suggest that given the fairly widespread lower motor neuron signs, the presence of any retained reflexes is a bit unusual. In addition to mixed upper and lower motor neuron signs, the clinical diagnosis rests on demonstrating the abnormalities in multiple neurological segments. Specifically, we look for changes in the bulbar segment, cervical segment, thoracic and lumbosacral segments. Because of this, it would be especially important to complete the neurological examination and assess cranial nerves, lower limbs, and look at the paraspinal muscles. In terms of history, we would expect patients with ALS to have progressive weakness. The onset can be bulbar or in the limbs. It's often asymmetric. Lots of patients get cramp, but true sensory symptoms are not a feature of this condition. Remember also to consider changes in behaviour and cognition. A significant proportion of patients with ALS have comorbid frontotemporal dementia. Family history is important, as some cases of ALS are familial, associated predominantly with the C9orf72 hexanucleotide repeat expansion. Other, rarer motor neuron diseases can be genetic, such as X-linked spinobulbar muscular atrophy or Kennedy's disease. The treatment of ALS and other motor system degenerations should be patient-centred and involves an entire multidisciplinary team. Drug treatment with riluzole has been shown to improve survival, although the benefits are relatively modest. Perhaps a more practical use is the input of the specialist nurses, OTs and physios. A major part of management involves regular screening for complications, specifically regular speech and language input to help with communication, but also, with dietitian support, to look for whether PEG feeding might be needed. Respiratory function has to be monitored, as symptoms of neuromuscular ventilatory failure can be ameliorated with non-invasive ventilation.
Hello there. Is
Hi.
it Miss Whitfield?
Miss Whitfield, yeah.
My name's Gavin Britton. I'm one of the medical doctors. I've been asked today to have a look at your legs, if that's all right.
Okay.
Is there any pain or stiffness in your legs or back?
Not at the moment, no.
Okay, I'm going to start by having a look at them, if that's okay.
Okay.
Okay, what I'd like to do next is see you walking, so if I can ask you just to slip over to that side of the bed for me.
Okay.
And then when you're ready, stand up. I'll just get your stick for you.
All right.
And if you could just walk towards the wall for me. And then turn around and come back. And I'll just stop you there.
Okay.
And if we can turn to face this wall.
All right.
Shuffle, yeah, just so you're just near the bed there. I would like you to, if I take the stick off you, yeah.
Okay, just pop that there then. Yeah.
Thank you. And put your legs together. I've got you if you do fall, but if you close your eyes for me. Okay, we'll stop there.
Okay.
That's okay. Thank you. If you just have another seat for me. Okay, I'm just going to have a look at your legs now and just move them from side to side. Okay. I'm just going to have a look at your ankles now. Okay. I'll just have a look at this side. Okay, thank you. And then we'll check how strong your legs are now. So if we start with this leg, if you just lift it up off the bed for me, don't let me push it down. Okay, and then on this side, again, don't let me push it down. Okay. Don't let me lift it up off the bed, so you push down. That's fine. Don't let me lift it off the bed. Okay. Could you bend your leg at the knee for me? And then push away for me. That's it. And then pull in towards your bottom. That's it, okay. And on this side, if you could bend at the knee and push out, and then pull in. That's okay. Push down as if you're pushing on a car pedal. And on this side, back up the opposite way. That's it, back up the opposite way. That's it. Big toe up towards your head. That's it. Big toe up towards your head. That's it, that's okay.
Okay.
I'm just going to check your reflexes now. I'm just going to give them a gentle tap on your knees and your ankles, okay? So you just relax your leg for me. And on this side. And then we'll have a look at your ankles next. Just going to move this leg out. Okay. And then this one up. Okay. I'm just going to give you the bottom of your foot a gentle scratch with this stick. And on this side. Okay. Okay, what I'd like to do now is check your coordination in your legs. So with this heel, if you could pop it on this knee, run it down your leg towards your ankle and lift it off, back to your knee, and then back down again. That's okay. And then if we swap legs, so this heel onto your knee, down your shin, lift it off, back to your knee and down again.
Okay.
Okay, that's good. What I'm going to do now is check the feeling in your legs.
Right.
I'm going to start off with this cotton wool. If I could just show you in the middle what it feels like. Can you feel that?
Yes.
Okay. Can you feel that?
Yes.
Can you feel that?
Yes.
Does it feel the same as up there?
Yes.
And the same on both sides? Can you feel there and there?
Yes.
Again, same on both sides?
Yep.
Good. You feel here and here?
Yes.
Here and here?
Yes.
Here and here?
Yes.
Okay. I'm going to run the cotton wool up your leg now, so tell me if the feeling changes at all.
No, that stayed the same all the way up.
Okay, and then this side?
Again, that's the same all the way up.
Okay. I'm going to do a similar thing now, but with a pin.
Okay.
It won't break the skin. I'll show you again in the middle. You feel that?
Yeah.
Okay. Can you feel that?
Yes.
Can you feel that?
Yes.
Does it feel the same on both sides?
It does, yes.
Does it feel the
And
same?
same here, yeah.
Can you feel that and that?
Yes.
Does it feel the same on both sides?
It actually feels sharper on that side.
So it's sharper on this side?
Definitely sharper.
And what about compared to up here?
Compared to there, yeah.
So it's sharper than up
Than there,
than
yeah.
there, and sharper than this side as well?
Yeah, so it all feels sharp, but it's more sharp that side, yeah.
Fine, okay. Here and here?
Yeah, again, it feels sharper that side.
Okay. Here and here?
1 minute remaining.
Again, same.
Here and here.
Yeah, it definitely feels sharper at
Okay.
that side.
I'm going to run this up again. Tell me if the feeling changes at all.
It's very sharp all the way up.
And there?
Yeah, that's the same all the way up, but it's not still not as sharp as that side.
Okay. Fine. The next one we're going to do is with this tuning fork, so
Yeah,
it should
sure.
vibrate. Can you feel that?
Yes.
Okay. Can you feel it there?
Yeah.
If you close your eyes and tell me when it stops.
Stop.
Okay, and again on the other side. Can you feel that?
Yes.
Tell me when it stops.
Stop.
Okay. The last thing we're going to do is have a look at your toes now. So if you have a look at what I'm doing, I'm going to point it down or up. If you
Okay.
close your eyes and tell me which way it is.
That's down. Down. Up.
Okay, and the other side.
Down. Down. Up.
Okay. Thank you very much.
Oh, you're welcome.
To complete my examination, I'd like to assess this lady's upper limbs and cranial nerves.
Thank you. Could you present the case to me, please?
This lady had an asymmetric spastic paraparesis. On examination, she had an ataxic gait that was broad-based, and she did use a stick. She was Romberg's positive. On further examination of her lower limbs, there was increased tone bilaterally, more so on the right compared to the left, with sustained clonus in the right leg. Reflexes were brisk bilaterally, but more so on the right compared to the left, with an upgoing plantar on the right side. Power was reduced in both legs at hip flexion and knee flexion, but otherwise well preserved. Sensation showed a hyperesthesia in the left leg to pinprick, but other sensory modalities were preserved. These findings were in keeping with a partial Brown-Séquard syndrome, and to further assess this lady, I would want to perform an upper limb and cranial nerve examination, as well as check for a sensory level. The differential diagnosis for this myelopathy in this lady can be split into a number of different categories. I'd firstly like to consider compressive causes, such as disc herniation, tumours, whether that's intramedullary or extramedullary, and whether they're primary or secondary in terms of metastasis. And I'd also want to consider spinal stenosis in that category as well. Second category I'd like to consider are autoimmune causes, such as multiple sclerosis, and lupus and sarcoid would also fit into that category. The third category I'd want to consider are infectious causes. Such examples could be HIV or varicella. After that, I'd want to consider the nutritional category, and I'd be putting vitamin deficiencies, such as B12 in that category, as well as copper deficiency. Lastly, I'd want to consider rarer diseases that can be genetic, such as hereditary spastic paraparesis. To assess this lady further, I would want to perform an MRI scan, and the urgency of that would be guided by further examination and my history.
Okay. You mentioned wanting to complete the full neurological examination. If this was going to be a cervical myelopathy, what signs would you expect to find?
So firstly, I'd expect to find a completely normal cranial nerve examination. When assessing her upper limbs, I might expect to find increased tone, reduced power, brisk reflexes, and potentially find a sensory level in the cervical region.
Okay, let's turn now to the history. What features in the history are particularly helpful when trying to determine the etiology of someone's myelopathy?
So first off, I'd want to establish the onset and any progression of this disease. If this condition occurred over minutes, I might be thinking of vascular causes. If this was still acute but occurred over a day or so, I might be wanting to consider other causes such as trauma or disc herniation. If this was subacute, as in over days to potentially weeks, I might want to consider my autoimmune causes such as demyelination and lupus. If this occurred over weeks to months, I would be thinking about nutritional deficiencies or a slow-growing tumour. If this occurred over a more chronic time period, so months to years, I might be thinking about my genetic causes. Further elements of the history I'd want to obtain would be to inquire about any previous episodes of neurological dysfunction that might lead me to thinking that this was caused by demyelination. I'd also want a full systems inquiry to rule in or out my autoimmune causes, and I'd also want to be screening for malignancies and underlying cause. Lastly, in my history, I'd want to be taking this patient's family history.
Okay, thank you very much.
Thank you.
In this case, the candidate was asked to examine the lower limbs. He presented a case of asymmetric spastic paraparesis, and, as is often the case, it wasn't possible to infer the etiology from just this examination. The lower limb exam was performed well. It was fluent, professional, and all the important elements were covered. As is customary in the lower limb station for PACES, the candidate checked tone, power, reflexes, coordination, and 4 sensory modalities, as well as performing a gait assessment. The candidate detected the slightly unsteady and broad-based gait, so wisely didn't attempt to do tandem gait. Romberg's test was checked, and in this case it was positive. The increased tone, ankle clonus, brisk reflexes and mild weakness all helped to define a spastic paraparesis. The findings were asymmetric, and the upper motor neuron signs were more apparent on the right. The sensory findings were very subtle, and all that could be detected was a relative hyperesthesia in the left leg. This combination of pyramidal signs prominent on one side and spinothalamic dysfunction on the contralateral side mean that this could reasonably be presented as a partial Brown-Séquard syndrome. In any event, these signs are highly suggestive of myelopathy or, in other words, spinal cord dysfunction. From this examination of just the lower limbs, we cannot accurately localise the level of the myelopathy. As the candidate correctly pointed out, it's necessary to examine the upper limbs and cranial nerves to localise the lesion. One would also look for evidence of a sensory level on the trunk. The reason for completing the neurologic examination is really twofold. Primarily, you need the information from the upper limb exam to work out the level of the lesion, but you also want to look for signs of other neurological lesions that might hint at a multifocal disease process, such as MS. So, for instance, if this patient also had evidence of pale optic disc and a relative afferent pupillary defect, one could say that the combination of an optic neuropathy and a partial myelopathy would be highly suggestive of multiple sclerosis. This is another one of those situations where it's only really possible to come up with a syndromic diagnosis and then offer a differential for underlying causes. The candidate did an excellent job here and provided a highly structured approach to this differential diagnosis. The candidate was also able to explain how they would use key points in the history to narrow down the broad differential. When you detect signs of a myelopathy, perhaps the most critical investigation is going to be an MRI scan of the spine. Your clinical localization from the full neuro exam will guide precisely which segment needs to be scanned. The urgency with which the scan is arranged is determined by how quickly the patient's symptoms have come on and the severity of the signs. In acute onset or rapidly progressive syndromes, the patient should have same-day MRI. In this instance, we're looking to exclude acute compression that may need urgent surgery, or metastatic disease that could require same-day radiotherapy. In many slowly progressing or static cases, the scan can be arranged as an outpatient.
Hello there, is it Mr. Johnson?
Yeah.
My name's Gavin Britton, I'm one of the medical doctors. I've been asked today to have a look at your legs in terms of their power and how they move. Is that alright?
Yeah, that's fine, yeah.
Do you have any pain or stiffness in your back or legs?
No.
Okay, fine. I'm just going to have a look at them first, if that's okay.
Yeah, fine.
Okay, and to get things started, what I'd like to do is have a look at you walking, if that's alright. So if I can just ask you... Hello there, is it Mr. Johnson?
Yeah.
My name's Gavin Britton, I'm one of the medical doctors. I've been asked today to have a look at your legs in terms of their power and how they move. Is that alright?
Yeah, that's fine, yeah.
Do you have any pain or stiffness in your back or legs?
No.
Okay, fine. I'm just going to have a look at them first, if that's okay.
Yeah, fine.
Okay, and to get things started, what I'd like to do is have a look at you walking, if that's alright. So if I can just ask you to move over to that side of the bed for me.
Yes.
And if you just jump up off the couch for me and just head towards that wall for me. That's brilliant. And if you come back, turn around and come back heel to toe for me. Okay, okay, and just stop there. Yeah, and if you just turn that way and put your feet together for me and then close your eyes for me. That's okay. And if you want to jump back onto the bed for me. So So I'm going to have a look at how your legs move now. So I'm just going to move them from side to side.
Yes.
Okay, and same with your ankle. That's okay. I'm going to check how strong your legs are now. If you can lift this leg up towards the ceiling for me. That's okay. And this one?
Yeah.
That's okay. Down into the bed for me. That's okay. Down into the bed. That's okay. Can you bend this leg at the knee for me? And push out. And pull in towards your bottom. That's it. And relax this leg. And the same with this one. Push out for me. That's it. And pull in. That's brilliant. Push down as if you're pushing on a car pedal. This one. And then the opposite way back up towards your head. And the opposite way back up towards your head. And then big toe up towards your head. Big toe up towards your head. That's okay. I'm going to check your reflexes now and just give them a gentle tap if that's all right.
Yes.
Just relax your legs for me. With your hands, if you can just do this for me and then pull when I ask you to. If you pull and relax for me. And if you pull again, that's okay. And just relax. Give them a pull again. Okay. And relax. And give them a pull again. That's okay. I'm just going to gently touch the bottom of your foot with this stick now.
Yeah.
Okay. And again on this side. Okay, it's fine. And then I'd like to check your coordination of your legs. So what I'd like you to do is with this heel, if you can put it onto your knee, slide it down your shin towards your ankle, lift it off, and back towards you. Yeah, if you keep going for me. And then can you swap sides for me? So this heel onto that knee. Yeah, that's fine. That's okay. I'm going to check your feeling in your legs now.
Okay.
I'm going to start off with this cotton wool. I'll show you what it feels like just on your chest bone there. Can you feel that?
Yes.
Okay. Can you feel it there?
Yes.
And there?
Yes.
Does it feel the same as up there?
Yes.
Can you feel there and there?
Yeah.
Can you feel here and here?
No.
No. Can you feel here and here?
No.
No. Or there and there?
No.
No. I'm going to go up your leg now. If you can tell me when the feeling returns.
Yes.
It's about there. Okay.
Yes.
So the same on both sides.
Yes.
Good. I'm going to do a similar thing, but with this pin, it won't break the skin. I'll show you what it feels like on your chest bone again. Can you feel that?
Yes.
Does it feel sharp?
Yes.
Can you feel that? And
Yes.
that? Does it feel sharp?
Yes.
Here? And here?
Yes.
Here? Or here? Can't feel either side.
No.
Okay. There? Or there?
No.
There? Or there?
No.
Can't feel either side.
No.
Okay. Again, I'm going to run up your leg now. You can tell me when the feeling returns.
Yes.
Okay.
Yes.
Yes, you can feel that there. Good. We're going to do a very similar thing, but with this tuning fork, so it should vibrate. I'll show you what it feels like, just in the middle. Can you feel that?
1 minute remaining.
Yeah. Okay. Can you feel it there?
No.
No. Or there?
No.
No. Can you feel it there? No. Can you feel that?
Yes.
Okay.
Yeah.
If you close your eyes and tell me when it stops.
Yeah.
Okay, that's fine. Again on the other side, just open your eyes. Can you feel that?
No.
Or that?
No.
Can you feel it here?
No.
Can you feel it there? Close your eyes and tell me when it disappears.
No.
Okay, that's fine. What we're going to do next is check how you can sense the position of your toes. So if you keep your eyes open and just have a look at what I'm doing, that's down and that's up. If you
Yeah.
close your eyes and tell me which way it is.
Down. Down. Up.
That's fine. And then on the other side.
Down. Yeah. Down. Up.
That's fine. Thank you very much. To complete my examination, I'd like to assess this patient's upper limbs and cranial nerves.
Okay, thanks. Could you present the case to me, please?
This gentleman had findings consistent with a sensory peripheral neuropathy. In this case, I think this is a complication of his underlying diabetes. On examination, my key findings were that on inspection, he had trophic changes in his toes and nails, and there was some distal hair loss as well. His gait, although was almost normal, there was slight ataxia on tandem walking. He had normal power and tone was also normal. Reflexes were absent globally, including with reinforcement. On sensory testing, his sensation to soft touch and pinprick was reduced bilaterally in a stocking distribution to just above the knees. Vibration sense was also reduced to the patella on both sides, but proprioception was normal. I did note when checking his gait that he had a diabetic insulin pump in his arm. My differentials in this case, I would like to split into metabolic causes, of which diabetes is the top of this list, and that's what I think is the underlying cause here, given this gentleman's insulin pump. Other metabolic causes might be hypothyroidism or nutritional deficiencies such as vitamin B1, B6 or B12. Other causes of a sensory peripheral neuropathy could be split into toxic causes, of which alcohol would be the top of this list. Chemotherapy and medications would also be on this list, such as antibiotics or antivirals. I could further split this list, split the causes of the sensory peripheral neuropathy also into immune-mediated causes. So whether that's part of a wider multi-system disease such as rheumatoid arthritis or GPA, or whether that's part of a neurological condition such as CIDP or an acute cause such as Guillain-Barré syndrome. Rarer causes of a peripheral neuropathy might include genetic causes or infections such as HIV.
Okay, thanks. In this situation, having seen this patient, what further tests would you like to do?
So given that I think the underlying diagnosis is due to his diabetes, I would like to check a lying and standing blood pressure to check for any autonomic instability. I'd also then like to go on to check urinalysis and look in the back of his eyes and do frontoscopy. I'd want to check this gentleman's HbA1c to check his diabetic control and also check his renal function.
Okay, thanks. Let's for a moment assume that he's not diabetic and you're looking for alternative causes for the peripheral neuropathy. How would you go about investigating that?
So I'd want to start off with a basic blood screening. So I would want to do a full blood count, an ESR looking for any inflammatory disorders. I could do a connective tissue disease screen at that point as well. I'd also want to check this gentleman's renal profile, liver function as well. I'd also like to check immunoglobulins and electrophoresis as well. I'd complete my investigations by performing nerve conduction studies. Most peripheral neuropathies are caused by axonal degeneration. However, I could also be looking out for demyelination on the nerve conduction studies, and that might signify other causes such as CIDP or Guillain-Barré.
Okay, thank you very much.
Thank you.
In this case, the candidate was asked to examine the lower limbs. He presented a case of peripheral sensory neuropathy. The examination was fluent, professional and well structured. As is usual in the lower limb neurological examination for PACEs, the candidate checked tone, power, reflexes, coordination and sensation. 4 sensory modalities were checked and gait was also assessed. To begin with, it appeared as if there was little to find, as inspection, tone and power were relatively unremarkable. This is, in fact, very helpful, as early in the examination the normal tone and power already indicate that a significant upper motor neurone lesion is unlikely. Remember, as you work through the examination in order, you should be building up a hypothesis and refining it with each piece of new clinical information. As the candidate checked the reflexes, it became apparent that the knee and ankle jerks were absent. He made sure of this by performing reinforcement manoeuvres. This is a clear clue that peripheral neuropathy may be the underlying diagnosis. The sensory testing was entirely in keeping with this, as a stocking distribution of sensory loss became apparent. You'll have noticed that not all the sensory modalities were affected equally. This is very common in peripheral neuropathy, as different sensations are mediated by different nerve fibre types, and while some diseases will affect all nerves, some have a tendency to target one fibre type or another. In this case, we saw quite significant soft touch, pinprick and vibration loss, although joint position was relatively spared. The next finding of note was a mild abnormality of gait. The patient walks quite well to begin with, so the candidate made the test harder by asking him to walk heel to toe. This revealed a midline gait ataxia. Romberg sign was negative. Even with a negative Romberg test, the mild gait ataxia is likely to be due to the patient's sensory loss. Taken together, the findings of areflexia, stocking sensory loss, and mildly ataxic gait are in keeping with a predominantly sensory peripheral neuropathy. This is a common scenario for the neurology station in PACES, so you should prepare well for it. In a situation such as this, you can expect to be asked about potential causes for the peripheral neuropathy. In this case, we saw the candidate give the most likely diagnosis first, which I think is a very reasonable strategy. The candidate then went on to provide a comprehensive and structured list of alternative causes. It's a really good idea to break down the differential diagnosis into major disease categories. In this case, we heard about metabolic causes, toxic causes, immune-mediated causes, and some other rarer causes. This seems like a good way of organising the vast numbers of potential causes of peripheral neuropathy. Having gone through the potential causes, it would be natural for the examiner to explore how you might investigate the patient. Once again, given the frequency with which this case appears in PACES, it's worth rehearsing an answer to this question. When doing so, it's important to think about simple bedside measures that can be done. This would predominantly be bedside tests for diabetes, such as a BM or urine dipstick. But don't forget, it's possible to directly assess diabetic end organ damage by looking for diabetic retinopathy on fundoscopy. Your investigation plan needs to match the list of possible causes you've been given, but also needs to be rational, which means starting with basic blood tests and moving on to more advanced tests and tests for rarer diseases. As well as blood tests to investigate the cause for the neuropathy, it's worth thinking about nerve conduction studies. This can provide valuable information about the neuropathy and in particular can determine whether the neuropathy is demyelinating or axonal. This is principally important because demyelinating neuropathies are much more likely to be immune-mediated and will need specialist investigation and treatment. In this case, the neuropathy was indeed diabetes associated, so the mainstay of treatment is with tight glycemic control. However, it would also be important to consider other management steps such as regular podiatry for foot care.
Hello there.
Hello, sir.
My name's Gavin Britton. I'm one of the medical doctors. I've been asked today to look at the nerves in your face, if that's all right.
Yes, sir.
Is it Mr. Roberts?
Yes.
Can I ask, have you noticed any change in your sense of smell?
There's been no change.
No change. I'm going to start by having a look at your vision, if that's all right.
Yes.
So what I'd like to do is if you can cover one eye for me, and then start at the top and read down.
Right. TVHXUA.
Is that as far?
That's right, is it?
Okay, if we swap eyes for me.
Yeah.
And again for
TVHXUA. HTY0. VUAXTHAYOUX. TUXTHAGY.
Thank you. I'm going to have a look in the backs of your eyes now. Yeah. So if you could just look over my shoulder at the wall behind me. I'm going to come quite close to you and have a look in your eyes now. Just blink as normal. If you look at the light for me.
Yeah.
Okay, I'm going to have a look at the other side. If you look at the light.
Yeah.
Okay, thank you. I'm going to shine this light in your eyes now. You just keep looking straight ahead for me. It's okay. If you could just look into my eyes for me, and then point to which hand you can see moving.
On the right. Both.
And now.
Both.
Okay, if you could cover one eye for me. I'm going to cover the same eye, and if you can tell me if you can see the red pin.
Yes.
And now.
Yes.
No.
Yes.
No.
Yes.
Okay, I'm just going to bring it in from the side now, if you tell me when you can see it coming into your vision.
Yes.
Okay.
Yes.
Okay, I'm going to swap hands. You stay as you are.
Yes.
Okay.
And yes.
Okay, if you swap eyes for me.
Yes.
No.
Yes. Yes. Yes.
Okay, I'm going to bring it in from the side now.
Yes.
Okay.
Yes.
Okay, I'm going to swap hands.
Yes.
Okay, and again.
Yes.
Brilliant. Okay, thank you. If you can look at the wall behind me, and then look at the tip of my finger. That's okay. What I'd like you to do now is if you can keep your head looking towards me, and look at the tip of my finger, and then follow it. Let me know if you get any abnormalities of your vision. Okay, thank you. What I'd like to do now is if I can test the muscles in your face. So if you can clench your teeth for me, I'm going to see how strong they are. Okay. If you can open your mouth, don't let me close it. That's okay. If you can very gently open your mouth, I'm just going to tap on it. So just slightly smaller for me. That's it. Okay, thank you. And what I'm going to do next is I'm going to check the feeling in your face. So I'm going to use this cotton wool. I'll show you on your chest bone what it's going to feel like.
Yep.
Okay, and I'm going to test it on a couple of areas in your face. I'd just like you to tell me if you can feel it.
Yes. 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 Yes.
Okay. Does it feel the same on both sides?
Both the same, yeah.
And does it feel the same as in the middle?
Same as the chest.
Good. What I'm going to do next is see how your actual muscles in your face move. So if you can lift your eyebrows up for me. Okay, and screw up your eyes really tight. Don't let me open your eyes. Okay, that's okay. If you can purse your lips for me. Don't let me open your mouth. That's okay, and smile. That's okay, thank you. I'm going to test your hearing now. So I'm going to cover one ear and make a noise in the other ear. Just tell me if you can hear the noise.
Yes. Yes.
Good. I'm going to have a look at your mouth now, so if you can open your mouth for me. If you say ah for me.
Ah.
And if you stick your tongue out for me. Okay. Can you waggle your tongue from side to side?
1 minute remaining.
Okay, thank you. And can you push your tongue into the side of your mouth? Don't let me push it over. And again, the other side, don't let me push it in. That's okay. Can you lift your shoulders up for me? Don't let me push them down. And if you turn your head to one side, don't let me pull it over. And turn your head to the other side. Again, don't let me pull it over. That's okay, thank you. So what I'd like you to do next is if you can repeat a couple of phrases for me. So baby hippopotamus.
Baby hippopotamus.
And 42 West Register Street.
42 West Register Street.
Okay, thank you very much. That's everything. To complete my examination, I'd like to check this patient's corneal reflex, potentially their gag reflex, and perform an examination of their upper and lower limbs, as well as checking this patient's gait.
Thank you. Could you present the case to me, please?
My main differential in this case would be that of motor neuron disease. On examination, this patient had an obvious facial weakness, which was predominantly in the lower half of his face. There was obvious wasting and weakness of his tongue with fasciculations. There were also fasciculations in the perioral region and in his neck. Of note, sensation was normal and the jaw jerk reflex was also normal. On general inspection, he was obviously in a wheelchair, and there were wasting and weakness. There was wasting and fasciculations in his hands and forearm. I did detect reduced acuity in his right eye, but this was associated with normal fundoscopy and no relative afferent pupillary defect, so I don't think that's relevant in this case.
Okay, thanks. You mentioned that you'd go on to complete the neurological examination. You mentioned a few things you detected already. What other signs would you be particularly interested in looking for here?
So in this case, I've only detected lower motor features, so I'd be wanting to assess the rest of this gentleman's neurological system, looking for a mixture of upper and lower motor features with an absence of sensory signs, and that would be consistent with motor neuron disease.
Okay. Apart from motor neuron disease, are there any sort of similar conditions we could consider in this sort of case?
So conditions that I'm aware of, examples would be spinal muscular atrophy and Kennedy's disease, which both present primarily with lower motor features, but there's also primary lateral sclerosis, and you'd primarily see upper motor features, which we don't see currently in this case.
Okay. In terms of investigating this gentleman, what sort of tests would you like to do?
So I'd like to perform neurophysiology, and I'd be looking at the peripheral nerves, looking for evidence of denervation and a lack of sensory changes. I could, if we were thinking of the rarer conditions such as Kennedy's disease, follow this up with genetic testing.
Okay. On reflection and thinking about the case that you've seen, were there any clues or signs that might point towards one of these rarer conditions?
So this gentleman did have perioral fasciculations, which I'm aware are a feature of Kennedy's disease.
Okay, good. Let's talk generally about the management of these degenerative motor system disorders. What are the important things to consider?
So the only drug treatment that I'm aware of is riluzole, which is licensed in motor neuron disease and confers an increased prognosis for those patients. There are no other drug treatments available for any other of the similar conditions. After that, management is largely supportive and would consist of approaching the patient with a multidisciplinary team approach. The primary team members would be a consultant neurologist and a nurse specialist, who would, in association with the occupational therapists and physios, work to support the patient at home and establish any of the other circumstances that need to be looked at home. Other team members would be the speech and language therapist, who I would want this patient to assess their swallowing ability in case they need any changes to their diet or fluids, and to consider whether they need non-oral feeding, such as a PEG tube. Lastly, I'd want this patient's respiratory function assessed regularly, as I'm aware that patients with neuromuscular conditions can get respiratory weakness, and they may benefit from non-invasive ventilation, which improves quality of life.
Okay, thank you very much.
Thank you.
This candidate presented a case with features of bulbar dysfunction, but there were other important signs as well. The neurological examination was performed in a confident, fluent and well-structured manner. All the key elements were covered and the pertinent signs were elicited. This patient's predominant problem was weakness, and the candidate did well in the assessment of this. Not only were all the facial movements checked, but key areas such as eye closure and mouth closure were tested against resistance. This revealed the full extent of the weakness. Another aspect that was done well was the inspection of the tongue. Remember to do this with the tongue at rest in the mouth as well as sticking out. This is by far the easiest way to spot fasciculations. There was evidence of weakness, wasting and fasciculations affecting the tongue. The speech had a mildly bulbar quality to it. The patient had facial diplegia, and this predominantly affected the lower facial muscles. Interestingly, there were fasciculations visible in the muscles around the mouth and neck. The candidate remembered to observe more generally, which was useful in this instance. He correctly identified the wasting and fasciculations in the hands. Whenever you detect the combination of weakness, wasting and fasciculations, the first diagnosis that springs to mind is likely to be motor neuron disease, also known as amyotrophic lateral sclerosis or ALS. That's entirely reasonable, as whilst it's a relatively rare condition, it's a very serious disease. Remember, however, the clinical diagnosis of ALS rests on the presence of combined upper motor neuron and lower motor neuron signs. In this instance, we only detected lower motor neuron signs. In particular, there was no evidence of a brisk jaw jerk or a spastic tongue, usually characterised by slow, stiff movements and a strained quality to the voice. Very clearly, in a case such as this, the full neurological examination will be vital, to check for both this combination of upper and lower motor neuron signs, but also the absence of any sensory signs. In terms of history, we would expect patients with ALS to have progressive weakness.
The onset can be bulbar or in the limbs. Lots of patients get cramp, but true sensory symptoms are not a feature of this condition. Remember also to consider changes in behaviour and cognition. A significant proportion of patients with ALS have comorbid frontotemporal dementia. Investigating disorders such as this will often involve requesting peripheral neurophysiology. This can help for a few reasons. It should confirm the presence of denervation, demonstrate the extent of involvement, and assess for any unexpected sensory problems. The diagnosis in this case was actually Kennedy's disease, also known as X-linked spinobulbar muscular atrophy. This is a motor system disorder, but only the lower motor neurons are affected. The perioral fasciculations are almost pathognomonic. It's an X-linked recessive disorder associated with androgen insensitivity. It has a very slow rate of progression, significantly distinguishing it from the sporadic amyotrophic lateral sclerosis.
Hello there, my name's Gavin Britton, I'm one of the medical doctors. I've been asked today to have a look at the nerves in your face, if that's alright. Is it Mrs. Edwards?
It is.
Well, I'd like to start with just a question and then I'm going to go on to look at your eyesight and your vision. Have you noticed any change in your sense of smell?
No.
No. I'm going to have a look at your vision now. So if you can cover one eye up for me, and if you can read from the top down.
TVHXUAHTYOVUAXTHAYOUX. That's as far as I can go.
If you swap eyes for me.
TVH. That's it, I'm afraid.
Okay, thank you. I'm going to have a look in the backs of your eyes now, yeah, so if you could pop your glasses off for me. I'd like you to just look at the wall behind me. I'm going to come slightly close to you and have a look in the backs of your eyes. But you just blink as normal. If you can look at the light for me. That's fine. Have a look in the other eye. And if you look at the light. Okay. So I'm just going to have a look at your eyes now. If you keep looking over my shoulder, I'm just going to shine a light into your eyes. Okay, thank you. So if you can look into my eyes, and then I want you to point to which hand moves.
That one. That one. Both. Both.
Okay, brilliant. And if you cover up one eye for me, I'm going to cover up the same eye, and I'd like you to tell me if you can see the red pin.
Yes. 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 Yes.
Okay, I'm just going to bring it in from the side. Tell me when it comes into your vision. Keep looking into my eye.
Yes.
Okay.
Yes.
Okay, I'm going to swap hands. You stay as you are.
Yes. Yes.
Okay, swap eyes for me. And again in the middle. Tell
Yes. Me. Yes. Yes. Yes.
Okay, and just out to the side. If you tell me when it comes into your vision.
Yes.
Okay.
Yes.
Okay. Just swap eyes.
Yes. Yes.
Brilliant. Okay, thank you. If you can look at the wall behind me, and then look at the tip of my finger. That's fine. And then what I'd like you to do is if you can keep your head looking towards me, and with your eyes if you follow the tip of my finger. Let me know if you get any double vision.
Jumping.
Oh, okay.
Jumping. Jumping. Jumping.
Just up here.
Jumping.
And then down to the bottom.
Jumping.
Okay, thank you.
Sorry.
It's okay, take your time. I'm going to have a look at your face now and how your face muscles are working. So if you can clench your teeth for me, just going to have a feel of the muscles. Okay, thank you, and relax. I'm going to tap this onto your jaw now. What I want you to do is if you just relax your jaw for me. And if you open your mouth, and don't let me close it. Okay, that's fine. It's just a bit of cotton wool. I'll show you what it feels like on your chest bone. Can you feel that?
Yes.
I'm going to touch it on a couple of places in your head, if that's okay. Can you feel that?
Yes. 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 Yes.
Okay. Does it feel the same on both sides?
It does.
And does it feel the same as in the middle?
Yes.
Brilliant. Okay. I'm going to have a look at some other muscles in your face now. So if you could lift your eyebrows up for me. Screw your eyes up really tight and don't let me open them. Okay. Open your eyes for me and smile. And if give us a yeah, that's fine. That's okay. I'm going to have a look at your hearing now. So I'm going to cover one ear and then make a noise in the other ear. If you can tell me if you can hear it.
Yes. Yes.
Okay. I'm going to have a look at your mouth now, if that's all right. If you could pop your mouth open for me. I'll just have a look at the back if you can say ah.
Ah.
That's okay. Can you stick your tongue out
1
for
minute
me
remaining.
and waggle it from side to side? Okay. And if you stick your tongue into the side of your mouth, and don't let me push it. On the other side, again, don't let me push it. That's okay. And then I'm going to have a look at your muscles in your neck now. So if you lift your shoulders up for me, don't let me push them down. If you can turn your head to one side for me, don't let me push it over. And turn your head to the other side. Don't let me push it over. That's fine. And relax for me. And then I want you to repeat a couple of phrases for me. So, baby hippopotamus.
Baby hippopotamus.
And 42 West Register Street.
42 West Register Street.
Okay, thank you very much. That's everything for today. To complete my examination, I'd like to check this patient's corneal reflex, gag reflex, and check and perform an examination of their upper and lower limbs and check this patient's gait.
Thank you. Could you present the case to me, please?
So this lady has evidence of a cerebellar ataxia. My findings on examination were a head tremor, truncal ataxia, nystagmus in all directions of gaze, as well as she complained of a jumpy vision or oscillopsia. She also had scanning dysarthria evident throughout the examination. As an aside, there was evidence of reduced visual acuity in the right eye. However, there wasn't any evidence of a relative afferent pupillary defect and fundoscopy was normal, so I don't think the optic nerve is affected here. My causes for this lady's cerebellar ataxia, I could split these into acute and chronic causes. My acute causes would be primarily vascular, be that hemorrhage or more commonly infarction. However, I'd expect infarction to be unilateral rather than this examination being suggestive of bilateral. Other causes of acute cerebellar syndrome would be cereballitis, so infections such as varicella, or autoimmune causes. And I'd also be looking at demyelination as a cause of acute syndromes like this. My chronic causes would be split into primarily alcohol as the most common cause. There would also be nutritional deficiencies, as well as genetic conditions, surgery and previous trauma, and other infections as well. To investigate this lady, if this was an acute cause, I'd want to do a CT of this lady's head to look for any bleeding or infarction, and if this was a chronic cause, I'd primarily want an MRI of the brain.
Okay, thanks. You've diagnosed a lady with cerebellar ataxia and said you'd want to go on and do a full neuro exam. What signs might you expect to see on limb exam in this case?
So on further examination of this lady, I'd be expecting to see an intention tremor and pass pointing. I'd also be looking for other features of incoordination, such as dystiodocokinesis and heel-shin ataxia. I'd also be looking at a gait, and I'd be looking for a broad-based gait.
Okay. When doing the full neuro exam and assessing the limbs, are there any other signs that might be helpful in working out what's going on with this lady?
So I'd want to be screening for other associated neurological features that might indicate for instance, spinocerebellar syndrome or a peripheral neuropathy in combination with the cerebellar syndrome. So for instance, I'd be looking, in terms of the spinocerebellar features, I'd be looking for upper motor features such as upgoing plantars and increased reflexes. And in terms of, I'd also want to look at the peripheral nerves to look for any evidence of peripheral neuropathy. in combination with the cerebellar features that might be suggestive of, for example, alcohol.
Okay, let's return to the history. What are the key areas you'd want to explore when assessing a patient who presents with cerebellar ataxia?
So primarily I'd want to firstly establish the onset and any progression of the cerebellar ataxia. I'd then want to go on to screen for other associated neurological signs and symptoms that might be suggestive of certain conditions, such as multiple sclerosis. There might be an element of relapsing remitting to this, to her disease process. And I'd want to screen for other signs and symptoms that might be consistent with things like alcohol as well. I'd then want to go on to screen for evidence of systemic disease or nutritional deficiencies, and I'd specifically want to be making sure that I'd ruled out malignancy as a cause in terms of paraneoplastic syndrome. I'd then want to go on to check this patient's relevant medications and previous medications, as well as drugs and alcohol as a cause. Lastly, I'd want to check the patient's family history.
Okay, thanks very much.
Thank you.
This candidate presented a case with signs of cerebellar ataxia on cranial nerve examination. The neurologic examination was performed in a confident, fluent and well-structured manner. All the key elements were covered, and the potentially tricky bits of the exam, such as eye movements and visual fields, were well performed. There were some aspects of this patient assessment I really liked. When fields were assessed, the candidate checked for an obvious field defect and visual neglect before assessing each eye's field in more detail with a red hat pin. Whilst it's possible to check fields with just your fingers, the pin does allow for a more sensitive examination, and the central field areas can be better assessed. You can check for enlarged blind spots with a red pin, but it's not routinely required and is only really relevant when the history and/or other signs suggest raised intracranial pressure. Don't worry about spending a bit of time on these components of the cranial nerve exam. The lower cranial nerves can all be checked very quickly. When performing the neurological examination, it's really important to give clear instructions to the patient, and the candidate did a very good job in this case. In addition, listen carefully to what the patient is telling you during the examination. In this case, the patient complained of a slightly unusual problem. Her vision was jumping during the eye movement testing. Don't just listen to what the patient is saying, listen for how it is said. In this case, you can hear the dysarthria. The signs here were relatively subtle, with nystagmus in all directions of gaze and staccato speech being the most apparent abnormalities. The patient described visual disturbance in the form of oscillopsia. Other useful observations include the presence of head tremor and the presence of truncal ataxia. These findings are extremely useful as they clearly point towards cerebellar pathology. Having identified these cerebellar signs, the good candidate will know what limb signs to be on the lookout for. In a case like this one, we might expect to see intention tremor with dysmetria, dysdiadochokinesia and gait ataxia. Even though you might be able to predict other cerebellar signs, the limb examination is going to be very important. The signs we've seen so far clearly suggest cerebellar disease, but it's useful to know whether other components of the nervous system are implicated. This might give clues to the etiology of the condition. For instance, the combination of cerebellar signs and upper motor neuron signs in just the legs would be clear evidence of lesions disseminated in space and might, in the context of an appropriate history, support a diagnosis of MS. Conversely, the finding of peripheral neuropathy signs, in conjunction with the cerebellar findings, might make you consider toxic causes such as alcohol. One final thought on cerebellar ataxia. The cause is usually evident from the history, and clearly the cadence of onset is critical. Investigations will be guided by the history, but all patients with cerebellar ataxia will require brain imaging. MRI is far superior to CT for looking at this area, but CT has an important role to play in hyperacute presentations when hemorrhage needs to be rapidly excluded.
Hello there. My name's Dr. Maskery. Can I ask your name, please?
Mr. Roberts.
Hi, Mr. Roberts. It's nice to meet you. I'd like to examine your arms today, if that's okay.
Yes.
Are you in any pain at all?
No, sir.
If I cause you any discomfort at any point, please let me know and I'll stop.
Yes.
I'd like to have a look at you to begin with.
Yeah.
Put your hands out like this and turn them over and relax. Okay. Can I get you to put your hands out in front of you and spread your fingers wide? Close your eyes for me. Open your eyes, turn your hands over like this. Close your eyes and keep them there. Open your eyes again, make 2 fists and relax. That's good. You can relax this arm down now. Now I'd like to just ask you to go as floppy as you can, nice and relaxed. And on this side, nice and relaxed. Good. I'd like to see how strong you are now. So bring your arms out to the side. Don't let me push these down. Okay. Push down against me. Thank you. Arms out in front like this. Pull me towards you. Pull me towards you. Back up in front and push away. And push away. Arms out straight like this. Make 2 fists. Bring them back up towards you. Nice and strong. Fingers out straight. Nice and strong. Don't let me push these down. Don't let me push these down. And if you spread your fingers wide, don't let me push this in. Don't let me push this in. Again, don't let me push this in. Don't let me push this in. Turn your hands over. Thumbs up towards the ceiling. Don't let me push this down. And don't let me push this down. And now grip my fingers. That's good. Thank you. And relax your arms. I'd like to check your reflexes now. If I can just get you to relax your hands there. This time, I'd like you to clench your teeth when I say. So I'll say 1, 2, 3, clench, okay? So relax for now. 1, 2, 3, clench. And relax. 1, 2, 3, clench. And relax. 1, 2, 3, clench. Relax. 1, 2, 3, clench. And relax. Just relax this time. 1, 2, 3, clench. Good. 1, 2, 3, clench. And relax. Thank you. Now with this hand, I'd like you to reach forward with one finger. Touch my finger. Now touch your nose. My finger, your nose. Good. And can you do the same on the other side? Thank you. Now with the left hand, I'd like you to hold it out flat. And I'd like you to clap with the right hand, but each time you clap, turn your hand over for me like this. Good. Can you do the same on the other side? That's good. And relax down. I'd like to check the sensation in your arms now. If I can ask you to turn your hands over. Perfect. Does that feel soft there?
Yes.
I'd like to see yes if you can feel it each side. Close your eyes for me.
Yes. Yes.
And does it feel normal?
Yes. 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 Yes.
Good. You can open your eyes now. This time it's a little sharp. If I can just touch it here, can you feel that?
Yes, sir.
Turn your hands over again for me. Just touch it here and
Yes.
here.
Yes.
Does it feel the same on both sides?
Yes. 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 Yes.
And if I just run it down the hand now, does it feel the same all the way?
Yes.
Yeah. And on this side?
Yes.
Good. You can open your eyes. This time you'll feel a vibration. Can you feel that?
Yes.
And can you feel that it stopped?
Yes.
Now, I can just take your hand. Can you feel that vibrating?
Yes.
Keep your eyes closed. Tell me when it stops.
Stop.
Good. And on the other side, can you feel that vibrating?
Yes.
Keep your eyes closed. Tell me when it stops.
Stop.
Good.
1 minute remaining.
Now what I'd like to do is if I can borrow this hand. So if you just look at your finger, this
Yes.
would be up and
Yes.
this would be down.
Yes.
I'd like you to close your eyes for me
Yeah.
and just say up or down.
Down, down, up,
Good. And on the other side.
down, down, up.
Okay, you can relax this arm and open your eyes now. That completes my examination. Thank you very much for your time.
Thank you, sir.
I'd like to complete my assessment by examining the cranial nerves and the lower limbs.
Thank you. Please could you present the case to me?
So there was evidence of symmetrical hypotonia in the upper limbs, and this was accompanied by quite prominent fasciculations, particularly in the triceps muscle distribution bilaterally. On assessment of power was reduced globally throughout the upper limbs, and I was unable to elicit any reflexes. Coordination and sensation are importantly not affected in this patient, and they are completely normal on examination. This therefore suggests that this is a lower motor neuron syndrome, particularly affecting the motor nerves. Now this could affect the anterior horn cells or be affecting the motor nerves themselves. The differential diagnosis here would be one of either anterior horn cell dysfunction, such as motor neuron disease, or affecting the nerve itself, such as multifocal motor neuropathy. However, on general inspection of this patient, I did notice that there was perioral fasciculations present. And in the context of these clinical symptoms and signs, one would have to suspect a type of motor neuron condition called Kennedy's disease. I'd like to investigate this patient by actually taking a full history, looking at the onset of the symptoms and their progression. Also, I'd like to examine his lower limbs and cranial nerves. And I'd like to arrange for nerve conduction studies and EMG, looking for evidence of denervation.
Okay. Thinking about Kennedy's disease, which is your preferred diagnosis, what features in the history might help you differentiate that from other anterior horn cell disorders?
So in sporadic anterior horn cell disorders, for example ALS in motor neuron disease, I'd be expecting that to be a rapidly progressive condition affecting only the motor nerves. Now, in Kennedy's syndrome, which is an X-linked recessive condition, actually taking a history I would expect for a much more chronic and insidious onset of the symptoms. Another key element of the history would be looking at family history, either people with a previous diagnosis of Kennedy's syndrome or unexplained neurological disorders in the past.
Okay. And just turning to the examination again, what key features help differentiate Kennedy's from sporadic ALS?
So on examination of the patient, as with ALS, we would expect to find only the motor nerves affected, but here it's the clear evidence of fasciculations around the mouth that would point us towards Kennedy's syndrome.
Okay. How would you like to manage this patient?
So the management of this patient would depend upon the multidisciplinary team. So regular follow-up with the neurologist looking for symptomatic management, involvement of the occupational therapists and physiotherapists to help maintain function and independence, so assessment of the home, workplace and modes of transportation to ensure that these are appropriate for the patient's condition would be important. Involvement of the speech and language therapists again would help to ensure that the patient's diet is appropriate to help reduce the risk of aspiration in these patients. Neuropsychology can be arranged to help the patient come to terms with these diagnoses as well, and this can often be arranged with the help of the motor neuron disease specialist nurses. Some patients will experience neuromuscular ventilation weakness, and an early morning blood gas could help to identify these patients. In this case, it would be important to make a referral to the respiratory team and to the ventilation specialist nurses as well, as they may need additional support, particularly nocturnally.
Okay, thanks very much. This candidate presented a case with predominantly lower motor neuron signs. The neurological examination was performed in a confident, fluent and well-structured manner. As is customary in the upper limb exam, the candidate inspected in general and then checked tone, power, reflexes, coordination and sensation. All the key elements were covered and the pertinent signs were elicited. The patient's predominant problem was weakness, and the candidate did well in the assessment of this. He remembered to put the muscles into activation first, checking power against gravity, and then testing against resistance. Importantly, the candidate remembered to say he needed to go on and complete a full neurological examination. In this case, and indeed in all other neurological presentations, assessing the nervous system in its entirety is critical. There was evidence of weakness, wasting and fasciculations affecting both arms. The patient was areflexic, sensation was entirely normal. Allowing for the patient's weakness, coordination seemed normal. There were some other important observations out with the limited examination of the upper limbs. The patient's speech had a mildly bulbar quality to it. There was evidence of facial diplegia, and this predominantly affected the lower facial muscles. Interestingly, there were fasciculations visible in the muscles around the mouth and in the neck. This demonstrates the importance of careful general inspection. Whenever you detect the combination of weakness, wasting and fasciculations, the first diagnosis that springs to mind is likely to be motor neuron disease, by which most people mean amyotrophic lateral sclerosis or ALS. That's entirely reasonable, as whilst it's a relatively rare condition, it's a very serious disease. Remember, however, the clinical diagnosis of ALS rests on the presence of combined upper motor neuron and lower motor neuron signs. In this instance, we only detected lower motor neuron signs. In particular, there was no evidence of increased tone or hyperreflexia. In terms of history, we would expect patients with ALS to have progressive weakness. The onset can be bulbar or in the limbs. Lots of patients get cramp, but true sensory symptoms are not a feature of this condition. It's an aggressive disorder generally, with rapid progression over months. Many patients' disease duration is only of a couple of years. The diagnosis in this case was actually Kennedy's disease, also known as X-linked spinobulbar muscular atrophy. This is a motor system disorder, but only the lower motor neurons are affected. It's an X-linked recessive disorder associated with androgen insensitivity. It has a very slow rate of progression, significantly distinguishing it from sporadic amyotrophic lateral sclerosis. In addition, the presence of perioral fasciculations is said to be near pathognomonic for this disorder. Investigating disorders such as this will often involve requesting peripheral neurophysiology. This can be helpful for a few reasons. It should confirm the presence of denervation, demonstrate the extent of involvement, and also assesses for any unexpected sensory problems. Kennedy's disease can be confirmed with clinical genetic testing. The candidate did really well to remember other useful tests, such as checking for neuromuscular ventilatory failure. Whilst there's no effective disease-modifying treatment for Kennedy's, quality of life may well be improved by detecting and then treating ventilatory issues with non-invasive ventilation.
Hello there, my name's Dr. Maskery. Can I ask your name, please?
It's Mr. Flyer.
Hi, Mr. Flyer. It's nice to meet you. I'd like to examine your legs today, if that's okay.
Yeah, that's fine.
Are you in any pain at all at the moment?
Just a little in the ankle.
If I cause you any discomfort at any point, please let me know and I'll stop. I'm just going to have a look at your legs to begin with. Just get you to pop your hand by your side. Okay, I'd like to move your legs now and see how relaxed they can be. So if you just relax your legs for me. Nice and relaxed. Nice and relaxed. Now I'd like to see how strong they are. Can I ask you just to lift this leg straight up off the bed for me? Don't let me push it down. Okay. And this side, can you lift this one up? No. Okay. If I put my hands underneath, can you push down into the bed? And on this side, can you push down into the bed for me?
No.
Okay. Can you bend this knee?
Yes.
Okay. Now, can you pull me towards you? And can you push away? Straighten the leg for me. Straighten the leg. Good. Good. And relax. Are you able to bend this knee?
No, it won't be.
If I lift it for you, are you able to try and straighten it at all?
No, it won't.
Okay. And will it bend towards you?
No.
Thank you. Looking at your ankles now, can you bring this foot up towards you by bending your ankle? Don't let me push it down. Can you bring this one up towards you?
No, I can't. Okay. I can't.
Will this toe move up towards you?
No.
Okay. Will this one move up towards you?
Yes.
Push it down. Good. And now as if you're pressing down on a brake pedal. Good. And can you push down with this ankle?
No.
Okay. Push down now. Thank you. I'd like to check your reflexes now. So again, if you just relax your legs, let me take the weight. Good. And on 3, I'd like you to clench your teeth. So just relax for a moment. 1, 2, 3, clench. Good. And relax. And again, just relax to begin with. And now on 3. 1, 2, 3. Okay. And relax. And on 3. 1, 2, 3. Thank you. And on 3. 1, 2, 3. Just going to run this across the bottom of your foot. Now, with this leg, I'd like you to touch your heel against your knee for me by bending your knee. Run it down the leg. Take it off and pop it back on your knee and run it down again. That's great, thank you very much, and relax. Now I'd like to check the sensation in your legs. I'll start off with this piece of cotton wool. I can just touch it on your neck. Does it feel soft?
Yes.
Just say yes if you can feel it.
Yes. 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 Yes.
Thank you. This will feel a little sharp. Can you feel that there? Just say yes if you can feel it and it feels normal.
Yes. 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 Yes.
I'm just going to run up the foot now. Tell me if it changes at all. You feel the same on the way up?
Yes.
Yep. And on this one. Does it feel the same on the way up?
Yes.
Thank you. You'll feel a vibration with this one. So if I just step there, feel that vibrating. Tell me when it stops.
Stop.
Good. I'd like you to close your eyes this
1
time.
minute remaining.
You feel that vibrating there? Or here?
No.
Okay. What about here? Try that again.
Tiny maybe, but nothing perceptible.
Tell me if it stops. Okay. If I pop this on the hip, you feel that vibrating there?
No.
Okay. On the other side, feel that there?
Yes.
Tell me if it stops.
Yes.
Thank you. I'd like you to just look at your big toe now. I'm going to move it up or down. So down or up. I want you to close your eyes for me and say down or up.
Down. Up. Up.
And on the other side now, keeping your eyes closed.
Down. Up. Down.
That's great. And you can open your eyes now. That completes my examination.
Thank you very much.
So to finish this assessment, I would also like to examine this patient's upper limbs and cranial nerves.
Could you please present your findings to me?
So on general inspection, this patient had evidence of walking aids at the side of the bed and also splints present as well. Looking at his legs, there was evidence of multiple prior surgeries indicated by multiple different scars. There was also evidence of a leg length discrepancy with the left leg being shorter than the right, and it was also underdeveloped as well in terms of wasting of the musculature. On checking of tone, there was hypotonia, but that again was more prominent in the left leg. Power was reduced globally, but notably was absent in the left foot. I was unable to elicit any reflexes, and planters were mute, including checking with reinforcement. Coordination in the right lower limb was still preserved. In general, sensation was preserved, but I did note that vibration was reduced in the right lower limb, and this is difficult to explain. Ideally, I would like to also examine the patient's gait to complete my examination. To further assess the patient, I would like to take a full history, particularly focusing on any evidence of problems in childhood and asking about any childhood vaccinations that the patient might have had. I would also like to examine the patient's upper limb and their cranial nerves as well. Putting this together, his signs and symptoms are indicative of a lower motor neuron syndrome, and given the fact that he has evidence of pes cavus and also underdevelopment of the limb and leg length discrepancy, this would suggest that the problem is long-standing. For example, this could have come from childhood. Thinking about the differential diagnosis here, it's likely one of polio, and given that the scenario suggested that the patient's having progressive weakness, this could indicate the patient is having post-polio syndrome. I'd like to confirm this suspicion by taking a full history and looking for other symptoms associated with this syndrome, such as fatigue, cramps, and weakness. Investigating this patient, well, one would want to exclude any concurrent or alternative pathologies that could be causing these new symptoms if the symptoms have been long-standing previously. This would be in the form of using an MRI scan of the lumbosacral spine and also nerve conduction studies and EMG to confirm.
Okay. Given your favoured diagnosis of post-polio syndrome, how do you think you could explain those sensory abnormalities that you detected?
So it would be correct to think that the sensory abnormalities would not be expected in a post-polio syndrome. Given the number of scars that the patient has and the distribution of other skin changes such as previous healed, what look like venous ulcers, one could expect that this sensory change, which only affected vibration sensation in the right lower limb, could be secondary to something such as trauma.
Okay. So how would you like to manage this patient?
So it'd be important to, first of all, confirm the diagnosis of post-polio syndrome, and then a multidisciplinary team approach to management would be important. This would include regular review with the neurologist, looking for any symptoms which could be helped, such as if the patient's reporting neuropathic pain, then agents such as amitriptyline, pregabalin, gabapentin or duloxetine could be used to help with that symptom. Other members of the MDT would include occupational therapists and physiotherapists. It would be important for regular review and assessment of the patient to help maintain function and independence. So reviews of the home, workplace and modes of transportation would be important as well. Other members of the multidisciplinary team could include neuropsychologists to help the patient come to terms with this diagnosis as well.
Okay, thank you very much. In this station, the candidate presented a case of bilateral but asymmetric lower limb weakness with lower motor neuron signs. The neurological examination was performed in a confident, fluent and well-structured manner. As is customary in the lower limb examination, the candidate inspected in general and then checked tone, power, reflexes, coordination and sensation. In this instance, the candidate did not assess gait, as the patient's weakness was so profound it may not have been safe to do so. The candidate had spotted the patient's extensive orthotic support and specialised footwear. There were quite a lot of other signs to spot on inspection. The patient had several scars on the legs to suggest previous orthopaedic procedures, including evidence of previous external fixation device on the left leg. The patient also had clear evidence of wasting and weakness in the right upper limb. Because of the severe weakness in the left leg, the candidate realised it would not be possible to test heel-shin testing, so didn't even attempt it. The finding of such dramatic weakness, wasting, areflexia and limb shortening is highly suggestive of polio. It was possible to see that the right leg, whilst clearly much stronger than the left, was also affected. In addition to the weakness and areflexia, there was evidence of pes cavus in the right foot. People often equate pes cavus with Charcot-Marie-Tooth disease, but remember, this finding simply reflects a very chronic neuromuscular disease, usually one that started in childhood. You can see pes cavus in polio, but also in conditions such as Friedreich's ataxia. In this patient, with signs of old polio, but a given history of new and progressive weakness, one ought to consider the possibility of post-polio syndrome. This is a relatively poorly understood condition. Patients develop symptoms of progressive weakness in the previously affected areas, but can also get significant issues with pain, cramping, and fatigue. The diagnosis of this syndrome rests entirely on the history. However, as this candidate mentioned, it would be reasonable to investigate further, predominantly to exclude additional pathologies. It would certainly be sensible to consider structural imaging to look for any nerve root pathology, and nerve conduction studies might also be helpful. There is no specific treatment for post-polio syndrome. Previous trials of immunotherapy have failed to demonstrate a significantly beneficial effect. Management is therefore supportive. A carefully planned physical therapy program is usually recommended. However, caution has to be employed as over-exercise of the affected muscle groups has been associated with a worse prognosis. Occupational therapy and orthotics are very important, as evidenced by the specialised limb orthosis that this patient was using.
Hello there, my name's Dr. Maskery. Can I ask your name, please?
Mr. David.
I'd like to examine your arms today, if that's okay.
Yes, no problem.
Are you in any pain at all?
No.
If I cause you any discomfort at any point, please let me know and I'll stop.
I will do.
Thank you. I'd just like to have a look at you to begin with. Okay, can I get you to pop your arms out in front of you, spread your fingers out wide and close your eyes for me? You can open your eyes now, turn your hands over and keep them there, close your eyes. Open your eyes again, make two fists and open them out. That's great, you can relax your arms down now. If I can take this hand, I'd like you to relax as much as possible. And on this side, relax as much as possible. That's good. I'd like to see how strong you are now. Bring your arms out to the side and don't let me push those down. Okay, push my hands down. Arms out in front of you like this. Pull me towards you and push me away. Pull me towards you and push me away. Arms out straight in front of you, make two fists, bring them back up towards you. Don't let me push that down. Don't let me push that down. Fingers straight out in front. Don't let me push those down. Don't let me push those down. Fingers wide apart. Don't let me push it in. 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 Good. Turn your hands over. Thumbs up towards the ceiling. Let me push that down. Don't let me push that down. And now grip my hands and pull towards you. Good. And relax. I'd like to check your reflexes now. So I just want you to stay nice and relaxed. Okay. This time, I'd like you to bite together when I say clench. So I'll say 1, 2, 3, clench. Okay. 1, 2, 3, clench. 1, 2, 3, clench. Good. And relax. 1, 2, 3, clench. 1, 2, 3, clench. And just take this arm nice and relaxed for me. 1, 2, 3, clench. And on this side, nice and relaxed to begin with. Thank you, and relax. With this hand, I'd like you to reach forward with one finger, touch your nose, my finger. Can you try and do that with your eyes closed? Okay, you can open your eyes now. Reach forward again with this finger, touch my finger. Now your nose, my finger, your nose, and try and do it with your eyes closed. Okay, you can open your eyes now. I'd like to check your sensation now. So that should feel soft just there.
Yep.
I'm going to touch it onto your arm. Just say yes if you can feel it.
Yes. Yes.
And if you turn your hands over for me.
Yes. 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 Not so much.
Okay.
Not so much. Yes. Yes.
Okay, thank you. Feel this pin? Should feel sharp.
Yep.
Yeah. And
Yep.
Can you feel it on both sides?
Yep.
Does it feel the same?
Yeah.
Say yes each time you feel it.
Yes. 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 No. Yes. 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 Yes.
Okay. Now if we can turn this hand over, can you feel it there?
There, yeah.
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 And does it change as I move up?
Yeah. Comes sharper. Yeah.
Okay. And on this side, can you feel it there?
Now I can.
And does it change as I move up?
Yes.
What happens?
Comes sharper.
Okay. And relax. This time, can you feel the vibration? And can you tell me when it stops?
No.
Okay. So, I'm going to do this on your hands. Can you feel that vibrating there?
Not really.
Okay. So I'm not looking for the temperature or the pressure, it's
Yeah.
just the vibrations.
No, not really. Not really. No.
Okay.
Think yes there.
Close your eyes, tell me if it stops. Okay, open your eyes again.
1 minute
And
remaining.
here, can you feel that vibrating?
Yeah.
Keep your eyes closed, tell me if it stops.
Stops.
Okay, on the other side now. Just looking at your hand. You feel it there?
Not really.
There.
A bit.
Close your eyes, tell me if it stops.
Can't feel it at all.
Okay. Open your eyes for me. Can you feel it there?
Slightly, yeah.
Close your eyes, tell me if it stops.
It stopped, yeah.
Okay. Now what I'd like to do is if you look at your finger and move it down or up, I want you to close your eyes and say down or up for me.
Okay. Down, up, down.
And on the other side, keep your eyes closed.
Up, down.
Okay, a little bit further down the finger now. So that's up and that's down. Close your eyes. Not sure?
No, no.
Okay, using the whole finger now. So that's up, that's down. Close your eyes.
Up, down, up.
Okay,
down.
and relax. That completes my examination. Ideally, I would like to finish this assessment by examining the cranial nerves and also examining the legs.
Thank you. Please could you present the case to me?
So on general inspection, the patient was in a wheelchair, and on screening of his function, I noticed that he had pseudoathetosis. His tone was normal and symmetrical. On checking of his power, I noticed that this was reduced proximally. On checking his biceps reflex, I was not able to elicit these, but the rest of the reflexes were present with reinforcement. His coordination was impaired, in keeping with a sensory ataxia. On testing of sensation, I noticed that soft touch was intact throughout. However, pinprick was impaired distally in the fingers, and proprioception was also impaired in the fingers as well. Vibration sensation was absent throughout the whole right arm, but was present more proximally on the left-hand side. Putting these things together, this is consistent with a lower motor neuron syndrome. However, given the combination of proximal muscle weakness and asymmetric sensory change, the common causes of a peripheral neuropathy, such as diabetes, alcohol consumption, or hypothyroidism, are much less likely in this scenario. These features are more in keeping with an inflammatory cause of a neuropathy. In the acute setting, in the context of areflexia, you could consider something such as Guillain-Barré syndrome, but if this was a much more chronic presentation, we could consider things such as chronic inflammatory demyelinating polyneuropathies. In terms of investigation, we should start off with routine blood tests such as full blood count, urea electrolytes, liver function tests, and measurement of CRP and ESR. There are further blood tests which should be done in peripheral neuropathies such as HbA1c, thyroid function tests, and checking for things such as vitamin B12 and virology. In clinical suspicion, you could also check for things such as paraneoplastic syndrome with a paraneoplastic screen. Neurophysiological tests such as nerve conduction studies, EMG, can be used to look whether this is an axonal or a demyelinating process, and that can help to guide diagnosis as well. Other tests that can be used is examining the CSF in the form of a lumbar puncture. In processes such as CIDP or GBS, I would expect the protein to be raised, but the cell count to be relatively normal.
Okay, thanks. Let's say this was an acute presentation and you diagnosed Guillain-Barré syndrome. How would you manage this patient on the ward?
So in the acute setting, it would be important to approach the patient in an ABCDE manner and resuscitate them as necessary. The vast majority of patients with GBS can be managed supportively on the ward. However, you would need to monitor their forced vital capacity, or FVC, to look for any involvement of the respiratory muscles. If the FVC was less than 1.5, you would need to consider whether there was evidence of ventilatory failure present. You may require to do an arterial blood gas and discuss with higher levels of care, such as intensive care, for whether or not a ventilator would be required in this patient. In patients who are severe, such as those who are unable to walk, other therapies such as plasma exchange or intravenous immunoglobulin may be required.
Okay, let's look at it from another point of view. Let's say this was a chronic situation and you diagnosed CIDP. How might you go about managing that?
So in the chronic presentation such as CIDP, a multidisciplinary team approach would be required. Regular review from the neurology team would be required to consider whether or not there's any symptomatic therapies such as neuropathic pain agents required, or any disease-modifying therapies such as plasma exchange, IVIG, or steroids and immunosuppression therapies could be required. Other members of the MDT would include physiotherapy, could include occupational therapy, and also the orthotics team as well.
Okay, thank you very much. In this case, the candidate was asked to perform an examination of the upper limbs. This examination was done very well in a systematic way. As is recommended for PACEs, a strict structure was used, and inspection, tone, power, reflexes, coordination and sensation were checked in order. There was an important initial observation in this case. The patient exhibited quite an unusual sign in the form of pseudoathetosis. This is when a patient's hands and fingers develop involuntary writhing type movements with the eyes shut. It provides clear evidence of sensory ataxia. In a case like this, where the scenario has told you there's a problem with hand function, it suggests that loss of sensation may be the main issue. The candidate went on to demonstrate a predominantly proximal pattern of weakness, albeit quite mild. The reflexes were absent or suppressed. Coordination testing revealed ataxic movements, and the candidate demonstrated that this got worse with eyes closed, once again helping to confirm the presence of sensory ataxia. Accordingly, there was a pattern of distal sensory loss, although this was quite asymmetric. These signs support the diagnosis of a mixed motor and sensory neuropathy. However, there are some definite red flags here to suggest that this is not your typical length-dependent neuropathy of the sort seen in diabetes or other common general medical conditions. The red flags here are as follows. Firstly, non-length dependency. This is evident from the pattern of proximal weakness but preserved hand strength. Secondly, there is evidence of marked asymmetry. This is not typically seen in the common neuropathies. Thirdly, there was a prominent sensory ataxia problem. This should always make one think of unusual neuropathies. This combination of atypical features should really bring to mind the idea of immune-mediated neuropathies. This in itself includes a broad range of conditions. The candidate thought about it in terms of acute versus chronic, which is a simple and effective way of splitting things up initially. The commonest acute immune-mediated neuropathy is Guillain-Barré syndrome, whereas the commonest longer-term condition is chronic inflammatory demyelinating polyneuropathy. Whilst detailed knowledge of the treatment of immune-mediated neuropathies is not required, as that would be neurologist-led, you do need to be aware of the overall principles. Having a good working knowledge of ward-based treatment of GBS is critical, particularly the safety aspects. Monitoring respiratory function is especially important, and forced vital capacity is far more useful than peak expiratory flow rate. It's also important to consider venous thromboembolism risk and use low molecular weight heparin where indicated. The diagnosis in this case was in fact Guillain-Barré syndrome. This patient's acute onset was actually some time ago, but there are significant residual symptoms. Although we often consider Guillain-Barré to be an acute illness from which people recover, it's worth bearing in mind that a significant minority are left with long-term residual disability.
Hello there.
Hi.
My name's Dr. Maskery. Can I ask your name, please?
Yeah, John Brazil.
Nice to meet you. I'd like to examine your legs today, if that's okay.
Okay.
Are you in any pain at all at the moment?
No.
Please let me know if I cause you any discomfort, and I'll
Okay.
stop.
Okay.
I'll just have a look at your legs to begin with.
Okay.
Now I'd like to move your legs, so if you
Okay.
stay as relaxed as possible.
Okay.
Nice and relaxed. Nice and relaxed. Now I'd like to see how strong your legs are.
Okay.
Can I ask you just to lift this leg straight up into the air? Don't let me push it down. And this side, don't let me push it down. And push down into the bed. Push down. And push down. Now if I can get you to bend your knees for me. Pull me towards you. And push me away. And on this side, pull me towards you. And push me away. Now by bending your ankle, I want you to bring your foot up towards you. And on this side, just the big toe this time. Just the big toe this time. And push away. And push away. Now I'd like to check your reflexes.
Okay.
So again, as relaxed as possible. As relaxed as possible. Just bending your knee now. And bending your knee. Now I'm going to run this stick along the bottom of your foot.
Okay.
And again. Thank you. Now I'd like you to pop this heel onto this knee. Run it down the leg. Take it off. And back to the knee. And can you do the same on the other side for me? And up and back. That's great. And relax. Now I'd like to check the sensation in your legs.
Okay.
I'm just going to touch this on your chest there. Can you feel that there?
Yeah.
Does it feel soft?
Yeah.
I'd like to say yes each time you feel me touching you.
Okay.
If it feels normal. Okay.
Okay. Yeah. 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 Yeah.
Thank you. Now this will feel a little sharper. Can you feel that there?
Yes.
Does it feel sharp?
Yes.
Just say yes each time you feel it.
Yes. Yes.
Does it feel the same on both sides?
Yeah, it does. Yeah.
And again, yes when you feel it.
Yes. 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 Yes.
Thank you. Now I'll be checking for the sensation of vibration.
Okay.
So it might feel cool, but I'm just feeling the vibrations there.
Yes.
Tell me if it stops.
Yeah.
Thank you very much. So if you close your eyes for me,
Okay.
can you feel it vibrating there?
No.
Or there?
No.
There?
No.
Or there?
Yes.
Tell me if it stops.
Yes.
And on the other side now, feel it there?
No.
There?
No.
There?
No.
Or there?
Yes.
Tell me if it stops.
Yes.
You can open your eyes now. Now just looking at your toe, I'm going to move the joint. I can move it down or
Yeah.
up.
Yeah.
If you close your eyes for me,
Okay.
just say down or up. Now,
Down.
now,
Up.
and now.
Down.
And on the other side now, up now.
No idea.
That's okay. Now,
Down.
now,
Down.
and now.
Up.
I'd like to see you walk now, if that's okay. Yep.
Thank you. Okay.
Okay. Now if I can just ask you to take a few steps in this direction.
One minute remaining.
And turn around for me. And back this way. and just take a seat on the bed.
Okay.
Thank you. And relax back.
Okay. Okay.
Thank you.
Okay. Okay.
That completes my examination. To finish my assessment, I'd also like to examine the upper limbs and the cranial nerves.
Thank you. Could you please present the case to me?
So this patient presented with evidence of a spastic paraparesis. On examination, tone was increased bilaterally with evidence of non-sustained clonus at the ankles. Power was generally reduced, but more so in the proximal distribution. I was able to elicit brisk reflexes bilaterally and upgoing plantars. There was a degree of distal dysfunction in his dorsal columns, as evidenced by decreased vibration and proprioception sensation. I note also that he had quite a marked spastic gait on examination. These features together suggest a myelopathic cause of his spastic paraparesis. The differential diagnosis for this would be broad, and a history looking particularly at the onset of the symptoms would be important. If this has come on quite suddenly, in the context of, for example, back pain or red flags associated with back pain, then you'd need to consider a compressive pathology, such as an intervertebral disc herniation, in which case urgent MRI scanning of the whole spine would be important. If this has come on very suddenly, then a vascular cause, such as a spinal stroke, could also be the cause. However, I would not expect the patient to present with such spasticity in the acute phase. If this is something which has come on over a period of days, then an inflammatory or an infective pathology could be the cause. If it was an inflammatory pathology, the most likely would be multiple sclerosis presenting as a transverse myelitis syndrome. If it was infective, then classically VZV could be the culprit. If this is a condition which has come on over a period of time, then metabolic causes such as vitamin B12 deficiency can also be the cause. Again, in these presentations, one would need to consider infective causes as well, things like HIV, or if the patient has travel history, then things such as HLTV1 infection could also be considered. In the longer term, obviously we need to consider slowly growing tumours. However, neurodegenerative conditions such as primary lateral sclerosis, or in the context of a positive family history, things such as hereditary spastic paraparesis need to be considered. I'd like to investigate these patients essentially with imaging. An MRI of the whole spine is important, and the timing of that is dependent upon how fast these symptoms have come on. So if this is an acute onset, then urgent scanning, ideally on the same day, should be performed.
Okay, thank you. Let's say this patient's symptoms came on very gradually but are progressive. What point in a history would you be particularly interested in?
So as you said, it's important to identify when they first noticed the symptoms and how they've changed since then. Has there been any progression in the symptoms in that time? It's also important to identify whether or not there's any family history of similar symptoms or undiagnosed neurological syndromes in the past. It's also important to identify how these symptoms affect their day-to-day life so that we can start to think about how the multidisciplinary team can help to improve their independence and their function.
In a chronic progressive myelopathy, what would be your investigation strategy? Talk me through that.
So clearly imaging is vitally important in these patients, but wouldn't necessarily need to be urgent given the chronic nature of the symptoms. You'd need to consider whether or not there's any reversible nature, so things such as vitamin B12 and copper levels would need to be measured, as these can be reversed with supplementation. It's also important to consider whether or not there is a family history present, because if positive, genetic screens for things such as hereditary spastic paraparesis can be arranged and the patient can be referred to the genetic counselling team.
Okay, thank you very much. This candidate presented a case with upper motor neurone signs and correctly identified the syndrome as spastic paraparesis. The neurological examination was performed in a confident, fluent and well-structured manner. As usual in the lower limb exam, the candidate inspected in general and then checked tone, power, reflexes, coordination and sensation. All the key elements were covered and the pertinent signs were elicited. By using this standardised approach, the candidate was able to synthesize the signs and come up with an accurate syndromic diagnosis. This combination of signs should be instantly familiar to all of you. The presence of increased tone, brisk reflexes, upgoing planters, weakness and reduced sensation characterize the syndrome of spastic paraparesis due to a myelopathy, i.e. a cord syndrome. Such a patient will present with problems walking, but could also have upper limb symptoms and signs, depending on the level of the lesion. In fact, the upper limb exam findings would be critical in terms of localizing this sort of lesion. And in all neurology cases, the completion of a full neuro exam is critical. Remember, patients with cord syndromes also often have bladder symptoms in the form of urgency and frequency. The likely cause of a cord syndrome is usually made apparent from the history, and the cadence of onset is especially important. In hyperacute presentations, we always think of vascular events. But in that acute setting, remember that patients will not have developed spasticity and can even seem to have hypotonia, sometimes referred to as spinal shock. In situations where the symptoms have come on rapidly, it's important to ask about a history of trauma and pain, as compression is high on the list, but don't forget that cord compression can be a chronic process due to slow-growing tumours or gradually worsening spondylosis. Many acute onset cord syndromes that come to internal medicine are due to transverse myelitis. It's important not to assume that all transverse myelitis is MS related. Other inflammatory conditions and some infections can also present in this way. In rapid onset cases, the critical investigation is an urgent MRI scan of the spine. Things get a bit more tricky when the symptoms come on over a period of weeks or months. In this situation, there is quite a broad differential diagnosis. However, it's safe to say that the MR scan remains amongst the most important of the tests. In many instances of myelopathy, the MRI scan will give a clear indication of the underlying cause. However, it's worth remembering that in a significant minority of cases, the scan will be normal. These scan-negative myelopathies can be challenging. I think it's really important in these sort of situations not to miss easily correctable causes, so testing for vitamin B12 and copper, deficiencies of which can give subacute myelopathies, is very important. In this case, the diagnosis was actually hereditary spastic paraparesis. This diagnosis would normally be made from the history, where one would expect a slowly progressive picture of walking difficulties and other affected family members. The diagnosis can be confirmed with genetic testing, often using next-generation sequencing.
Hello there, my name's Dr. Mastery. Can I ask your name, please?
I'm Fiona.
Hi Fiona, it's nice to meet you. I'd like to examine your arms today, if that's okay.
That's fine.
Thank you. Are you in any pain at all at the moment?
No.
Please let me know if I cause you any discomfort at all, and I'll stop.
Thank you.
If you'd like to rest back to begin with, I'm just going to have a look at you. Okay, and if I can just ask you to take my hand and be as relaxed as you can for me. And on this side, as relaxed as you can for me, please. Okay, now if I can ask you just to pop your arms straight out in front of you like this. Spread your fingers wide and close your eyes for me. Open your eyes again. Turn your hands over and keep your hands there for me. Close your eyes. Open your eyes again. Make two fists. And now release them. Good. And now just relax your hands down again. Close your eyes and count backwards from 10.
9, 8, 7, 6, 5, 4, 3, 2, 1.
Open your eyes again. I'd like to see how strong you are now. So I can ask you to put your arms out by your side like this. Push up against my hands. Good. Push down. Good. Arms in front of you like this. Pull me towards you. Good. And just bring the arm away a little and push. Good. Pull me towards you. Bring the arm away a little and push. Okay. Now bring your arms out in front of you. Make two fists. Just push up against my hand. And up. And down. And down. Fingers out straight. And together. Don't let me push it down. Gently push it down. Fingers apart. Nice and strong. Fingers apart. Turn your hands over. Thumbs up towards the sky. Don't let me push it down. And don't let me push it down. Squeeze my hands. Good. And relax. Now I'd like to check your reflexes. So I'm just going to be tapping on your joints. Just stay nice and relaxed for me. Nice and relaxed. Now, I'd like you to reach out with one hand in front of you like this. Touch my finger. Now touch your nose. Touch my finger and your nose. And can you do the same on the other side, please? And your nose. My finger. Good. Now, holding your left hand flat, I'd like you to tap your hand, and each time you tap, turn your hand over for me like this. And can you do the same on the other side? Good. And relax. Now I'd like to check the sensation. So if I can get you to turn your hands over for me and just relax them down. I'm just going to touch this here. Can you feel that?
Yes.
It feels soft.
Mm-hmm.
Just say yes each time you feel it and it's normal.
Yes. 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 Yes.
This should feel a little sharp. Can you feel that there?
Yeah.
And the same again. Yes each time you feel it and it's normal.
Yes. 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 Yes.
Thank you. This time, just feeling for vibration. So can you feel that there vibrating?
Yes.
And can you tell me when it stops?
Yes.
Okay. Can you feel that vibrating there?
Yes.
Close your eyes for me. Tell me when it stops.
Yeah.
And now on the other hand, can you feel that vibrating?
Mm-hmm.
Can you tell me when it stops?
Yes.
Open your eyes again for me. Now I'd like to just take this hand. I'm just going to be moving your joints. So if that would be up and that would be down. Close your eyes, say where it's up or down now.
Down.
Now.
Up.
Now.
Up.
And on the other side. Now.
Up.
Now.
Down.
Now.
Down.
And relax your arms down. Open your eyes. I'd like to do just a few more things. So on the right hand side to begin with, can I get you to bring your fingers apart like this and then together?
1 minute remaining.
And then as quickly as you can, nice big movements. Okay, keep going, try and match my speed. And can you do the same on the other side for me, starting with the fingers wide apart and then bringing them together? Okay. And with both hands now, I'd like you just to rotate your hands like this, both at the same time. Okay, and relax your hands down. So now I'd like you just to look at my finger and keeping your head still, follow my finger out to the side and to the side and up and down. And now I'd like you to look up at my palm, down at my fist, palm, fist, palm, fist. Thank you. I'd like to complete this examination by also assessing the patient's cranial nerves and lower limbs. In addition, I'd also like to take a lying and standing blood pressure and also assess function in terms of handwriting and things such as doing up buttons.
Thank you. Could you present the case to me, please?
So this patient presented with a Parkinsonian syndrome. This is evidenced by bradykinesia, rigidity and tremor. On assessment, I noted that power was preserved, as was sensation and coordination. I was unable to identify any features consistent with a gaze paresis, which would be suggestive of a progressive supranuclear palsy, and I was unable to identify any features which would be consistent with multisystems atrophy, such as postural or cerebellar symptoms. Ideally, I would have liked to go on to examine the patient further, looking for things such as their ability to write, looking for symptoms such as micrographia, and also asking her to draw Archimedes' spiral. It's important also to assess function in terms of things like doing up buttons, to ensure that they're able to function in their day-to-day life. I believe this lady is most likely to have a diagnosis of idiopathic Parkinson's disease. This is a clinical diagnosis, and therefore there's no specific test required in order to make this diagnosis. It's important to take a thorough history, as this will help to eliminate some of the other differentials. For example, it would be important to ask specifically about any visual hallucinations or any cognitive dysfunction. If this preceded the onset of the Parkinsonian symptoms, then the alternative diagnosis, such as Lewy body disease, would need to be considered. Vascular Parkinsonism is another differential. However, this classically affects the lower limbs and presents with gait failure. I also wouldn't expect that to present with unilateral symptoms, and in this case, the right side was predominantly affected.
Okay, you've talked to me about the motor side of Parkinson's. What would you ask patients about non-motor symptoms of Parkinson's?
So there's a number of non-motor manifestations of Parkinson's disease. One of the earliest signs is anosmia, or the loss of the sense of smell. There's a number of other cognitive effects, which can be seen as well. There are also mood disorders, and a number of patients will present with pain.
Do you know anything about what sort of sleep disorders patients with Parkinson's can get?
So sleep is often affected, whether this is affected by problems such as turning over in bed, or whether they have broken sleep. Some patients will also have REM sleep disorders.
Okay. Let's say you had a patient with signs of early Parkinson's disease and they wanted to start treatment. How might you go about that?
So there's a number of medical therapies which can be used in idiopathic Parkinson's disease. These can start with things such as anticholinergics, also include COMT inhibitors, monoamine oxidase B inhibitors as well, and then dopaminergic therapies such as levodopa or dopamine agonists. They can be delivered in preparations suitable for the patient, whether that's tablets, patches, or dispersible preparations. It's important to consider the side effects of medical treatments when initiating them. Things such as impulsivity and disinhibition can be associated with dopaminergic therapies, and levodopa in particular is associated with on-off phenomenon and also with dose-related dyskinesias, and in these patients it's important to address the timing and the doses of the medications. Managing patients with Parkinson's disease requires a multidisciplinary approach, particularly as the disease progresses. Involvement of the occupational therapists and physiotherapists can help to retain the patient's strength and function and can ensure that the patient has any mobility aids or adaptations to the home or workplace that they need to retain their independence as much as possible. Again, as it progresses, speech and language therapists can be helpful to assess things such as swallow and to advise regarding diet.
Okay, thanks very much. In this case, the candidate was asked to perform an examination of the upper limbs. This was done very well in a systematic way. As is recommended for PACEs, a clear structure was used and inspection, tone, power, reflexes, coordination and sensation were all checked in order. However, extra elements were added based on observations made and signs detected during the examination. This ability to slightly modify one's examination routine is really useful and demonstrates to examiners that you're experienced and able to use clinical reasoning in real time. The candidate had detected the presence of asymmetric upper limb rigidity, and he probably had noticed some hypomimia. Because of this, he took the opportunity to pause and check for the presence of a resting tremor at the outset of the examination. Then, at the end of the traditional upper limb exam routine, he checked for bradykinesia by testing finger snaps and rapid alternating hand movements. In this way, he was able to detect the classic triad of Parkinsonism by demonstrating tremor, rigidity, and bradykinesia. The candidate looked for other features that are important in the assessment of Parkinsonian conditions. Firstly, he checked eye movements. The reason for this is twofold. Primarily, you're looking for evidence of a vertical supranuclear gaze palsy as a sign of PSP, but you're also checking for nystagmus, as any cerebellar signs could be a clue towards the diagnosis of multiple system atrophy. As a final aside, the candidate mentioned checking lying and standing blood pressure, as well as measures of hand function, such as writing, where one might be able to see micrographia. The diagnosis here was probable idiopathic Parkinson's disease, The features that support this include the asymmetric and predominant upper limb tremor, rigidity and bradykinesia. The absence of vertical gaze palsy and cerebellar features help to make PSP and MSA less likely. Having identified the motor signs, the candidate was asked about non-motor features of Parkinson's disease. This is entirely appropriate as it becomes increasingly apparent that these issues are common and debilitating. Early non-motor features of Parkinson's include anosmia, REM sleep behaviour disorder and constipation. These may occur before the motor onset. Later features include cognitive impairment and visual hallucinations. Some features such as pain, autonomic disturbance and mood alteration can occur at any stage of the illness. It's important to inquire about these areas at diagnosis and throughout the follow-up phase. The candidate was then asked to talk through some basic management approaches in Parkinson's disease. This can be broadly split into pharmacologic and non-pharmacologic strategies. The mainstay of drug treatment in Parkinson's is with dopaminergic medication, either levodopa or dopamine agonists. These drugs can be very effective, but it's important to warn patients about the risk of impulse control disorder that can lead to excessive spending or gambling. Examples of non-pharmacologic strategies include physiotherapy, especially helpful for gait problems, and speech therapy, which is useful for the hypophonia that may develop.
Hello there. My name's Dr. Maskery. Can I ask your name, please?
Sheila.
It's nice to meet you. I'd like to examine your arms today, if that's okay.
Okay.
Are you in any pain at all at the moment?
No.
Please let me know if I cause you any discomfort at any point, and I'll stop.
Okay.
I'd like to have a look at you to begin with.
Okay.
Okay, now I'd just like to take your arm. If you stay as relaxed as you can for me, I'm just going to be moving your arm. Okay, hand on this side, nice and relaxed. Okay, now what I'd like you to do is if you just put your arms out like this for me, okay, spread your fingers wide and close your eyes. Open your eyes for me again, turn your hand over and close your eyes for me. Open your eyes, make a fist and relax. That's good. And relax your arms down now. Okay, what I'd like to do now is see how strong your arms are.
Okay.
So if I can ask you to just bring your arm out to the side like this and push up. Good. And push down. Good. And on this side, are you able to bring your arm out?
Not really, no.
Okay. And bring it back towards you?
No.
Okay. On this side, I'd like you to just pull me towards you. Pull me towards you. Good. And push away. Push. Good. And on this side, are you able to bend your arm for me? Okay, and can you push away? Straighten your arm. Thank you. Looking at this hand now, just keep your fingers straight for me. Good, make a fist. Bring this fist up towards you, so bending your wrist. Good. Make a fist again, and push down. Good, spread your fingers out wide. Keep them out wide. Turn your hand over for me. Bring your thumb up like this. Perfect. Just push against mine. Good. And relax. And then grip my fingers. Good. And relax. On this side, are you able to squeeze my fingers?
No.
Okay. And can you straighten your fingers out for me?
No.
Okay. Are you able to move your thumb upwards like this?
No.
Okay, and I'll just relax that down there. Now I'd like to check your reflexes.
Okay.
So I'm just going to be tapping on your joints. If you just stay nice and relaxed for me. Nice and relaxed. Okay. On this side, I'd like you just to reach forward with one finger, touch my finger, and now your nose, my finger, and your nose. That's good, thank you, and relax. Now I'd like to check the sensation. So can you feel that there?
Yes.
Should feel soft. You feel it here and here.
Yes.
Does it feel the same on both sides?
Yes.
Just say yes each time you feel me touching you. Can you feel that there?
Yes.
And there?
Yes.
If you just turn your hand over for me and keep it there. Feel it there?
Yes.
And there?
Yeah.
Here?
No.
You can't feel it there?
No.
Can you feel it there?
Yes.
Here?
Maybe.
Can you feel it more on that side?
Yes.
What about here?
No.
Or here?
Yes.
And here?
Yes.
And here?
Yes.
Thank you. This should feel a little bit sharp just there. Does that feel sharp?
Yes.
Does it feel sharp there? And there?
Yes.
Does it feel the same on both sides?
Yes.
If you turn your hand over for me, just keep it there. There and there.
Yes.
There and there.
Yes.
There and there.
No.
Can you feel it there?
No.
Can you feel it there?
Yes.
Here?
Yes.
Here?
Yes.
Here?
Yes.
And here?
Yes.
Thank you. So this time I'm just checking the vibration. So can you feel that vibrating there?
Yes.
Can you feel that it stopped?
Yes.
Okay, so close your eyes for me. Can you feel it vibrating?
Just a bit.
Okay. Can you feel it vibrating there?
Just a bit.
Okay, close your eyes for me. Tell me if it stops.
1 minute remaining.
Yes.
Okay. And on the other side, keep your eyes closed. Can you feel that vibrating there?
Yes.
Tell me if it stops.
Yes.
Open your eyes for me. Now what I'd like to do is if I just take your hand here, so I'm going to move your fingers now. Can you feel me moving that up and down?
No.
No. Can you feel me moving it up and down here?
No.
What about here? Can you feel me moving that up and down there?
No.
No. If I'm moving the wrist, up or down?
Yeah. Up.
Up or down?
Yes.
Is that down or up?
Yes.
Okay. If we do the same on the other side, just starting at the end again, so that would be down and that would be up.
Okay.
Close your eyes for me now.
Down.
Now.
Up.
Now.
Up.
Perfect. And relax. That completes my assessment. So to finish my assessment, I would also like to examine the cranial nerves, the lower limbs, and assess speech.
Okay, thanks. Could you please present the case to me?
So this patient has evidence of right-sided weakness. On examination of her upper limbs, I noticed that the right side was weaker compared with the left, and there was all but no movement on the right-hand side. There was spasticity at the elbow, but a flaccid weakness in the hand. There was also impairment of sensation distally in the right arm as well. Notably, I could find no problem with power, coordination or sensation in the left arm. On more general examination of this patient, I noticed that she had an ankle-foot orthosis as well, and this could be consistent with a total right-sided hemiparesis. When I was asking some of the more complex questions and giving her more complex instructions, I noticed that there was a hesitancy in her speech and a hesitancy when responding to the verbal commands. When patients present with symptoms such as this, the most important thing to do would be to establish the onset. If that onset was sudden, then a vascular cause, namely a stroke, would be the most likely cause. And I think this is the most likely cause in this situation as well. When patients present with hemiparesis, in the context of stroke, it's important to arrange for an urgent CT scan in order to establish whether or not there's any element of hemorrhage. It's also important to take a history, and in the context of dysphagia, take a collateral history as well, to identify what the onset time of the stroke was and their premorbid state. In patients who present within the thrombolysis window, it's important to escalate this rapidly, as well as performing some baseline tests such as blood glucose in order to exclude stroke mimetics such as hypoglycemia. Those patients who are proceeding to thrombolysis need urgent input from the specialist stroke services.
Okay. You mentioned wanting to assess speech when you finished the examination. Can you talk me through how you do that?
So there's multiple points of speech which should be assessed. So to start with, you can give some simple commands, such as close and open your eyes. If they're able to understand these, you can move to more difficult commands, such as two-step commands, like touch your right ear with your left hand. It's then important also to check for any evidence of an expressive dysphagia, or dysarthria, and you can do that by asking them to repeat phrases such as baby hippopotamus or 42 West Register Street. Speech production can be tested by asking them things such as please tell me what you had for breakfast this morning. Testing naming, for example holding up a pen, asking them to name it, and then also asking what you would use that for, can also look for any difficulties with things such as naming items.
Okay, let's say the patient's had a stroke but present out with the thrombolysis window. How do you manage that situation?
So with any acutely unwell patients, it's important to approach them in an ABCDE manner and resuscitate them as necessary. Once the patient is stabilised, it's important to revisit the history and identify things such as onset and the symptoms which have occurred. It would then be important to do some bedside tests, things such as a baseline blood glucose and also a urine dipstick, looking for mimetics such as hypoglycemia or infection. Other bedside tests would include an ECG, looking for factors such as atrial fibrillation, which increases the risk of stroke. Blood tests should be sent, initially screening for things such as infection, but also looking more specifically with things such as an ESR, thyroid function tests, and also a cholesterol screen as well. These patients should also undergo a CT brain to exclude a hemorrhagic stroke, and all patients should undergo a bedside swallow assessment, and antiplatelets should be delivered as soon as possible after hemorrhage has been excluded and when stroke is suspected. Once the patient has a diagnosis of stroke, they should be managed on a stroke unit ideally. On this unit, there'll be access to the multidisciplinary team, such as speech and language therapists, occupational therapists, and also physiotherapists to help with their rehabilitation.
Okay, thank you very much. In this station, the candidate presented a case of quite severe right upper limb weakness. The neurologic examination was performed in a confident, fluent, and well-structured manner. The examination was technically more difficult to perform because of the patient's marked weakness. The candidate had to slightly modify his technique to take this into account and help provide support for the patient's weak arm. This was done well. Because of the severe weakness in the right arm, the candidate realised it would not be possible to test right-sided finger-nose coordination or look for dysdiadochokinesia. There were quite a lot of other signs to pick up using general observation during the examination. The candidate noticed that the patient had an ankle-foot orthosis on the right side, suggesting weakness there also, and overall indicating a right hemiparesis. In addition, there were instances in the encounter where the patient's speech seemed hesitant, and overall there was a slightly telegrammatic quality to her output. Quite reasonably, the candidate suggested speech assessment in addition to completing the neuro exam. This was a good suggestion on at least two levels. Firstly, there was the suggestion of language problems noted in the assessment, but also secondly, in patients with right hemiparesis, we would expect a left hemisphere brain lesion, so looking for speech and language problems is entirely reasonable, as in most patients, language is left hemisphere lateralized. The candidate mentioned wanting to do a speech assessment, so was understandably asked to expand on this a bit. Speech and language assessment in general terms is fairly complicated and moves away from neurology towards neuropsychology. However, it's reasonable to expect physicians to be able to perform a basic speech assessment for instances such as this. If you were to do this, there are a few stages to consider. It's a good idea to check comprehension first, as a deficit in this would greatly affect the rest of the assessment. We do this by giving the patient initially simple instructions and then progress to more difficult tasks. One way to achieve this is to go through 1, 2, and 3 stage commands. If patients can comprehend well, it's then useful to check repetition, and after that, we'd want to check spontaneous speech and confrontation naming. When listening to the speech, we're on the lookout for a few things. We want to see if the speech is normally articulated, or whether there are problems with dysarthria or phonological errors. In spontaneous speech, we observe the same things, but also want to listen out for any signs of agrammatism. We also want to look for evidence of word retrieval difficulties and hesitancy. Giving patients objects to identify enables us to look for anomia. A more complete language assessment would also include looking at reading and writing, but this moves beyond what is usually performed in acute settings at the bedside. In this case, the likely diagnosis was a stroke. For PACES, you should be able to classify strokes according to vascular territory based on the clinical signs, as the candidate did here. You also need to be familiar with the emergency treatment of stroke, especially thrombolysis indications, and the longer-term management, including the search for underlying causes and secondary prevention measures.
Hi, I'm Dr. Maskery. Can I ask your name, please?
Joe.
Hi, Joe. It's nice to meet you. I'd like to examine your nervous system today. Are you in any pain at all at the moment?
No.
Please let me know if I cause you any discomfort and I'll stop.
Okay.
Can you see me okay at the moment?
Yeah.
Good. Just looking at my finger. If I get you to keep your head still for me, follow my finger out to the side, and to the side, and up, and down, and back to the middle. Any double vision at any point?
No.
Thank you. If you can cover your right eye for me. I'm just checking the corner of your vision, so keep looking straight at me. Tell me when you can see my finger.
Yeah.
And now,
Yeah.
keeping your hand where it is.
Yeah. Yeah.
And covering your other eye instead. Tell me
Yeah.
when.
Yeah.
And again.
Yeah.
And again.
Yeah.
Great. Relax your hand down. I'm going to shine a light into your eye now. Just look into the distance. Now I'd like to look at the back of your eye. If I can get you to look into the distance for me. May I put my hand on your shoulder?
Yeah.
If I can get you to look at this wall for me. That's great, thank you. If I can get you to raise your eyebrows for me and close your eyes tight. Don't let me open them. Open your eyes for me. If I can get you to show me your teeth and blow out your cheeks and open your mouth. Say ah, and stick your tongue out. Good. Now I'd like you to just take my hand, nice and relaxed. And on the other side. Okay, now if you just pop your hands out like this and close your eyes. And open your eyes for me. Relax your hands down. I'd like to see how strong you are now. If you could pop your arms out by your sides and push up and push down. Arms in front of you like this, pull me towards you and push me away. Pull me towards you and push me away. Arms out straight like this, bring your wrists back. Fingers out straight, together. Fingers out wide. Hands over, thumbs up. And grip my fingers. Good, and relax your arms. Now I'm going to be looking at your legs. If you just relax your legs for me. Good. I'd like to see how strong your legs are now. If you lift this one up, gently push it down, and this one, and now push down, push down. Good. Bend your knees for me. Push away, pull me towards you, and pull me towards you. And relax your legs. Bring your foot up towards you, and again, and push down, and push down. Good. Now I'd like to check your reflexes. Just relax your arms down there. Nice and relaxed. Good. Just bending your knee slightly. And again. Relax. Just going to be moving this along the bottom of your foot. Now I'd like you to reach forward with one finger, touch my finger, now your nose, my finger, and the same on the other side. And your nose, my finger. Good. Now I'd like to check the sensation. So if I touch this just here, can you feel that vibrating? And has it stopped?
Yeah.
If I can do that on your hands. So can you feel that vibrating there?
Yeah.
Close your eyes, tell me if it stops.
1 minute remaining.
Keeping your eyes closed on your other hand, can you feel that vibrating there?
Yeah.
Has it stopped?
Yeah.
You feel it there?
Yeah.
Tell me if it stopped.
Yeah.
And there.
Yeah.
And tell me if it stops.
Yeah.
Open your eyes for me. This should feel sharp.
Yeah.
Just going to touch it on each hand. Does it feel sharp there?
Yeah.
And there?
Yeah.
And here?
Yeah.
And here?
Yeah.
And if I move it up the leg, does it change at all?
No.
And on the other side, does it change at all?
No.
Thank you. I'd like to see you walk now.
Okay.
Just stand with your back against the wall. Take a few steps forwards. Turn around. And on the way back, can you walk heel to toe?
Yeah.
And relax back on the bed. Thank you very much. I've completed my assessment.
Thank you. Please could you present the case to me?
So this patient has a normal neurological examination. Given that they've presented with a headache, important negative findings are those which are associated with increased intracranial pressure. None of these were present, so there was no evidence of a sixth nerve palsy, there was no papilledema, and there was normal visual fields. Also, signs associated with a posterior fossa syndrome, such as incoordination, truncal ataxia, or nystagmus, were not present as well.
Okay. The patient presented with migraine as headaches. What features in the history would support a diagnosis of migraine?
So migraines are classically described as unilateral, throbbing in nature, and can be associated with symptoms such as light aversion, phonophobia, and some patients report that they feel nauseated during attacks. There's often an aura preceding the migraine, and patients can describe things such as fortification spectra or scintillating scotomas. They may also note some behaviours or foods, for example, which can trigger these episodes as well. Migraines can last for a few days, but importantly, they do get better, and we're not looking at an insidious onset of a headache with a migraine. They may report that they've had similar episodes in the past as well.
Okay. So you've told me a little bit about the features that support a diagnosis of migraine in the history. What features in the history would you consider to be red flags for something else going on?
So when patients present with a headache, it's important to ask specific things in the history, looking for evidence of red flags. So if we're considering a vascular cause, we need to be asking about the onset of the headache. Was it sudden onset, such as a thunderclap headache, a headache which gets to its maximal intensity within 1 to 2 minutes, could be suggestive of things such as a subarachnoid hemorrhage. If the patient presents acutely unwell, for example confused and pyrexial, we would need to consider things such as meningitis, so assessing them for features such as meningism, photophobia would be important as well. With the more insidious onset of headaches, we need to consider space-occupying lesions. And features we need to ask specifically about in these situations is when the headache is worse. For example, if the headache is early morning, that's more concerning. Also, features such as continued nausea or vomiting, any visual obscurations, or any focal neurological deficit or posterior fossa syndromes also need to be asked about as well.
Okay, let's suppose that his history is suggestive of migraine. As you've shown, the neurological examination was normal. What would you do next?
Well, if this patient had presented with his first headache over the age of 55, then I'd have to be a little bit more suspicious. But given that he's young, there's no red flags in his history, and this is classically migrainous sounding, and in the context of a normal neurological examination, the diagnosis here is most likely to be migraine, and in that case, no further investigations are required at this time. We could start treatment for migraine. So in the acute phase, simple analgesia combined with an antiemetic is often very effective. Analgesia such as paracetamol and non-steroidal anti-inflammatories should be used first line. avoidance of opioids is required, given that these can often exacerbate the headache in the longer term. Some patients may need more therapy. Things such as triptans can be used in the acute phase, and they can be taken orally, intranasally, or subcutaneously. Thinking about more long term, if the patient considers any triggers that might be causing these headaches, or if there are any foods, for example, which might make them increase the frequency of their onset, they can be avoided as well. General lifestyle measures can be advised as well. So these are things such as a healthy lifestyle, having exercise, and also having good sleep hygiene.
Okay, thank you very much. The scenario given in this station was a little different to usual. As opposed to being asked to examine a component of the neurological system, such as cranial nerves, upper limbs or lower limbs, the candidate was asked to perform a basic neuro exam in the context of a patient presenting with migrainous headaches. This situation is entirely reflective of real life. It's commonly the case that you see a patient with a history to suggest migraine and who therefore is expected to have a normal neuro exam. When this situation arises, the aim of the neurological examination is to make sure there are no unexpected abnormal findings or red flag signs. The candidate proceeded to perform a very competent basic neurological examination. It was both swift and comprehensive. There are certain signs that in this instance we specifically want to exclude. Clearly, we want to ensure that there is no obvious field defect, papilledema or sixth nerve palsy, as any of these could suggest raised intracranial pressure. We also need to exclude any upper motor neuron signs in the limbs, so the assessment of tone, power and reflexes is essential. Checking for ataxia is important, and excluding nystagmus, limb ataxia and gait ataxia helps us to do this. As we've seen from this case, it's a straightforward task to do all this by systematically checking the neurological system by examining from top to bottom. You'll notice that several aspects of the traditional neurological examination were omitted. In particular, in a situation like this, the sensory examination can be kept to a minimum. Clearly, when patients specifically complain of altered sensation, a more detailed assessment of that's required. Having excluded red flag examination findings, the candidate was asked to go over aspects of the headache history that could be considered red flag points, but also to outline what features in the assessment would support a diagnosis of migraine. It's important to remember that migraine is in no way a diagnosis of exclusion. There are characteristic history features that allow a positive diagnosis to be made without further recourse to investigation such as structural imaging. It's important to have a working knowledge of migraine management, as it is by far the commonest primary headache syndrome and almost certainly the commonest cause of headache full stop. The treatment of migraine can be thought of in broadly three categories. Firstly, there's the acute treatment. Drugs such as ibuprofen, naproxen or triptans can all be very effective in aborting a migraine attack if taken promptly at onset. Patients with just occasional migraine headache need only have an acute effective treatment plan. The second area of treatment is migraine prophylaxis or prevention. This applies to those patients who have multiple migraines per month or chronic migraine. As we heard from the candidate, there are several treatment options, but propranolol and topiramate are commonly used first-line drugs. In patients with frequent or chronic migraine, a vitally important step is to ensure there's no analgesia overuse, particularly with opioids, as this worsens migraine. The third area is lifestyle modification, with the avoidance of triggers, ensuring good hydration and sleep hygiene, and considering withdrawal or reduction in caffeine intake.
Hello there, I'm Dr. Maskery.
Hello, nice to meet you.
Can I ask your name, please?
Mrs. Janeway.
Hi, Mrs. Janeway. It's nice to meet you.
Nice to meet you.
I'd like to examine your legs today, if that's okay.
Sure.
Are you in any pain at all at the moment?
No.
Please let me know if I cause you any discomfort at any point and I'll stop.
I'll do that.
I'm just going to have a look at you to begin with. I would like to move your legs, if you just stay as relaxed as you can. Nice and relaxed. Now I'd like to see how strong your legs are. Can you just try and lift this leg up for me? Okay. If I lift it, are you able to keep it up there? Okay. And on this side, can you lift this one up? And if I lift it up, can you try and keep it there for me? Okay. And push down into the bed. Push down into the bed. Can you bend this knee? Bring your foot towards you and push away. And on this side, bend your knee. Bring your foot towards you and push away. And relax your legs. Now bring your foot up towards you. Bring your foot up towards you and push down. And push down. And just bring the big toe up and bring the big toe up. Okay. Now I'd like to tap on your joints to check your reflexes. Just relax your leg. What I'd like you to do is if you just clasp your hands together like this, just keep them there to begin with, and I'll say 1, 2, 3, and then I'd like you to pull and then relax, okay? 1, 2, 3, pull. And relax. 1, 2, 3, pull. And relax. 1, 2, 3, pull. One, two, three, pull. You can relax your hands now. Just going to move this on the bottom of your foot. Thank you. Now I'd like you to pop this heel onto this knee. Run it down the leg. Up and away and back to the knee. And down the leg again. And on the other side now. So with this heel onto this knee, run it down the leg, up and back to the knee. Thank you, and relax your legs. Now I'd like to check the sensation in your legs. If I can just touch this here, does that feel soft? Just there, can you feel that there?
Slightly.
Slightly. If I roll these up a little further, can you feel it here?
I think so.
Okay, can you feel it here?
Yeah.
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 Or here?
Yeah.
Okay. This time with a pin.
Mhm.
Can you feel that there?
Mhm.
Does it feel sharp?
Mhm.
Can you feel it there?
Yeah.
And there?
Mhm.
Does it still feel sharp?
Mhm.
Here?
Dull.
Here?
No.
Here?
No.
Here?
No.
Or here?
No. No.
Okay. Can you feel it there?
No.
If I move up the leg, can you tell me when you start to feel it?
There.
Okay. And on the other side?
There.
Thank you. This time I'm just feeling for the vibration there. Can you feel it vibrating? And tell me if it stopped?
Yeah.
Okay. Feel it vibrating?
No. 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 No, just feel the pressure of it.
Okay. And on the other side?
No. 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 No.
Okay. I'd also like you to just look at your toe. If I move it down or up,
1 minute
I want you to
remaining.
close your eyes, say down or up for me now. Now. And just moving the whole toe now.
Down.
Now.
Up.
Now.
Up.
And on the other side now. Now.
Up.
And moving the whole toe now.
Down.
Now.
Down.
And now.
Up.
You can open your eyes now. I'd like to see you walk now, if that's okay. Do you need your crutch to walk?
Not short distance, probably.
Thank you. If I can get you just to walk to the wall and turn around and just walk to the end of the bed for me. I'll be with you.
Okay.
Good. And just walk back to the bed.
Over there?
Yeah. And take a seat back on the bed. Thank you very much.
You're welcome.
To complete my assessment, I would also like to examine the upper limbs and the cranial nerves.
Thank you. Could you please present the case to me?
So this patient has a lower motor neuron syndrome. Specifically, she has a symmetrical, non-length dependent, predominantly sensory motor neuropathy. On examination, she has evidence of reduced tone and she was areflexic. Power was reduced throughout the lower limbs, but particularly she only had anti-gravity movements in hip flexion. I noticed that she was hesitant when checking heel-shin coordination, and sensation was impaired to the mid-shin. On examination of her gait, she was unsteady when standing and walked with a broad-based ataxic gait. I did not perform Romberg's test, as she was clearly unsteady when standing still. I'd expect Romberg's to be positive, given the degree of sensory impairment. Putting these together, as I said, it's a lower motor neuron syndrome, and whilst the features are atypical, you need to consider the common causes of a peripheral neuropathy. These would include diabetes, alcohol excess, vitamin B12 deficiency, and hypothyroidism. However, given that these are quite atypical, and I noticed that she was wearing a steroid bracelet, we'd need to consider an immune-mediated neuropathy. If this was an acute onset, we'd need to consider Guillain-Barré syndrome. However, if this has come on over a more prolonged period of time, it could be due to CIDP. It could also be due to a systemic inflammatory condition, such as Sjogren's, SLE, or rheumatoid.
You've suggested a possible immune-mediated cause. What features in the history might help support that diagnostic contention?
So I'd be looking at the onset of the symptoms and how they've progressed. So if these symptoms have come on acutely, for example, they've noticed weakness in their lower limbs over a period of days, then I'd be considering a diagnosis of Guillain-Barré syndrome. If this had come on over a longer period of time, then something such as chronic inflammatory demyelinating polyneuropathy would need to be considered as well. In inflammatory or immune-mediated neuropathies, we expect to see a waxing and waning of the symptoms. So have they got better and worse over a period of time? Are they static? And if they've changed and got better and worse, then that's more likely to be immune-mediated as well. Also, where did the symptoms start? So if, for example, if the symptoms started on the hands or on the face, that would be unusual unless it's immune-mediated. Similarly, if they have any truncal symptoms as well. In patients who are presenting with predominantly ataxic syndromes, they are again more likely to be immune-mediated in nature. It'd be important to look for any signs or in the history which would be suggestive of systemic inflammatory conditions as well. So is there any features of an inflammatory arthropathy, which would mean that I'd be looking for early morning pain or stiffness in the joints, which gets better as the day goes on. Have they got any skin changes, for example, on photosensitive areas which are exposed to the sun, or any other unexplained rashes that they've been experiencing? There's the general Sicca syndrome as well, so have they got dry eyes and dry mouth, which would be more suggestive of things like Sjogren's syndrome. You'd also need to explore the patient's current and previous medications. Have they received any biologic or chemotherapy agents, which could explain these symptoms as well?
Okay. You wanted to complete the neurological examination, doing the cranial nerves and the upper limbs, which is a good idea. What features would you be particularly on the lookout for?
So I'd be looking again for an immune-mediated features. So checking the upper limbs to see if there's sensory impairment in a glove and stockings distribution. If this wasn't present, then it's likely to be non-length dependent, and this would lend itself to a diagnosis of an inflammatory neuropathy. And again, we don't generally see facial sensory loss in conditions which aren't inflammatory in nature.
Okay, thanks very much. In this station, the candidate presented a case of peripheral neuropathy. The lower limbs were comprehensively and systematically examined, with 4 different modalities of sensation assessed as well as gait. There were quite a few abnormal findings, including motor, sensory and ataxic signs. These abnormalities all have to be synthesized to produce a syndromic diagnosis. Clearly, the combination of sensory loss and areflexia is a familiar combination, meaning peripheral neuropathy. Many neuropathies are mixed, motor and sensory, so adding weakness to this combination shouldn't cause any diagnostic concern. The only slightly atypical motor feature was the pattern of weakness. In typical length-dependent neuropathies, the weakness is distal, but in this case there seemed to be quite significant proximal weakness. This is unusual, and the candidate did well to try and account for this finding. The final abnormal area was the evident ataxia. This can sometimes confuse candidates, and when people see signs, such as gait ataxia, they start to invoke cerebellar pathology. But remember, ataxia is commonly due to a loss of sensation, and in this case it would appear that there was a significant sensory ataxic component to the patient's neuropathy. Given all of the findings, it's quite reasonable to assume this isn't a straightforward, common neuropathy, such as that caused by diabetes, nutritional deficiency, or another metabolic condition. The candidate had noticed this patient's steroid wristband, so suggested an immune-mediated neuropathy. This is a good suggestion, as the findings were consistent with that. Immune-mediated neuropathies are much more likely to be non-length dependent and associated with significant sensory ataxia. They can also be asymmetrical. There are several features in the history that can make one think of an immune-mediated chronic neuropathy. Syndromes such as CIDP may well have waxing and waning courses and sometimes have quite abrupt onsets. A history of symptoms starting in the hands, trunk or face would be clear evidence of non-length dependency, and look out for prominent sensory ataxia, usually described as balance problems worse in the dark or with the eyes closed. The other sort of immune-mediated neuropathies we encounter are those associated with multisystem autoimmune disease. Because of this, it's important to ask questions that look for these types of conditions. One could ask for symptoms of an inflammatory arthropathy, rashes, and a Sika syndrome. Investigation of peripheral neuropathy is an area that you all need to be familiar with, given how often this diagnosis comes up in PACEs. In a case such as this, we would still do the standard neuropathy blood screen, but we're perhaps not really expecting to find a common cause. Neurophysiology is likely to be vital here, as we want to look for evidence of a demyelinating polyneuropathy, or perhaps signs of a dorsal root ganglionopathy. This patient did indeed have an immune-mediated neuropathy, and in this case it was due to underlying Sjogren's. She's on immunosuppression to control this.
Hello there, I'm Dr. Maskery. Can I ask your name, please?
Charlotte.
Hi, it's nice to meet you, Charlotte.
You too.
I'd like to examine your arms today, if that's okay.
Yeah.
Are you in any pain at all at the moment?
No pain at all.
Good. If you think I might cause you any discomfort, just let me know and I'll stop.
Okay.
All right. I'm just going to have a look at you to begin with. If you just lie back and relax.
Yeah.
Okay, what I'd like you to do now is just pop your hands straight out in front of you like this and spread your fingers out wide. And now can you close your eyes and keep your hands there? Open your eyes for me. I want you to put your hands like this. Good, and just hold it there. And if you relax your hands down by your sides. If I can take this hand, I'd like it to be as relaxed as possible. And on this side, nice and relaxed. I'd like to see how strong you are now. I can get you to bring your arms out like this. And push up. And push down. Good. And your arms like this now. Pull me towards you. And push me away. Pull me towards you. And push me away. And now arms out in front of you like this. Bring your wrists back. Push against me. Bring your wrist back. Perfect. And this side. Good. Fingers out flat and together. Keep them up. Keep them up there. Fingers out wide. Stay strong. And now palms up. Thumbs up towards the ceiling. And now grip my hands. Good, and relax. I'd like to check your reflexes now. I'll just get you to rest your hands on your lap. Perfect. Nice and relaxed for me. Now I'd like you to reach forward with one finger, touch my finger, now your nose, my finger, your nose, and using the other hand now. Good. Now with your left hand out flat like this, I want you to clap, but each time you clap, turn your hand over. And can you do the same on the other side? Thank you. Now I'd like to check the sensation in your arms.
Okay.
Will your sleeves roll up a little?
Yeah, sorry.
Thank you. If I can just touch this at the bottom of your neck, can you feel that there? Does it feel soft?
Yeah.
Say yes if you can feel it here.
Yeah.
And here.
Yeah.
Here.
Mhm.
And here.
Yeah.
If you just turn your hands over, can you feel it here?
Yeah.
And here.
Yeah.
Turn your hand over for me. Here.
Yeah.
Here.
Mhm.
Here. And here.
Yeah.
This should feel sharp.
Yeah.
Just turn your hands over for me. And the other one. Perfect. You feel it there?
Yeah.
And there.
Mhm. Mhm. Yeah. Yeah. That's it.
And there.
And there.
And
Yeah.
there. Okay, so this time, I'm just going to be feeling for the vibrations. Can you feel that vibrating there?
Yeah.
And can you tell that it's stopped?
Yeah.
Just lift this hand for me. Can you feel that vibrating there? Close your eyes for me. Tell me if it stops.
Stopped.
And open your eyes. And on the other hand now. You feel that vibrating there? Close your eyes for me. Tell me when it stops.
Stops.
And relax your hand down. Okay, open your eyes. Now just looking at the finger, I'm going to move it up or down.
Okay.
So if you close your eyes and say up or down. Now.
Down.
Now.
Up.
Now.
Down.
And relax that hand down with the other hand now. So the same again, just close your eyes for me. Now.
Down.
Now.
Down.
Now.
Up.
And relax that hand down. Opening your
1
eyes
minute
now.
remaining.
What I want you to do is with this hand first, just spread your fingers wide like this. And then together. And then repeat that movement as fast as you can. Big wide snaps. And can you try on the other side? So initially spreading your finger wide, together, and then big snaps. Okay. And relax your hand down. I'd like to check your vision now. Okay. If you keep your head still, follow it out to the side. And to the side. And up. And down. Okay, now I'm going to place my palm above, my fist below. I'm going to say to look at my fist or look at my palm. Keep your head still for me.
Okay.
So palm, fist, palm, fist. And now palm this side, fist this side. So palm, fist, palm, fist. Thank you. To finish my assessment, I would also like to examine the lower limbs and the cranial nerves.
Thank you. Could you present the case to me, please?
So I noticed that this patient had quite subtle involuntary choreiform movements. These were actually more pronounced with outstretched limbs, but notably they were the same whether her eyes were open or closed. On closer inspection and examination, I couldn't find any changes in her power, reflexes, or sensation. Coordination was intact with finger-nose testing, but there was some difficulty with pronation and supination movements. Testing finger snap movements also showed this as well, but it wasn't classic bradykinesia. Examination otherwise was essentially normal. Examining her eyes showed no difficulty with pursuit or saccadic movements. If we consider the differential diagnosis in this case, you'd need to think about immune-mediated or inflammatory causes, such as Sydenham's or SLE-associated chorea. You'd also need to consider in the acute phase things such as hyperglycemia or vascular causes as well. If the onset was more chronic, then genetic causes, particularly in the context of a positive family history, would also need to be considered, and the most common of these would be Huntington's disease.
Okay, thanks. How do you go about investigating a case like this?
So it'd be important to take a thorough history to help delineate the causes of involuntary movements. So, for example, if this is something which has come on quite acutely, a blood glucose measurement would be important to rule out hyperglycemia. Equally, if it's quite an acute onset and a vascular cause is considered, then urgent imaging of the brain is required. Classically, we'd be thinking about a lesion in the subthalamic nucleus causing hemibolismus in this case. If we were thinking about an immune-mediated cause, then we need to look at other symptoms associated with SLE, for example, asking specifically about dry eyes, dry mouth, have they had any photosensitive rashes, and whether or not they have any joint involvement is also important. If you are considering SLE, then sending blood tests relevant to SLE such as double-stranded DNA, an ANA and an antiphospholipid screen as well should be requested. If we're considering that this could be a genetic cause, then taking a history specifically looking at a more chronic, insidious onset, and also asking about any unexplained neurological syndromes in other family members or previous generations, or indeed any diagnosis of, for example, Huntington's in the family, would be important. If you are considering Huntington's, then genetic testing in the form of a blood test can be arranged. However, often patients will require referral to the clinical genetics team to help with this.
Okay, let's say that the diagnosis of Huntington's disease was confirmed. What sort of important considerations are there thinking about management?
Well, often alongside the genetic testing, patients will also go for an MRI scan. But considering the management of these patients, there's no disease-modifying therapy, unfortunately, in patients with Huntington's disease. The long-term management is therefore a multidisciplinary approach looking at symptom management. A neurologist should be involved to help identify any symptoms that can be managed and can be medically treated. A neuropsychiatrist can help with the mood and cognitive disturbance. Involving the neuropsychologists is also useful, so they can help to tease out which parts of their condition are causing problems with cognition, and also help the patient and family to come to terms with such a diagnosis. With the involuntary movements, often there's an increased basal metabolic rate, and dietitians can be helpful to help ensure that they're having sufficient calorie intake. As the disease progresses, occupational and physiotherapists are important to help build strength and improve their strength and function, and to ensure that any adaptations are made to the home, workplace and modes of transportation to improve their independence.
Okay, thanks very much. In this case, the candidate was asked to perform an examination of the upper limbs. This was done very well in a systematic way. As is recommended for PACES, a clear structure was used, and inspection, tone, power, reflexes, coordination and sensation were checked in order. However, extra elements were added in based on the initial scenario presented to the candidate. He was told that the patient presented with involuntary movements, so spent extra time looking for these and tried different limb positions to maximise the chance of seeing them. In addition, the candidate added tests to look for bradykinesia and eye movement abnormalities, which is a good idea in movement disorder cases. The findings in this case were actually very subtle. On observation, it was possible to see some mild distal upper limb movements. These movements were not rhythmical, like a tremor, and they were not patterned, as one would see in dystonia. They were not stereotyped and repetitive like a tic. Rather, these movements were random and non-patterned, so fit the picture for a mild chorea. In addition, there were subtle problems in voluntary hand and finger movements. It was possible to see that supination, pronation, hand movements, and finger snaps were disorganized and slightly broken down. In this case, the pursuit and saccadic eye movements were okay, and there was no evidence of nystagmus. In any case of chorea, there are a number of potential causes to consider. There are a few absolutely key features in the history to help guide you. It's obviously very important to know if the movements are acute in onset or have come on gradually. Acute onset chorea can be caused by strokes, but classically this produces an asymmetric chorea. Chorea can also be caused by hyperglycemia or polycythemia, so there are some important basic blood tests to do. Post-infectious cases occur in the context of Sydenham's career, although this is now rare in the UK. Some patients with lupus can develop career, although the pathophysiology of this is unclear. Nonetheless, it would be important to inquire about SLE symptoms. One of the most important aspects of the history is asking about other potentially affected family members. Huntington's is the commonest hereditary career. If there is a known family history of HD, then the diagnosis may be more straightforward. However, in many cases, older affected relatives may have been misdiagnosed or not diagnosed at all. It's therefore necessary to ask about a history of any neurodegenerative type illness or psychiatric condition in previous generations. HD is a trinucleotide repeat disorder, so we see the phenomenon of genetic anticipation. This means that subsequent generations are often affected earlier in life or have a more severe phenotype. Huntington's disease is usually managed within a specialist multidisciplinary clinic, as this candidate was able to explain. In addition to this, it's become increasingly common for HD clinics to have close links to research units as the field moves towards clinical trials for potential disease-modifying treatments.
Hello there. My name's Dr. Maskery. Can I ask your name, please?
Mrs. Carter.
Hi, Mrs. Carter. It's nice to meet you. I'd like to examine your arms, if that's okay. Are you in any pain at all at the moment?
No.
Please let me know if I cause you any discomfort, and I'll stop.
Okay.
If you'd like to just lie back, I'm just going to have a look at you to begin with. If I can ask you just to put your arms out in front of you like this, spread your fingers wide, and close your eyes. Open your eyes, turn your hands over like this, and just close your eyes again, keep them there. Open your eyes, make two fists, and relax. If you make two fists, and open them up. Good. And relax your arms down. Now I'd like to see how relaxed you can make your arms, so if you just let me take all the weight nice and floppy. And on this side, nice and relaxed. Good. Now I'd like to see how strong you are, so if I can get you to bring your arms out like this, don't let me push down. Okay, and now push down. Arms out in front of you, pull me towards you, and push away. And on this side, pull me towards you, and push away. Okay, arms out straight like this, two fists, bring them back up towards you. Don't let me push it down, nice and strong. Don't let me push it down, nice and strong. Fingers out straight and together. Don't let me push them down. Don't let me push them down. Fingers out wide. Don't let me push them in. 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 And then if you turn your hands over, thumbs up towards the ceiling like this. Perfect. Now nice and strong, don't let me push it down. Nice and strong, don't let me push it down. Good. And now grip my fingers and pull me towards you. That's great. And relax your arms down. I'd like to check your reflexes now. So if you just relax your arms there, perfect. Just nice and relaxed. Nice and relaxed. Good. And relax. Now I'd like to check your coordination, so if I can get you to reach forward with this hand like this, just one finger, good. Now touch your nose with this hand. Now my finger. Now your nose. Now my finger. Good. And on the other side, reach forward, touch my finger, and now touch your nose. And my finger. And your nose. Good. Now with your left hand out flat like this, if I can get you to clap, but each time turn your hand over. Good. And on the other side now. Good. And relax. I'd like to check your sensation now, so if I can just touch this at the bottom of your neck. Does that feel soft?
Yeah.
You turn your hands over so your palms are up and relax them down. Can you feel that there and there?
Yeah.
Does it feel soft?
Yes.
Just say yes each time you feel it.
Yes. 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 Yes.
Good. This time it should feel sharp. You feel that there? Say yes each time you feel it when it feels normal.
Yeah. Yeah. Yes. Yes.
Just turn your hands over for me.
Yes. 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 Yes.
And it feels the same on both sides.
Mm-hmm.
Good. So this time, this might feel cold, but I'm feeling for the vibration. Can you feel that there?
Yeah.
You feel it vibrating?
Mm-hmm.
Can you feel that it stopped?
Yeah.
Good. So now, if I place this on your hand, can you feel that vibrating there?
Yes.
Close your eyes, tell me if it stops.
Yeah.
Okay, open your eyes again. Place this on your other hand, can you feel that vibrating?
Yes.
Now close your eyes and tell me when it stops.
Yeah.
And finally, just looking at your hand now, and I move it up or down, I'd like you to say, close your eyes and say up or down. So now,
Up.
now,
Down.
now.
Up.
Good. And relax that hand down. And on the other side now, keeping your eyes closed. Now,
Down.
now,
Down.
and now.
Up.
1 minute
Okay, and
remaining.
relax your arms down. Thank you very much. That completes my examination.
Thank you.
I'd like to complete my assessment by also examining the cranial nerves and the lower limbs.
Thank you. Could you present the case to me, please?
So, on general inspection, there was evidence of a left-sided partial ptosis. Tone was normal on examination, and power was reduced proximally. Reflexes were initially looking brisk, however, on examining for a Hoffman's reflex and checking for finger jerks, I can conclude that there's no evidence of pathologically brisk reflexes. Coordination and sensation were both intact. When we consider patients presenting with weakness, but in the context of normal sensation and normal reflexes, we can localise the pathology to either the neuromuscular junction, in terms of myasthenia gravis perhaps, or to the muscles themselves, for example a myopathy. We can differentiate between these two broad categories with neurophysiological tests. In patients with neuromuscular junction conditions, I'd expect repetitive stimulation to show a decrement in the action potentials associated with stimulation. Actually, in patients who present with myopathy, I'd expect to find characteristic changes on the EMG. We can also help to differentiate between these two with antibodies. For example, acetylcholine receptor antibodies I'd expect to be positive in patients with myasthenia gravis.
Okay. What clinical tests could you do at the bedside to help differentiate between these two possibilities?
So there's further examination findings that I could look for to help conclude of a diagnosis of myasthenia gravis. So for example, if I examine the eyes, I'd be looking for ptosis, but fatigable ptosis, so ptosis which gets worse after looking up for a prolonged period of time. In myasthenia as well, you can get a complex ophthalmoplegia, so it's restricted eye movements, but without necessarily respecting any of the particular cranial nerves. The limbs as well can show fatigable weakness, so for example, I could check shoulder abduction strength, then ask her to exercise this particular muscle group, and then I would expect it to be weaker the second time I check this strength. There are some other clinical tests that can be performed. For example, the use of an ice bag carefully placed on the ptosis could provide some resolution of the symptoms in patients with myasthenia.
Okay. What points in the history would be helpful in concluding this is myasthenia?
So it would be important to take a thorough history in the patients presenting with these symptoms. In particular, we should look at the onset of the symptoms and the progression and the amount of time it has taken to reach their current symptoms. Other symptoms that should be specifically inquired about would include things such as the symptoms getting worse towards the end of the day, which I would expect in patients with myasthenia, or after a period of sustained exercise getting worse as well. It'd be very important to ask about particular features. So do they notice diplopia? Do they notice any change in their voice or in their swallowing?
Okay. In newly diagnosed myasthenia, what are some sort of important initial steps to take?
So in patients who are presenting with a myasthenia crisis, so for example they presented acutely, it would be important to approach the patient in an ABCDE manner and resuscitate them as necessary. With monitoring of forced vital capacity, I would want to discuss this patient with my senior colleagues early and also with other colleagues in intensive care to see whether or not they need any ventilatory support. In patients who present more subacutely, it would be important to make the diagnosis by way of history, examination, neurophysiological studies, and also by testing for antibodies. Once the diagnosis has been made, it would be important to arrange for a CT chest to look for any evidence of a thymoma, which, if present, might need to be resected. Treatments for this would include medical treatments, so for example pyridostigmine can be used to help with the symptoms, however would not change the natural history of the condition. Immunosuppressive therapies such as steroids can be used to help dampen down the immune system, and then titration of steroid-sparing agents can be used as well.
Okay, thank you. This candidate was asked to examine the upper limbs in a patient who presented with difficulty in dressing. The neurological examination was performed in a confident, fluent and well-structured manner. As is customary in the upper limb exam, the candidate inspected in general and then checked tone, power, reflexes, coordination and sensation. All the key elements were covered and the pertinent signs were listed. The main finding appeared to be weakness, and the candidate did well in the assessment of this. He remembered to put the muscles into activation first, checking power against gravity and then testing against resistance. Other aspects of the examination were normal, which is a really important point and greatly helps in the differential diagnosis. The candidate clearly felt that the reflexes might have been initially brisk, so sensibly checked for pathological reflexes by testing for finger jerks and Hoffman's sign. The fact that tone was not increased and the reflexes were not brisk means that this weakness is unlikely to be due to an upper motor neuron lesion. The fact that the reflexes were normal rather than depressed or absent means that the weakness is unlikely to be neurogenic. So this leaves us with only a couple of options. The weakness could be either myopathic or due to a neuromuscular junction disorder. Both of these problems tend to result in proximal and symmetrical weakness, so the pattern in itself won't help us differentiate these disorders. So what other signs can we use? Well, looking for eye involvement is crucial, as neuromuscular disorders, such as myasthenia, characteristically involve the eyes, although it is less common in the Lambert-Eaton myasthenic syndrome. If you can demonstrate fatigable ptosis and or oculoparesis, then myasthenia is highly likely. In this case, the candidate noted on observation that there was a left-sided partial ptosis, and this is a reasonable clue to the fact that this patient does indeed have myasthenia gravis. Another useful clinical sign is the demonstration of fatigable proximal upper limb weakness. This is done by asking the patient to repeatedly abduct their arm at the shoulder and then comparing the strength there with the opposite non-exercised side. Investigating myasthenia is generally pretty straightforward. The majority of patients will be seropositive, so the first-line investigation is acetylcholine receptor antibodies. In patients who are antibody negative, neurophysiology can be helpful. Repetitive stimulation or single-fiber EMG can demonstrate characteristic changes in support of a neuromuscular junction disorder. Having confirmed a new diagnosis of myasthenia gravis, there are several important next steps. Firstly, there are some decisions to make about treatment. This will be guided by the severity of the presentation. In acute cases, sometimes referred to as myasthenic crises, inpatient care, intensive monitoring and treatment with IVIG or plasma exchange may be required. At the other end of the spectrum, there are some very mildly affected patients who only need pyridostigmine. In generalized myasthenia, however, the majority of patients will need immunosuppression. In all patients diagnosed with myasthenia, we get a CT thorax to check for the presence of a thymoma.
Hello there, my name's Dr. Maskery. Can I ask your name, please?
Mr. Smith.
Hi, Mr. Smith. It's nice to meet you. I'd like to examine your legs today, if that's okay.
Yep.
Are you in any pain at all at the moment?
No.
If I cause you any discomfort at any point, please let me know and I'll stop.
Okay.
Thank you very much. I'm going to have a look at your legs to begin with. Now I'd like to see how you move your legs. So if you just relax them completely. Nice and relaxed. Nice and relaxed. Let me take the weight. Nice and relaxed. Relax there. Nice and relaxed. It's nice and flappy. Good. Good. I'd like to see how strong your legs are now. Can I get you to keep this leg still? Lift this one straight up off the bed for me. And don't let me push it down. Okay. And this one straight up off the bed for me. Don't let me push it down. Okay. Now push down into the bed. Push down into the bed. Okay. Can you bend your knees for me? Good. Pull towards you. And push away. Okay. Pull towards you. And push away. Good. And relax your legs down. Now I'd like you to bring this foot up towards you. Don't let me push that down. Don't let me push that down. Just the big toe up towards you. Just the big toe up towards you. And now push down like a pedal. And push down. Good. And relax. Now I'd like to check your reflexes. So again, just let me take the weight of your leg. Nice and relaxed. Relax your leg there. Perfect. And what I'd like you to do is put your hands together like this for me. You can relax to begin with, but when I say pull, I want to go 1, 2, 3, pull and pull apart, okay? So just relax them to begin with. So 1, 2, 3, pull. Good, and relax. And just relax the first time. And now 1, 2, 3, pull and relax. So put your hands together but relax for me for the first one. And now 1, 2, 3, pull. Relax your leg. Let's bend this one slightly. Good. Relax the first time. 1, 2, 3, pull. And relax. You can relax your arms now. Just going to run this along the bottom of your foot. Okay. Now I'd like you to put this heel onto this knee for me. Okay. Run it down the leg and up and back on here. Okay. Now put this heel back onto this knee. Run it down the leg. Take it off and go back to the knee. And down again. Good. And relax your legs. Now I'd like to check the sensation in your legs. If I can just touch this on the bottom of your neck. Does that feel soft?
Yep.
So if I touch it here and here, can you feel that?
A little.
And does it feel the same on both sides?
Yeah.
I want you to say yes each time you feel it, okay?
Yes. Yes. Yeah. 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 Yeah.
Okay. This time it's a little bit sharp. Can you feel that there?
Yep.
Yeah? So if I press it here and here, can you feel that? Does it feel the same on both sides?
Yeah.
So just say yes each time you feel it.
Yeah. 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 Yeah.
Yep. This time it's vibration. So if I just pop that there, can you feel it?
Yep.
And can you feel that it stopped?
Yep.
Yeah? Okay. So if I touch that here, can you feel it?
Hardly.
Okay. What about here?
A little bit more.
A little bit more. What about here?
No.
No? Here?
A little more.
A little bit more. If you close your eyes, could you tell me if it stopped?
1 minute remaining.
Yeah.
Yeah? Okay. Open your eyes again. So now, can you feel it here?
Yeah.
You can. Close your eyes, tell me if it stops.
Yeah.
Yeah? Okay, you can open your eyes now. Now, if you open your eyes and just look at your big toe, I'm going to move it down or up, all right? I'm going to get you to say whether it's down or up. So if you close your eyes and tell me where it's moving now.
Up.
And now?
Not sure.
Not sure, that's okay. Now look at the whole toe, so down or up. Close your eyes for me. Now.
Down.
Now.
Up.
Now.
Up.
So starting off with the toe again. So now.
Down.
And now.
Down.
Okay, and with the whole toe. So now.
Not sure.
Okay. Now if I move your foot, so keep your eyes closed now.
Up.
Now.
Down.
And now.
Up.
Thank you. That completes my examination. You can open your eyes now. So to complete my assessment, I would also like to examine the upper limbs and the cranial nerves.
Thank you. Could you present the case to me, please?
So this young gentleman presented in a wheelchair. On an examination of his speech, I noticed that he was dysarthric. Looking at his legs, there was evidence of wasting of the muscles. Particularly, there was guttering of the small muscles in his feet. On examination of his tone, this was normal. Power was generally reduced throughout the lower limbs. I was unable to elicit any reflexes, but notably his plantar reflex was upgoing bilaterally. It was evident that his coordination was grossly impaired bilaterally, and on testing of his sensation, soft touch and pinprick were both normal. However, there was impairment of vibration to his knees and joint position sense to his ankles. Putting these things together, the main feature here is ataxia, but there's a mixture of both central features and peripheral features. So for example, he has evidence of cerebellar ataxia in terms of his dysarthric speech, but also sensory ataxia in terms of his incoordination of his legs, as demonstrated by the fact that his peripheral joint position sense is severely impaired. There's also a mixture of upper and lower motor neuron syndrome signs. So the upper syndrome signs would be the fact that he has upgoing plantars, but there's lower signs as well in the fact that he's areflexic. In the context of a young gentleman, these symptoms and signs would be most in keeping with one of a genetic ataxia and would be entirely compatible with the diagnosis of Friedreich's ataxia.
Okay, how would you confirm the diagnosis of Friedreich's?
So it would be important to rule out any treatable causes of these symptoms and signs. For example, we should send blood tests looking for vitamin B12 and vitamin E, which could present in a very similar way, and with replacement could alter his signs. We should also exclude compressive pathologies, for example, and we should look for structural imaging in the form of MR of his brain and spinal cord to rule these out. Other tests could be neurophysiology, so nerve conduction studies and EMG, trying to explain the reason for his symptoms. Ultimately, the diagnosis would be made with genetic testing.
Okay. What do you know about the management of Friedreich's ataxia?
So a very important cause of early mortality in patients with Friedreich's ataxia is associated with arrhythmias and cardiomyopathies. So they require regular echoes and also ECGs. If patients are symptomatic in terms of palpitations, then it's important to also use ambulatory ECGs to look for any exercise-provoked arrhythmias. If there's any features of these, then they should be referred to the cardiologist for further management, which may include implantable devices. The overall management of patients with Friedreich's is one of a multidisciplinary team approach, so regular follow-up from the neurology team, and also involvement of the physiotherapists and occupational therapists, with assessments of the patient's home, workplace and mode of transportation to ensure that these are appropriate. The orthotics team can help with any devices that the patient requires as well, and the speech and language therapists can also be an important role in these patients. The patient may also require input from the genetics counselling team as well.
Okay. Tell me a little bit about what you know of the genetics regarding Friedreich's.
So Friedreich's is due to a trinucleotide repeat disorder. It's autosomally recessive inheritance, and it's due to a problem with the frataxin gene.
Okay, thanks very much. In this station, the candidate presented an examination of the lower limbs. The neurological examination was performed in a confident, fluent and well-structured manner. As is customary in lower limb examination, the candidate inspected in general and then checked tone, power, reflexes, coordination and sensation. In this instance, the candidate did not assess gait, as the patient was a wheelchair user and couldn't safely walk unaided. There were quite a lot of other signs to try and put together here. Overall, I think it was correct to categorise this broadly as an ataxic syndrome, as the candidate did. When that happens, we usually suggest that you try to work out whether the ataxia is cerebellar or sensory in nature. However, Here we had clinical signs to suggest that both the cerebellar and sensory systems were involved. It's worth noting that the ataxic movements demonstrated on this lower limb examination don't help you to reach this conclusion, it's the other signs. In this case, cerebellar dysarthria and significant joint position and vibration sensory loss. In addition to these ataxic signs, there were other clues to piece together. The patient had clear upper motor neuron signs with upgoing plantars bilaterally, but also clear lower motor neuron involvement with deep tendon areflexia. So putting all this together, we can conclude that this patient has involvement of the cerebellum, spinal cord, and peripheral nerves. That means to fully investigate a patient with this combination of signs, one would have to get an MRI of the brain and spinal cord, plus doing peripheral neurophysiology. As is usually the case in neurology, the diagnosis rests on features in the history. These signs could actually be caused by quite a few different disorders, most of which can be differentiated by the cadence of onset and progression. The candidate acknowledged this, but did offer a favoured diagnosis of Friedreich's ataxia. This was very reasonable, given all the features seen here, which are entirely typical of that condition. Friedreich's is the commonest of the genetic ataxias. The diagnosis can be confirmed by genetic testing. It's standard practice to get structural imaging of the brain and spinal cord, mostly to rule out unexpected or additional pathologies. Similarly, it would be appropriate to check vitamin B12 and vitamin E, as deficiencies of these substances could also produce some of these clinical signs. There are several important aspects to the management of Friedreich's ataxia. Due to the complex nature of the disorder, patients are best managed in a multidisciplinary setting. One of the most important aspects is cardiac monitoring. Cardiomyopathy and arrhythmias are a common cause of mortality in Friedreich's, so regular monitoring with echocardiograms and ECGs is required. The involvement of a cardiologist is usually also needed. Patients can develop impaired glucose tolerance, so that too needs monitoring, and when indicated, treating. In the absence of a disease-modifying treatment, supportive care is really important. Physiotherapy, occupational therapy, orthotics, and speech therapy are all important. This multidisciplinary approach is a common theme in the management of many chronic and complex neurological disorders, so it's worth working out how you talk through this in the event of it coming up in your exam.
Hello there.
Hi.
My name's Dr. Maskery. Can I ask your name, please?
Yes, Mrs. Martin.
I'd like to examine the nerves of your head and neck today, if that's okay. I'll explain each point as we go along. Are you in any pain at all at the moment?
No.
Please let me know if I cause you any discomfort, and I'll stop.
Will do.
To start off, have you noticed any problems with your sense of smell?
No.
Thank you. I'd like you to check your vision at the moment. Do you normally wear glasses?
No.
Okay. I'm just going to stand up and hold this chart. So with both eyes to begin with, can I get you just to read down the chart as far as you can?
T V H X U A H T Y O B U A X T H A Y O U X Y U X T H A O V X O A T V H U Y.
Great. And now if you cover your right eye, using your left eye, can you still read that bottom line?
Yeah. X O A T V H U Y.
And now with the other eye?
X O A T V H U Y.
Great. Now I'd like to check the corner of your vision. So just with both eyes looking straight at me, I'm just going to move my hands in the corner of your vision, looking straight at me, point to the hand that moves.
That one. That one. That one. That one. Both of them. That one. That one. Both of them.
Okay. Now if you cover your right eye for me and look directly at me, I'm going to move this pin just into the corner of your vision. Tell me when you can see it.
Yeah. Yeah.
Okay, keep your hand where it is.
Yeah. Yeah.
Good. Now change eyes. And again, tell me when you can see it.
Yeah. Yeah.
Keep your hand where it is.
Yeah. Yeah.
Thank you. And relax your hands. Now I'd like to shine a light in your eyes. If you just look behind me. Now, if I could ask you just to pick a point on the wall, I'm going to move my finger just in front of your vision. And if you'd look at my hand now. Thank you. I'd like to have a look at the back of your eye now. Again, I'm going to ask you just to look at the wall. If I come into your vision, just keep looking at the wall, okay? I'd need to come quite close to you for this. Do you mind if I put my hand on your shoulder?
No, it's fine.
Thank you. So just looking straight at the wall. Okay. And on the other side now, again, looking at the wall. Thank you. Now I'd like to see the way that your eyes move. So if you look at my finger, keep your head still, follow it out to the side and tell me if you get any double vision.
No. 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 No.
Just looking down and up.
Yeah, a bit.
Get some double vision there. And just keep looking up for me. Just keep looking up. And now back down. And just look straight at me. Now, I'd like to